Good morning, everyone, and greetings, and a huge welcome from Médecins Sans Frontières, Doctors Without Borders, and the National Tuberculosis Control Centre in Nepal. My name is Helen O'Neill, and I'm the Strategic Advisor to MSF South Asia, and I'm leading and sponsoring the day, and I'll be the MC for the day as well. Today we convene amidst an urgent call for humanitarian action. Our objective is to cultivate a collaborative environment, bringing together scientists, public health organizations, infectious diseases specialists, and academics to foster a robust platform for sharing knowledge, expertise, and experiences. We are very pleased that this year's MSF South Asia TB Day is co-hosted alongside Nepal's National Tuberculosis Control Centre, marking a significant stride towards establishing a comprehensive arena for research and medical innovation in the tuberculosis space. While we gather in person, we're also extending our reach through live streaming, connecting with a global audience, including MSF affiliates and beyond. The partnership between these institutions aims to unite researchers, practitioners, academics, and seasoned scientists with a shared commitment to enhancing the continuum of care for tuberculosis. Our focus remains steadfastly patient-centered. Today we have a rich lineup of interactive sessions spanning several hours. We're privileged to hear from both public health professionals and researchers from across the globe. For our online viewers, a user-friendly guide is available. Before we proceed, let's quickly review the house rules. I kindly ask everyone to adhere to the schedule, keep cell phones on silent during sessions, and maintain respectful attention to the presentations and discussions. Online participants are encouraged to pose their questions via the chat box below the live streaming window on our website. Additionally, English auto-generated captions are accessible by clicking the CC option on your screen. Whether you're joining us in person or virtually, we invite you to share our live stream and engage with us on social media using the hashtag MSF TB Day. Questions for speakers will be addressed following each session, so please stay tuned. We also request all attendees to review and complete the consent form available at the registration desk. Thank you very much for being part of the MSF South Asia and NTCC TB Day 2024 as we embark on a day filled with enlightening discussions and the pursuit of excellence in TB care. Together, we can create meaningful change. And now it is my great pleasure to say that we have a very honored guest here. So I would like to invite Dr. Roshan Pokhrel, who's the Health Secretary of Nepal, to join me on stage. Thank you. And Dr. Prajwal and Dr. Farhat. They will conduct a lamp lighting ceremony. Sorry. Please, Dr. Prajwal is the Director of NTCC Nepal, and Dr. Farhat is the Director of MSF South Asia. Thank you. So now we will start officially inaugurating the program for the day, and our three special guests will perform the lamp lighting ceremony. Sorry. Thank you very much. Thank you. Dr. Farhat is now the Executive Director of MSF South Asia, and she's going to make some opening remarks.
Good morning, everybody. Very early morning. Very delighted to be here. And actually, after 20 years, this is not the first time we are in Nepal. As Médecins Sans Frontières, we have been on and off in Nepal as long as 20 years. So, but for now, a very good reason to be here today. Many of you have been asking me bilaterally, why Nepal? And why do we do it here? Maybe to start with, why TB Day in the first place? So, this is the third edition of TB Day. But this would have not been possible without the support of Ministry of Health and Population and National Tuberculosis Control Center. So we are here, a big thanks to them for that. And why Nepal? We as MSF South Asia have been trying to create a space for dialogue, learning from lived experiences, a collaborative space to ignite change in the area of TB. I'm talking to a group of people who know what TB is and how big is it a problem in South Asia and Southeast Asia. So I'm not going to give you any statistics to tell you how grave the issue is and why do we need to come together to find solutions and fast track the goal we have put for ourselves. Nepal has put a goal for itself for elimination of TB by 2035, and we hope today is a day of collaborations which starts a new journey of further fast-tracking the conversations that are happening in the civil society, with the policymakers, with the frontline clinicians, and really getting all the aspects of TB together and making sure that all the gaps that are there, all the opportunities are there, that they are taken care of. As I told you, this is the third edition of TB Days, and we chose Nepal for multiple reasons. The first one is that Nepal is emerging as a hub of engagement on various public health topics around the world, and especially for South Asia, this is more and more a space of prominence where we would like to bring in experts, policymakers, scientists from countries like India, Pakistan, Nepal, Bangladesh, Afghanistan, and this is our small endeavor in that step. So we have been asking ourselves a few things, and I'm going to refer to my notes because we were looking at among the top 10 causes of death in Nepal, drug-resistant tuberculosis is one of them. But at the same time, Nepal is a country that has embraced and has been very forward-looking when it comes to implementation of shorter, safer treatment regimen. So there is a lot to learn and express that we hope is through the conversations we will have all along the day. The day has been curated in a manner that it addresses multiple aspects of TB. So from a point of view, how funds are doing when it comes to TB care, to how community-led approach, patient-centric approach is helping us see what is the impact of that, to some of the learnings that come from India, from Nepal, from Pakistan, from Bangladesh. We would hear it through the day. So we hope that today is not a day which stops in itself, is a day that starts a chain of events, a catalyst that would bring more conversations, and we want to be just an igniter of that space. Thank you very much.
Thank you. I would like to call on Dr. Prajwal Shrestha, who's the director of NTCC, to give his opening remarks. Thank you.
Thank you, Dr. Helen. Respected Chairperson, Dr. Farhat, respected Chief Guest of this today's program, Dr. Roshan Pokhel, who is the Chief Health Secretary of Nepal. On behalf of National Tuberculosis Control Center, I would like to welcome all the respected delegates to this very important event of celebrating the World Regional TB Day 2024 in the Nepal. This is very special for us, and I would like to thank the Médecins Sans Frontières for considering the Nepal as a place where we are going to celebrate this important day. To talk about the TB, discuss about the major issue of this disease. So when we talk about the TB, it's a global problem, it's a regional problem. We are in the region where it includes almost the 45% of the burden of global burden of the tuberculosis disease. And in Nepal, this country is listed as a medium burden country for the drug-sensitive tuberculosis. And whereas in the recent global TB report of WHO, now the Nepal is enlisted among the top 30 high burden country for drug-resistant tuberculosis. So we have a huge incidence of almost 239 per 1 lakh population each year, and the prevalence of 417 per 1 lakh population, and we have a daunting task of decreasing it to 181 per 1 lakh population in this NSP period by 2026. And then we are guided by our goals and vision of ending and eliminating TB by 2035, and then eliminating TB by 2050. So we have a very we are working in line, as per the international commitment, global commitment to end the epidemic and to eliminate the TB by 2050. So in this regards, we as a national tuberculosis control, as a national tuberculosis program, we have initiated very few activities like more molecular diagnosis. We have to do almost 100% initial diagnosis test by molecular diagnosis by the end of 2026, 2027. And we have to do more this active case finding up to the community level. And in this regard, the Nepal has promised and given a high-level political commitment, which is globally appreciated as a program of TB-free initiative Nepal, which is basically implementing the program up to the local government, up to the local level, doing the active case finding in the hard-to-reach population, in the high-risk population at the local level. So in this regards, and since the Nepal is enlisted in the top 30 DRTB patient load, so we have, as a national tuberculosis program, we have also updated, endorsed and implemented this new all-oral safer, which is not only shorter, safer, but also effective regimen of all-oral regimen BPAL and BPALIAM in Nepal. And we are going to implement this since from the first week of April 2024. So lots of things I expect, and I hope that the day will be very fruitful. There will be a very fruitful and the productive session where we will have a two-way communication and discussion after each session. We have the media person here, and I look forward for the very productive discussion and the communication between all the delegates and the speakers as well. And especially I would like to thank the MSF for this collaboration to celebrate this special day in Nepal. And we had we had confirmed this day almost 3 months back, and we had a series of virtual meeting, this advisory committee meeting. And I would like to special thank to all the members of the executive members of the MSF, and from their efforts, our combined efforts, now the events is going to happen. So at the end, my special regards to the MSF, and as a program director, I also seek such a future collaboration in the various aspects of tuberculosis control program in Nepal. So, and in the end, and I would also like to again highlight the the line that the Dr. Helen just highlighted, that yes, together we can make a meaningful change. So thank you. That's
Thank you, Dr. Prajwal. May I invite our honored guest speaker, Dr. Roshan Pokral, to join and make. Thank you very much.
Thank you, Dr. Helen. यस कार्यक्रमका अध्यक्षता गर्नुभएका दुई मित्रहरू डाक्टर प्रज्वल, डाक्टर अराफत र उपस्थित साथीहरू, सेक्रेटरीको नाताले पहिले केही शब्द नेपालीमा बोल्नुपर्ने भयो हुनाले सबैलाई हार्दिक स्वागत गरे मैले यस कार्यक्रममा। आज के एउटा महत्त्वपूर्ण कार्यक्रम हो, यसले पक्कै पनि हामीलाई आगामी दिनमा कसरी अगाडि बढ्न मद्दत पुग्छ र हामीले गरिरहेका चिजहरू हामी कहाँ छौँ र कसरी हामीले 2035 मा टिबी एलिमिनेसनलाई सहयोग पुग्न सक्छ भनेर MSF का साथीहरू र NTCC लाई हार्दिक धन्यवाद दिन चाहन्छु. Now अब as a doctor, as a secretary, to all the delegates, thank you for coming today. It's a big day for us. I mean, the collaboration between MSF and NTCC is a big one. We know we're moving in a certain direction as per the world's direction in elimination, trying to eliminate TB in a very difficult situation. The concern for the government is not only in infectious diseases, but the movement of two non-communicable diseases is always there. So where are we? How do we move ahead? What are the programs that we are implementing right now? Are we in track to reach our goals? These things are a big concern to us right now. So I don't think with the pace that we are moving, I don't think we'll be able to reach our goals. That I'm not talking as a secretary, but as a doctor, as a public health expert, as a person working in this field for the last 22 years, this pace might not lead to where we want to go. So I think we have to drastically, radically change certain things in order to achieve our goals. So this deliberation, this talk today, this program today will definitely give the ministry, and especially NTCC, or the policymaker like us, some sort of direction to how to reach there, you know. So I welcome all the academicians, I mean, public health expert, I mean, especially people working for TV over the last many years. All of you are here. I see my seniors out here. I see a lot of renowned people out here. So I take this opportunity from the Ministry of Health and Population to thank you all for being here. And I'm not going to talk about TB because now I'm not an expert on that, you know. But as a secretary, I want certain deliberations, certain policy changes, certain ideas from all of you so that in the coming days, we can move in such a way that we can eliminate TB by 2035. The goal seems difficult, but I think with all your support, I think we can reach there. So thank you very much, and I especially thank MSF South Asia for letting us organize this event out here in Nepal, in Kathmandu, along with our colleagues in NTCC. All my colleagues are here. I wanted to be here, sit here throughout the day, but unfortunately, because of my other commitments, I'll not be able to do so, but I hope this deliberation will come up with certain policies, certain changes which we'll have to make in the coming days to move forward. And finally, thank you very much for all of you for coming here. I welcome you, and I hope the deliberation will definitely give us some sort of direction in the coming days. Thank you. Welcome.
Thank you very much, Dr. Roshan Pokhrel, for coming from your busy schedule to join us for this. So I would actually say that now we're starting our first panel discussion of the day, and it's on the topic of funds, the trickle-down effect right from the donors to the beneficiaries. The session would entail a deep discussion on how TB science stands on the precipice of delivering game-changing new tools to eliminate TB, including new vaccines, but development to date has been severely delayed by ongoing under-resources. The world will remain perilously off track in making good on this historic commitment to finally defeat history's deadliest infectious disease, with an additional 6.6 million TB deaths by 2030 estimated if the status quo is maintained as is. We have experts from the field with us today, and Dr. Farhat Mantu will moderate this session. Farhat, please come up. And I think some people are online and some people are in person. Yeah. Can we have Lorraine? Well, anyway, I'll let you do that. You invite up the speakers? I don't know them.
Okay. After hearing about from Dr. Bhargava about the holistic aspect of care when it comes to TB, let's move to something that is quite interesting from a point of view, where do you put your money? And for this session, I'm always, when I talk about money, I'm reminded about something, a story I read a long time back, and it stayed with me. It's about a couple, and it is around a time when COVID had kind of was towards its last leg. So it was a couple who were daily laborers, and because of COVID, they lost their employment in the sense that they were not able to work anymore. And at the same time, they started having problems, nutritional problems, problems to feed themselves from 2 meals a day to 1 meal a day, to a point in time when they had nothing left. And in the meanwhile, one of them was infected by TB. And then this couple they had only 2 cows. They had to sold it off to be able to afford TB care. And still then, one of them was not alive towards the end. Even after saving everything you had, you spent everything, but you still do not get what you want. So today, what we want to do through this panel discussion, we want to bring in a variety of views on TB funding. So we have so let me start. We have online being joined by Mike. Can we have Mike online, please? Very early for you, Mike, in US. So just to very briefly introduce Mike, he's the co-director of Tuberculosis Program at Treatment Action Group, New York. And he leads the following areas of TAG's TB portfolio. Number 1 is advocacy to support universal access to TB prevention, including research to develop new TB vaccines and preventable therapies, and research to track global funding for TB research and development. And third one is to work to define and apply the human right to enjoy the benefits of scientific progress to advance TB research and access. Then I have some colleagues in the room, so I'll invite all of you to come here. So starting with Dr. Ashish. Dr. Ashish is a senior technical advisor with Save the Children Nepal. His contributions are significant in the tuberculosis space and works closely with the National Tuberculosis Control Center of Nepal. So please have a seat. Then we have Dr. Shayala Islam, who is an accomplished public health professional with the experience of over 20 years in primary health care and currently serving for BRAC, Bangladesh, as an associate director for communicable disease. Then we have Dr. Adil Tahir, who works as a senior program manager for Mercy Corps International for Pakistan, who has been a significant player in the space of TB. We have also joining us Dr. Vaishali Venu, who is the Director of Health and Nutrition Program at Doctors for You India. And then we have Dr. Kritika Dixit, who is the research manager at Birat Nepal Medical Trust, who we believe that is going to bring in the patient's perspective. So how are we going to do this panel discussion? For the sake of setting the stage, we would invite each one of them to very briefly talk about what they have been doing in the space of TB and funding. And I will invite Mike to go first and share the recent report that has been published to help us see through the tuberculosis research funding trends. Over to you, Mike.
Okay, great. Thank you very much. I have some slides. Would you like me to project them, or are you going to do it in the room? And let me know if you can hear me okay.
So he can play. I'm just looking at my team. Yes, please go ahead and share your screen.
Okay, let me pull those up.
If you could put them in the presentation format, we can see your screen.
Yes, give me just a second. My computer is catching up to the screen sharing.
Mike, it appears that I don't know if you're still online or not. Are you? Okay, yes. Something is coming up on the screen. If it's difficult, then we can, okay, now we are done. Yes, please, go ahead.
It looks good. Okay, excellent. Thank you. Sorry for the technical issues. And hi, everybody. It's great to be here and to be able to join you from New York, where it's still Wednesday. Very happy to be with you, and sorry I can't be with you in person. So what I'm going to present is just an overview of funding for TB research and development. And this is based on an annual report that TAG and Stop TB publish each year. And before I get to the report and the data, I wanted to open with these two statements by Dr. Tedros and UN Deputy Secretary General Amina Mohammed, who at the UN high-level meeting on TB last September emphasized the importance of research and development to end tuberculosis, Tedros specifically calling out the need for a new tuberculosis vaccine, and Amina Mohammed saying that in order to develop these tools and ensure they can reach everybody everywhere, it will require financing on a massive scale. And when UN member states met in New York to talk about the financing needs, in the political declaration that they signed, they made a commitment in paragraph 68 to mobilize $5 billion a year for TB research and development by 2027. And so with that commitment, we have a global target for TB research funding of $5 billion a year. And I also wanted to point out that this paragraph talked about the importance of ensuring that all TB research efforts have the participation of institutions from all countries, especially developing countries, meaning that TB research and innovation is a global endeavor. It's not something just for some states, it's something that all states need to contribute to. And so with that in mind, since 2005, Treatment Action Group has been conducting an annual survey of global funding for TB research. We send a survey each year to biomedical research funders in countries around the world, and we publish the results in this report, which came out last December, providing new information on TB research funding in fiscal year 2022. And what this last year's report allows us to do is to at the first UN high-level meeting on TB in 2018, where states said we need $2 billion a year. And it also sets a baseline for measuring progress moving forward against this new target set at the 2023 high-level meeting on TB of $5 billion a year. So with that background, I'll show you the data on actual funding for TB research and development. This graph shows you total global funding over time from 2005, the first year we started the survey, to 2022. And on the face of things, this is a somewhat optimistic story. You can see that funding, the blue bar, is going up over time. The yellow line is showing you funding adjusted for inflation back to 2005 dollars. So we're not quite maintaining purchasing power, but nominal funding has increased significantly. But I think what is more sobering is to realize that we're far away from meeting those global TB research funding targets. So in 2022, which was the highest level of funding we've ever recorded at just over $1 billion, that's still only about half of the old target of $2 billion a year, and it's 1/5 of the new, more ambitious target of $5 billion a year. So we are very far away from meeting our global TB research funding goals. We also look at where funding is going, and we divide it into 6 different categories of TB research: funding for drugs, diagnostics, vaccines, money spent on basic science. We have a category that we call operational research and epidemiology and social interventions. And so, for example, the rations trial that we just heard about would be in that operational research, epi and social interventions category for us. And then we have an infrastructure unspecified category. So you can see that in terms of the different research areas, TB drug development receives the most funding, about 1/3 of the total, followed by TB basic science, diagnostics, vaccines, operational research, and then infrastructure. And this is a ordering and a proportion that has basically remained stable every year that we've done this survey. One thing I want to point out, because we'll talk about it later today, is that vaccines is actually the most underfunded area of the pipeline relative to the targets that have been set by member states and the UN. So over the past 5 years, 80% of the vaccine funding target went unfulfilled. The pie graph here is showing you funding for TB vaccine research in 2022. I wanted to put it on screen so you can see the leading donors to TB vaccine development. And as the graph indicates, over 80% of funding spent on TB vaccine research last year came from just 2 institutions, the US NIH and the Gates Foundation. So this is a field that is heavily reliant on just a handful of major funders. And when you compare, the amount spent on TB vaccine research over the past 5 years, just $610 million, it's really, pathetic is the only word in comparison to the tens of billions of dollars spent on COVID-19 vaccine research in just the first year of the pandemic. So this is a field that is critically undernourished in terms of the resources being put into it. I also wanted to show the numbers for TB operational research, implementation science, and epidemiology, and to show you who the leading funders of this area are. It's a bit of a more diverse funding pool than vaccines. The NIH is still the largest donor, but you have a greater proportion made up by donors, including USAID, Global Affairs Canada, donors in the UK. ICMR is there with just under $5 million spent in 2022. And so you can see what funding for operational research looked like, and it totaled just over $123 million last year. If you look at the overall funding figures for TB research and development, it's heavily concentrated among just a handful of institutions. So the top 2 donors are both based in the United States with the NIH and the Gates Foundation, and together they make up 51% of the total. By the time you get to the top 5, you're already at 62%. The top 10 and the Indian Council on Medical Research is there as the 10th largest funder of TB research last year. You're at 75% of the total. Top 15 with Korean Ministry of Health is at 83%. So this is a field that needs to attract more money, but also needs to attract more funders and the participation of more institutions and more donor agencies. I also want to point out that most money for TB research comes from the public sector. So we're very reliant on governments for what is spent on TB research and development. About 66% of all money spent on TB research in 2022 came from public institutions. But within that public total, half of public funding came from a single agency, the US National Institutes of Health. The second largest source of funding for TB research is philanthropies, and about 80% of the philanthropic total is from the Gates Foundation. The second largest is Wellcome Trust, and actually MSF is one of the largest philanthropic donors of TB research and development. We, of course, know MSF as being a humanitarian agency. They do research that is essential, but they're not primarily a research funder, of course. That's not, central to their mission, first and foremost. So the fact that MSF is the 3rd largest charitable funder of TB research tells you just how few philanthropies, I think, are in this space. And then the private sector, only about 11% of the total. So very little investment spent by private sector pharmaceutical companies and multilateral agencies make up the remainder. So I'll end by saying that the reliance of TB research on public sources of funding has led us to recognize that advocacy toward governments to increase investment is really critical because of the role that public money plays and because public money also attracts investment from other sectors. And so with this in mind, several years ago, TAG and Stop TB Partnership created something that we call the Fair Share TB R&D funding targets. And they basically acknowledge what UN member states did at the high-level meeting, that every country should contribute to TB research and every country has something important to give. But the question is, how much is enough? And so the Fair Share funding targets are a way to answer that question. And they basically take that global target for TB research, $5 billion a year, and they break it down and say, what share of the $5 billion should come from India versus the United States versus Nepal versus France versus other countries. And they make a concrete ask of those governments. And fair share is set in relation to what that country is already spending on other forms of research and development. And so when we put together this framework, we initially said that fair share was each country spending 0.1%, just 0.1% of what it spends on all forms of R&D, on TB R&D. And with the new higher TB research funding targets endorsed by the UN, we've increased that now to 0.15%. And on my last slide, the next slide, I'll just show you what that 0.15% translates to in dollar terms for different countries. It would mean that each year, Australia would need to spend 36 million on TB research and development, India would need to spend 88 million, and the United States would need to spend 1.2 billion. And I think what is important to realize is that no country is meeting its fair share target at the 0.15% level. And so our advocacy for TB research is going to be essential. And with that, I'll leave it there. The report is available online, and very happy to answer questions and to hear from you. So thank you so much.
Thank you, Mike. I'll request you to stay online. With this first presentation, actually Mike paints a very good picture of how the global funding scenario looks like in the space of TB. And while he mentioned MSF, operational research is like the research in itself is not a leading criteria. It is what our patients and our frontline workers experience on a day-to-day basis. And anything we do, be it TB Practical and TB Trial, these were the two trials we did in last many years, and the results are, some of them are on your table. They are driven by the barriers to access and sometimes non-availability of care. Now zooming in South Asia, so we asked our recipients of the Global Fund from the region and the main organizations that have been a part of that to come and share their experiences. So each one of them is going to very briefly set the stage of what is that they are doing, and so that we could get into a stage where we do a two-way conversation. So I'm now going to invite Dr. Ashish to talk about Save the Children, what they're doing in Nepal with the Global Fund funding. 7 minutes?
7 minutes?
Yeah.
All right. So someone is working with the slides, right? Okay. Just to check. Okay. Thank you, Farhad. Just to give a snapshot of how Save the Children is functioning and how the funding trickles down from donors to the community. So basically, Save the Children is a principal recipient of the Global Fund grant in Nepal for TB, HIV, and malaria. So if you see, So Global Fund kind of supports more than 100 countries throughout the world, and Nepal is one of the recipients of a Global Fund grant. So there's a coordination committee which is called Country Coordination Mechanism, so which governs the Global Fund activities in the country, and with that Nepal also received the grant, and Save the Children as a principal recipient is delivering the activities in the country in close coordination with Ministry of Health and Population and 3 different entities for all TB, HIV, and malaria. This is just a snapshot of where Save the Children is functioning. So you can see in the map that it's almost throughout the country where Save the Children is functioning through its sub-recipient partners, which are the local NGOs in the communities. And in particular, if we see where does this Global Fund support happens, it happens across the health systems. So be it system strengthening in terms of strategic information, procurement, lab, treatment, community system strengthening, all to actually system strain. So the main focus is to ultimately systems strengthen the government and create an enabling environment to deliver the needed interventions. So it works for all three, but in particularly if we see for TB. So in TB, what we can see is still, this is a snapshot of the TB situation in Nepal. Despite efforts, there's still a lot of cases missing. So that's the primary challenge for the country. If we see still 45% of cases are missing, even that is even higher still for DRTB, which is even a very negative outcome, kind of a very severe condition of TB where all drugs are being resistant. So the outcomes of patient dying is very high. Even in those conditions, the resistance is, the missing cases are very high. So that's the primary challenge for the country. And together with the ministry, the Global Fund, Save the Children is trying to, putting its effort, primary effort in trying to find these missing cases. So if we see that various fundings that is available, particularly for TB, so if you see there's a dedicated TB funding through Global Fund, and which is, I'll show later, we work with 4 sub-recipient partners for active case finding and 2 for DRTB. And there's another funding called catalytic funding where there's some support, especially for community system strengthening and addressing stigma and discrimination, as well as we discussed in the morning, the nutritional part of it. So there, through C19RM, there are some nutrition support and health system support for TB as well. This is particularly for TB. So if you see the coverage for TB interventions are through 4 SRs, as I mentioned earlier, and the primary intervention is active case finding. And it covers around 80% of all population. So here we see 42% district, but it's a very high burden districts out of 77. So these are our 4 sub-recipient partners, Bagmati Samaj Seva, Jantra, Kids and Trishuli Plus. So if you move on, so this is how the funding trickles down as well. So overall, around 81 million USD, the TB allocation is around 25%. So around 20 million USD is allocated for TB, and 53% of it goes to TB care and prevention. For program management, for human resource management, around 15 to 18%. We have interventions on MDR, which is around 15%, and health systems resilience is around 11%, and TB HIV also we do invest, which is around 3%. In terms of human resource, we see 24% is deported to the government entities. That means we have a very strong technical team stationed in each government entities. There's which is called PMU, which is at National TB Control Center, similarly at HIV control, which is called NTCC. So, and then 48% are in the provinces to strengthen the provincial government as well as for implementation. And around 20 to 25% are in the country office, which is mostly the cross-cutting human resources. And these are the key interventions that we do, because as I mentioned earlier, active case finding is the primary intervention, because we're still missing a lot of cases. Once we address that, there are other things to follow, like patient support, nutrition, and everything to follow. But these are the primary interventions. And we're very happy to say that these active case findings activities have really yielded a lot of cases. More than 60% of total notification that the government does comes through active case finding. So if we see, because the reach of diagnostics is still very centralized. Though we say we have 113 gene expert centers, they are still not true point of care. They are still near point of care. So to strengthen that, through our support, we have strengthened this Sputum courier and transport system. And we have that network throughout the country. With that Sputum courier, which is the most important part, which yields around 20% of all notifications. So that's very important. And similarly, we have in hospital, we have methods like FAST, where we actively screen and test TB patients to fast-track their process. So it yields around 20% of notifications also. And very important is screening in malnutrition children. And there we have around 7% of yield, total cases among notifications. So And another very important is private sector's engagement. So if we see the private sectors, we have in 7 districts, private practitioners and pharmacies are being engaged, and their yield is also very high in terms of 20 to 30%, 20% of notifications that come through private sectors are because of these engagements. And beyond that, we have a catalytic fund which does work for stigma, discrimination, community system strengthening. If you see, with this, we have been able to establish coordination meetings. We have been able to establish and strengthen community groups, youth engagements, advocacy and communications through this mechanism as well. So this is just a snapshot of how Save the Children is supporting to carry out national TB control program support. Thank you.
Thank you, Ashish. We'll continue. We'll have a time for Q&A once we are complete with all the presentations. So I would like to invite Dr. Shaila to share the experiences of BRAC on how they are looking at TB.
So, I think good morning again to everybody. So, I think just first of all, I would like to thank MSF to invite me here. It's my pleasure to be here to present my organization as well as my country, what we are actually working in TB control program in the country. So Bangladesh is still a high burden country among Southeast Asia's countries. So incidence is 221 still per lakh population. We can reduce the prevalence, but we didn't hit still the incidence in the country. And mortality has been reduced to almost half over the years, if we consider 2015. And the MDR or drug resistance TB incidence is 2.9 per lakh population. It's from the last drug resistance survey. We have among new cases it's 1.1 and previously treated cases 5.5. So BRAC is one of the principal recipient in the country with the government. Government is one of the principal recipient, and NGO from NGO, BRAC is the principal recipient for TB control in the country. So this is the implementation coverage in Grant Cycle 7 under Global Fund Grant. So we are working with 167 population. We have 64 districts in the country with 498 sub-districts. I would like to mention here that each of the sub-district is the treatment unit for the country for tuberculosis. And we were working with second lab that is below sub-district level. That's the number 365, and we have our engagement among the prisoners. We are screening in 53 prisons. Among them 3, we have the labs, and we have Port Hospital, APJ's expert processing zone. We are also working in the workplaces. We are running the 4 mobile vans throughout the country, equipped with X-ray and gene expert facilities. We have in GCC 7, 18, actually this is the wrong 23, it was in the previous cycle, so 18 sub-recipients with us throughout the country implementing. So here I would like to focus on the different area where the government peer is working and the NGO peer is working. So as in terms of policy planning and capacity building, the national development of national guidelines and training, central level trainings mostly, and the technical trainings are conducted by the government, and some local level trainings and some civil society mobilizations run by the NGO peer. And in terms of diagnosis and treatment, government diagnose and treatment in the facilities, and usually the NGO peers or implementing partners along with its SRs, they are doing it in the community level and below sub-district level, some of the below sub-district level facilities. And they are also implementing the DOT part, directly observed treatment part at the community. And then in terms of diagnostics and drugs, government is mainly responsible for procuring, and the NGO PR is responsible for distributing throughout the country. All the supplies up to the beneficiary level. And for TPT or prevention, the same government is procuring the drugs and the implementers are doing it throughout the country. And for monitoring supervision is the joint monitoring and supervision by the government with partners in the respective areas they are implementing. And for NGO, they are doing the local supervision and monitoring also. So the priorities for Grant Cycle 7 are here I tried to focus on. So comprehensive active case finding activity in the community level, so that there should be the early detection from the community and the treatment, and the optimum utilization of the molecular diagnostic, gene expert and true nurse, because country has already huge number of expansion of these molecular diagnostics throughout the country. And in GC7 we have also focused the contact investigation coverage as well as the proper documentation and ensure TB preventive therapy, though it's partly we are doing based on NSP, there is a gap, but in GC7 government is committed to do that fully based on NSP to contribute in the TPT, procuring TPT medicine other than funding. And the private sector providers we are trying to engage. So in that case, we are engaging the workplaces, more than 1,200 workplaces we are working with government. And prisons I have already mentioned, and we are supporting ambulatory treatment in the community for drug-resistant TB. We have 8 regions or division we call in the country, and we started from the 0-day treatment in the community for drug-resistant TB in the 4 regions already, and by this year we will scale it up in the 8 divisions. And in some malaria endemic districts, we have 13, so we are doing integrated disease-based program in those 13 districts. And the TB patients, so we are also screening the TB patients. We have 23 high priority districts for HIV, so we are doing HIV screening among TB patients in the country also. And we are going to do the pilot for community-led monitoring in the 5 districts in this GC7 grant cycle. So gap areas still will be in the GC7 funding. So in this part, I'm not going to go through all the points, but in the child TB, there is no specific activity under Global Fund grant, but government is committed to support in some of the activities throughout the country on that part. And the cartridge, TST kit, as well as TPT medicine and second-line drugs. Some are procurement, some will be procured under Global Fund grant, but government will be contributing other parts, as government is for over 6 years, Bangladesh government is contributing for first-line drugs totally. So nowadays there is a transition plan to take over by the government slowly, but in this GC7 government has planned to do something by its own funding. And the case finding activities in key population, there is a gap in some spaces because it was there in slums, refugee and some other marginalized group. And private sector engagement is not yet, the mandatory notification is not yet operationalization. So government is trying with other, government has one SRs, ICDDRB, so it's trying to functionalize that with using some app there in the country. And the main gap in GC7 funding is the community system strengthening here still, because the community, there is no training or capacity building activities for the community people here. So that is one of the major area for gap, and finally the nutritional support for the poor group of TB patients. So challenges, I have mentioned here the supplies, as is some of the major and important logistics will be transitioning in terms of procurement from the donor to the government. Government is taking care, so it might have some interruption. And scale up of ambulatory treatment, as we are facing already some challenges, we are addressing those accordingly. And strengthening the sputum transportation system. We have sputum transportation system, but still it's very challenging for some area, remote areas in the country. And prison screening in the prison among the prisoners is we are facing difficulties, and sensitization of private sector providers, because our treatment coverage is still around 80% in the country. And it's ups and downs per year over last 3-4 years, but we are trying, but it's the private sector where we are missing some cases, I think, and hence the domestic, finally the domestic resources, the government is trying to increase the government resources, as based on our NSP, there is a gap in between funding as well as the NSP, costed NSP. So I think that's all from my side. Thank you.
Thank you very much. I would like to now invite Dr. Adil Tahir from Mexico to talk about their experiences in the space of TB.
Hello, everyone, and thank you, Farhad. Yes. Okay, so a brief overview of the TB situation in the country. You can see that Pakistan is one of the largest country in terms of population. So we have 236 million people. TB burden in the country is high. In Pakistan ranks 5th among the high burden TB countries in the world. Incidence of new cases, you can see Pakistan estimated number of cases in a year is around 600,000, and TB incidence rate is 258 cases per 100,000 population, and the mortality for the year 2022 was reported around 47,000, unfortunately. So the health sector in Pakistan, it's divided into two main sectors, that is public sector and the private sector, and the Global Fund supports both the sectors. So in public sector, the principal recipient is National TB Control Program and is overall overseeing the implementation of TB activities. National TB Control Program has sub-recipients which are provincial TB control programs. Pakistan has 4 large provinces and regions, so they are the sub-recipients of the Global Fund as well indirectly. Health facilities on board, more than around 1,500 health facilities are on board. That includes tertiary care hospitals, secondary care hospitals, and primary healthcare facilities, including rural health centers. Geographical coverage is National TB Control Program is present in almost all the districts of the country. In private sector, Mercy Corps is the principal recipient, and we have 6 sub-recipients, which are 6 local NGOs, and they are working with us for almost a decade. Health facilities on board, if we talk about them, we have 14,000 general practitioners that are working in the country. They are a partner with us in this program, and 385 private hospitals, including large private hospitals as well. In terms of geographical coverage, we are covering 119 districts, and I will explain the details in the next slide. Yes. So these are the 6 sub-recipients, and they are covering 93 districts. And in 26 districts, Mercy Corps is directly implementing the TB control activities. through our field offices, which are present in 3 different locations. So that's a snapshot of our presence. Yes, so what activities we are doing? We are actually implementing all these activities, and I'll explain in detail in my next presentation after the lunch. But for now, we are involving general practitioners. So any general practitioner who is working in the district where we are working, we are present, we try to take them on board through a partnership agreement, and we provide them free of cost services like in terms of medicines and diagnostics. Active case finding is through organization of chest camp in far-flung areas where we do not find any general practitioners or large private hospitals. So we have 40 mobile vans that are equipped with digital X-ray machines and CAT4TB software, and also these vans are equipped with gene expert machines. So we go into the field, we diagnose the TB patients, and the treatment starts. Enhanced case finding intervention is involvement of large private hospitals. So in Pakistan, there are parastatal hospitals, private hospitals for profit, and NGO-led hospitals. So we take them on board through this intervention. And then specimen transportation system, we have developed a digitally innovative system that is functional in 102 districts, and it's all innovative, a paperless system, and it's run more or less like an Uber kind of transport system. There is a free application that is available in Google Play Store. Anyone can download it and be a part of our system. Funding landscape, so as I mentioned that the Global Fund funds both the PRs and the funding for the GC7 grant is $188 million. And Mexico's share in that is $40 million. Rest of the money goes to the National TB Control Program, who is also responsible for the procurement of TB drugs and diagnostics, particularly lab supplies, gene expert machines, and cartridges. Mexico does implementation mostly through its funding, but we also do some kind of procurement. Like, for example, we have a huge field force, which we call district field supervisors, who implement our TB activities. So we provide motorbikes to them, and then some other accessories for gene expert machines. So these kind of procurement Mexico does, but mostly the procurement is being done through the National TB Control Program. The supplies are distributed first centrally, then to the province, and then to the district level. The government of Pakistan also support this program through the provision of drugs for drug-sensitive tuberculosis, and also the infrastructure in terms of the health facilities where we are implementing our program. So what are the services that are covered through this program for the patients? Mainly our focus is out-of-pocket costs for the patient. So you can see that we provide free diagnostics, including sputum smear microscopy and gene expert testing, free TB medicines, both anti-tuberculous drugs and TB preventive medicines. We also provide a very nominal incentive to GPs to keep them motivated and develop the partnership with us, and also to the private laboratories. Then the travel cost of patients who are diagnosed as rifampicin resistance, they are referred to the PMDT sites where they are treated. We provide travel cost to them as well. But there are certain things that are not covered, and we are trying to cover them as well, which is the cost of ancillary medicines. So, you know, when the doctor diagnoses a TB patient, sometimes they provide multivitamins and some other drugs, but these are not covered through our program. Cost of ancillary tests, again, Pakistan is a country with a huge burden of hepatitis, so sometimes the doctor prescribes liver function test or renal function test. These costs are still not covered through our program. And cost of x-rays, yes, we do have certain x-ray machines installed in the program, but the districts where we do not have x-ray machines, the cost is being borne by the patients. This is the overflow of the data. You can see that the data reporting starts from the facility level. From the facility level, at the end of each quarter, the data is finalized through a quarterly review meeting. Then the data goes to the provincial level, and from provincial level to the national data system. And we do have checks and balances at each system, and we have a monitoring mechanisms. The flow of assets is in the reverse order from the national level to the provincial level and to the district level. We'll explain in detail in my next presentation. Some of the challenge, yes, I have mentioned the out-of-pocket cost for the patient. We try to minimize it, but still there are certain items that the patient has to bear. Less funding for advocacy related to tuberculosis over the years, thanks to the Global Fund, but mostly we are getting money for implementation and less for advocacy, and we are trying to tap certain resources to fill this gap. And then donor dependent, as I mentioned, that the Global Fund has been the principal, has been the donor for the last many years. So due to that, fortunately, we are working good in tuberculosis, but unfortunately, our dependence on the donor has increased. Like for example, we are totally dependent upon the drugs for MDR TB for Global Fund money, and this we need to coordinate with the government, and we are doing it and sensitizing the government. But these are a few challenges. That's it. Thank you very much.
Thank you, Dr. Adil. Dr. Vaishali from Doctors for You to share the perspective from India.
Good morning, everyone. This is Dr. Vaishali from the organization Doctors for You, India. I head the health vertical for them. So in the morning, Dr. Madhavi and Dr. Anurag had given an overview of the TB scenario in India. I would just like to give a quick recap of that. Globally, we are contributing to 27% of the TB cases. In 2022, we had 24.2 lakh cases notified in the country. And I can't see. Hello? Yeah. Great. So we have a prevalence of around 172 cases per lakh population. In spite of having such a huge population, the national program is being able to give the free diagnostic testings, the free medicines, and the private patient support systems through the direct benefit transfers and the nutrition support. There is a huge private sector in the country which accounts up to almost 70% of the population. Our private provider support agency basically is a system which is present in 16 states and is contributing to around 80% of the notifications. A very strong political advocacy, and it strives to achieve elimination by 2030. There are a few major challenges which exist in the country. First of all, stigma. So TB stigma is still huge. Secondly, we have a very large number of the missing cases. We need to expand the screening to find these missing cases. There's a rising number of DRTB cases with a very limited access to the treatment in the private sector. Half of the extrapulmonary and the pediatric TB are still diagnosed clinically. We need to scale up the prevention activities to reach towards elimination. So the Global Fund grant in India, we have the government PR and the non-government PRs. For the government PR, the total funding for India is around $284 million US, out of which the government PR, that is the Central TB Division, accounts up to almost 86%, which is around $245 million. And the rest NGOs are accounting up to 39 million, that is around 14% of the funding. In the non-governmental PRs, we have three main PRs, HLF PPT, SATHI, and KHPT. When we were having a conversation with MSF for this particular conference, that time we were a PR, today we are an SR. So that's the difference that happened in 2 months. So for the government PR, the Central TB Division mainly focuses on the 4 key interventions. First is the programmatic management of the TB preventive therapy, TPT. Expanding the coverage of the DRTB treatment, decentralization of the rapid molecular diagnostics, and strengthening of the TB surveillance. Through this funding, basically the drugs and the diagnostic consumables are procured. And for the TB surveillance, the district level and the sub-national level certifications are being funded. The grant modality is payments for the results. So whatever number of TPTs or the number of testings which are done are accordingly, the results are uploaded and then the payments are released. For the non-governmental NGOs, we have the 3 main organizations here. First is the KHPT. The main role of KHPT is around the community engagement. They do their engagements through strengthening of the community, then capacity building of the Gram Panchayats, the Panchayat Raj initiatives, then technical assistance for the direct benefit transfers, and the technical assistance for the Pradhan Mantri TB Mukt Bharat Abhiyan, that is the nutrition aspect. For Sathi, the main activity revolves around the pediatric TB, and that it gives the technical support to increase the uptake of the pediatric TB diagnostics and treatment in the public sector. It decentralizes the sample collection and the services through the other child health programs. Private sector engagement through the technical support to the PPSAs and the Indian Association of Pediatrics, national and sub-state level trainings of trainers, and the active case finding. HLPPT, we have the activity which revolves around the active case finding and the private-public partnerships. The first, active case finding. Next is the strengthening of the private sector engagement through the corporate hospitals and the online healthcare platforms. The skill development for the TB survivors. Engaging Ayush and informal providers for helping out in the case finding and the early diagnosis. And lastly, strengthening of the sample collection and transportation. I would just like to briefly introduce Doctors for You. So we are an pan-India organization established in 2007. We have a very humble beginning of a single room and few plastic furnitures. But today we are proudly associated with the public health system in India, catering to almost 26 states in the country. And we mainly focus on giving medical care needs to the vulnerable group in the crisis and the non-crisis situation, especially people who are affected by natural disasters, conflicts, or epidemics. We have a goal of health for all. The core areas of work include the primary health and nutrition, the emergency response, skill development and livelihood. We also have a small part working towards WASH, environment and training and research. We have a decade-long commitment that we've been doing in TB for the country. So the programs started off very small, like a DOTS provider, and went on to active case findings, then establishment of low-resource DRTB settings. Thanks to MSF, we've been receiving little funding for our DRTB center, also technical assistance, and the trust that they had during our initial days. Today, the major game changer for us was the PPSA program. So the PPSA program is a program wherein the private TB patients are notified into the government portal. So in India, we have around 7-8 agencies who are doing this work in the country. So we are one of them. We have around 500 plus trained employees doing this work, around 84 districts in the country. And last year alone, we were awarded by the Central TB Division for the highest number of TB notifications from the private sector, which was around 1.4 lakhs. Over the last 3 years, more than 2.8 lakh patients have been notified, and we have a successful, out of these patients, we have a successful treatment rate of around 81%. With respect to the funding that we have got for the Global Fund, there are 5 main objectives. The problems revolves around the DRTB, delayed diagnosis, a huge private sector, then clinically diagnosed EPTB and pediatric TB cases. So these are the kind of the problems that are there. So the objectives are firstly establishing a hub and spoke model for managing drug-resistant tuberculosis in the private sector, implementing strategies to expand the use of upfront NAT for extrapulmonary and TB, pediatric TB, to carry out the active case finding amongst the vulnerable population by using of a portable X-ray with AI. Fourth is involving Ayush practitioners for from the private sector to enhance TB care. And lastly, enhancing the sample collection and transportation through the Nikshay barcode system. So in DRTB, what the experience that we've had is that because India has a huge private sector, and the majority of the times what happens is that the patients reaches a public sector, and because of the continuous appointments that are given, they eventually turn out in the private sector for treatment. So with respect to the PPSA, all the drugs, the diagnostic tests are covered by the government. So we plan to establish a system similar to the PPSA, but PPSA is only for the DSTB. So this program will be for the DRTB. So here there will be capacity assessment of the hospitals, technical assistance, hand-holding, mentorship, and then accordingly a referral system within the hub and spoke model will be established. Of course, after the program, during the program, technical assistance to the NTP for scaling up this program in the other parts of the country will be done. And we are trying to target mainly with the medical colleges also, because in the medical colleges there are a mandate which says that you need to open a TB unit. But many times what happens is that because of the complexity of things involved, it's a single room with few team being there, and it's not able to expand in all of the countries. So that is what we want to do. Of course, the drug supply and the lab investigations will be run through the government sector. For the NAT, as we all know, once the symptoms comes, the doctor, if at all sputum is available, sputum testing is done. But if the sputum is not available, according to the symptoms, the antibiotics are started, because of which even the left out chance of having a sputum is gone. And also because of being clinically diagnosed, there is no specific treatment, which is given. So hence, we thought that there is a need to scale up the NAT. Here, what we'll be doing is that existing labs with wherever NAT is available, which can be upgraded, will be noted down in the whole of the country. Lab preparedness and upgradation of those labs along with the so the infrastructure and the technical assistance will be given. Establishment of the hub and spoke model, where the other private and public facilities can refer their samples to these particular labs, that referral system will be established. Next is providing the private-public engagement. So with our experience on ground, we have got feedback that many a times what happens is that there are only few practitioners within, in the urban areas, and also even lesser in the rural areas, where they have an experience of extracting the samples. Even basic gastric lavage is not performed in many of the locations. So we plan to give this capacity building so as to enhance their skills and scale up of these networks in the rest of the country. The next three activities, firstly, the active case finding. So it's a portable X-ray with AI. So the mapping will be done, and accordingly, the X-rays will be done, and then the whichever positive patients are there will be associated with the NTP for the further treatment. The next is involvement of Ayush. As we know, India is a country where there are many, a very good percentage of the Ayush practitioners, and the patients, if at all they have a trust in the Ayush practitioners, will keep continuing to go there. So we need to build and try to take advantage of this system. So this is what we wanted to do. So mapping, engagement, and linking up with the neighboring MBBS clinics or major hospitals, and incentivizing this referral mechanism, and then accordingly trying to engage the Ayush as DROTS provider. Although this is being done in a very few districts in the country, we plan to scale it up in the many parts of the country. Lastly, the sample collection and transport. It's a Nikshay-based QR code system where the turnaround time from the time the sample is collected at the facility to the time that the reports are uploaded on Nikshay. So this will be tracked. So I do have a video. To save time, I will just share the link so that everybody can see. So thank you MSF for this opportunity, and I would like to thank the Central TB Division and ICMR for funding many of our projects. Thank you.
Thank you very much. We also want everyone an opportunity to ask questions to all the panelists. So I'm going to go to the last one, Dr. Kritika Dixit. And the most important one, not that others were not, but it's about the patient's perspective, because we are an organization that is kind of patient-centered. So over to you, Kritika.
Is it all right, or should I come?
Can you see the slides? That's what
that's all right. Yes, thank you. Good morning, everyone. I'm Kritika Dixit from Birat Nepal Medical Trust. Birat Nepal Medical Trust is a national NGO that has been working for more than 55 years in Nepal. And in Birat Nepal Medical Trust, we do active case finding. We also do social protection to support people with tuberculosis. And very recently, we are also doing studies on transmission of how tuberculosis is transmitted among the people. So just a brief introduction about the organization. And my presentation is mainly focused on the different costs that are unfortunately incurred for many people with tuberculosis in Nepal. And I would like to share what could be the potential strategies that we can use to mitigate such costs. So I would like to share a story of this young girl whom I met a few years back. And this story has also made an impact in my life. When I met her, she was undertaking her MDR TB treatment. She looked very ill, she looked fragile. And she shared that because of her TB status, she lost her friends. Her mom lost her job. And above all, she lost all her dreams and hopes to live a normal life again. So while this was like really difficult situation for her and as a person living with TB, she shared that the cost for her was very substantial and it was a major barrier for the TB treatment. The cost became catastrophic to her family, which they can never ever forget. And especially as Farhad, while she was introducing the panel, I think she also shared a very similar story. And I was wondering like how similar the situation is across the world. And so her family had to sell the cattle and their livestock to meet the need for her food, travel, and different medicines, which unfortunately people, they often spend out of pocket, despite we claim that the TB treatment is free of cost. And because this catastrophic cost, it's a known barrier for the TB treatment. There are poor outcomes. There is prolonged illness because of these barriers, and it also leads to death. So I think we are all on the same page in the sense that we want to end this catastrophic cost. We want absolutely no one to suffer from this cost. And the good news is that our national TB program is aligned with this, and the global strategy, the NTB strategy, also commits to end the catastrophic cost by 2020. And unfortunately, we have not been able to do so till now. So we need more accelerated efforts to do that, because even today, 1 in 2 people, they suffer from catastrophic costs around the world. So until a few years back, I mean, although we are committed to NTB, end catastrophic costs, but we did not know how many people or how many households they have incurred, they are suffering from catastrophic cost. Therefore, Virat Nepal Medical Trust, under Impact TB project, we mapped the costs along the TB, along the pathway of TB. And this is the first study that has ever been done in Nepal, where we are mapping the cost longitudinally. And in doing so, we also wanted to see if the active case finding, the novel strategy, was able to mitigate such cost. So we evaluated the cost at early treatment phases, and also towards the middle and towards the end of the treatment phase. So this study is published. You can also scan here if you want to see, or you can also talk to me after the session. So we found out that people with TB, they spend money throughout the TB treatment. And as you can see here in the blue color, 1/5 of the cost is incurred in the direct medical cost. So that means during the medicines, tests, and different diagnostic tests. And as my previous speaker also highlighted, that these are not covered by the National TB program. Therefore, people have to spend out of the pocket. And a large proportion in the green color, you can see here in the indirect cost, that is towards the loss of time and income that is required to access the TB treatment or diagnosis for people with TB. And there are also other costs that are associated with the TB. So there are other social consequences. For example, many people were unemployed by the time they were into second months of the TB treatment. 1/3 of the people, they reported to have food insecure. And we especially found that people who were diagnosed with active TB case finding reported that they were food insecure. And this is one of the reasons for this is that we were able to reach the most vulnerable group in our study population. And also 1 in 2 people reported that they felt poorer, or much poorer, as a result of this TB disease. So we can see there are other socio-economic consequences along with TB diagnosis and treatment. So how about the catastrophic cost? our study found out that there were one third of the households, the study population, they said that they incurred catastrophic costs. And good news is that we found active case finding was able to reduce the cost, and especially it was able to reduce the pre-treatment cost. That is, if people, we have often seen that people, they go to different pharmacies or private clinics where they get symptomatic tests, but not necessarily diagnosed of TB. So they incur lots of costs in that, and therefore active case finding helps to reduce such costs. Therefore, it's an effective strategy to reduce the cost. And active case finding is a part of this bigger picture where we can use it to address the socioeconomic consequences. But we know that we need more comprehensive strategies to mitigate this cost. And we need more people-centric healthcare models. We need more sensitive diagnostic tools. But also, more importantly, we need social protection to support people with TB. And as Dr. Madhavi and Dr. Anurag has highlighted in the morning, that how food support can reduce the incidence, reduce the mortality, and support to live people with TB. So Birat Nepal Medical Trust, we also have been piloting different interventions to develop locally appropriate social protection strategies, for example, by providing food support, by providing unconditional cash transfers. And we are trying to develop locally appropriate interventions by evaluating such programs. And the ration trial has been one of our go-to strategy where we have been supporting people with TB, and we are looking into weights, BMI, and looking forward to also study the treatment outcomes. So I have saved 2 questions for you, doctors, and I hope I can talk to you over lunch. Thank you. And then we need more evidence-based research to design such strategies. So we need more funds to do that. So at last, I would like to say that we need to accelerate our efforts to to support people with tuberculosis. There are social protection strategies, there are social insurance where we need to prioritize TB into the agenda. We need the TB priority in high-level meetings so that we can ensure that people with TB get the right support. And this is the girl whose story I was sharing before, and she is now a TB champion. She advocates to screen for TB and to early diagnosis and for the need of social protection. And she is a TB champion, and therefore I think if we all are together, then we can end TB. Yes, we can end TB. Thank you.
Thank you, Dr. Kritika. You leave us with a lot of inspiration. I would request if we could get Mike on the screen. We open the floor for questions. You heard a rich exchange of how globally the TB funding scenario looks like. You see how the global funding is being kind of spent, what are the priorities and different countries have different priorities, and there are some commonalities too. So I am looking around if there are questions. Yes, please take the mic there. Please briefly introduce yourself before you ask your question. Mic is not working.
So you see, almost all the speakers have highlighted that catastrophic costs continue to plague the TB. And in almost all the countries in South Asian region, we can see that majority of the patients do reach the private sector first and are treated by the private sector, despite best possible interventions from the government and all the stakeholders, including NGOs. We can see that, and whatever, the one thing which some of us instinctively feel that private sector wants to make money. That's not at all true. In all my interactions with private sector have been that they will be very much willing to treat TB patients almost free of cost if possible. But that interaction has to be supported. And we have to find more innovative ways of supporting those interventions. We have a discussion in the afternoon about public-private partnership. And this is my interaction across almost all my colleagues in India, Nepal, Pakistan, everywhere, that this can be done. Because there are sufficient areas other than TB from which private practitioners can make their money. That's not an area. And that's one thing which I wish that this is the right point to highlight. Thank you.
Thank you very much. We have One here and one there. Yes, please.
Thank you for this very interesting panel. I just would like to highlight one thing, that when we are ending TB, we have some existing tools for TB diagnosis and care which have to be effectively this thing. And I would say that the whole issue of strengthening of primary care services, especially for the poor and the underserved, should be a key intervention. Because Mike has highlighted the gap in the funding for research. But right now we are struggling with diagnosis and treatment as well. So when we talk of TB in isolation, actually active case finding is a good strategy, but it is not a replacement for strengthening of primary care services. So if we can align our things and see what is the gap there in strengthening primary health care, that would actually locate TB in a wider and with solidarity with other groups also.
Thank you. Please
Hello.
briefly introduce yourself.
Yes, I'm Sharan Gopali. I'm from Nepal, leading one of the NGO. Thank you all presenters. As the doctor has already rightly pointed out, most of the presenters here highlighted the importance of active case finding, and they have been doing active case finding from a very long time. My only concern is, I'm as one of the sub-recipients for the Global Fund. We are doing active case finding, bringing sputum samples from the hard-to-reach areas to the diagnostic facilities, designated diagnostic facilities. My only concern especially goes to Grant 7 cycle stays. Many countries already propose for the active case finding, targeting vulnerable population. What are the tools you are thinking to use optimum utilization of the diagnostic tool you are going to use for active case finding? My only point is, when we say AI or these all softwares, the calibration, that what we are facing in the Gene Expert, the calibration will be always a challenge if you need to renew the license, So what is the practice currently, like in Pakistan, in the Bangladesh, when you do sputum courier, what is the turnaround time for receiving the result? Because we always have a shortage of testing kits. Thank you.
Thank you very much. Would one of the panelists like to take about it? Yes, please.
Hello. Yeah. Okay. So I briefly explain our experience or our method of implementing the active case finding through chest camps. What we do is that, first of all, we have a system, a software, where we put certain indicators, like number one, the number of cases registered from that particular area in the last 3 months, then the poverty index, the literacy rate, and some other indicators related to that area. And the software generates that these are the available hotspots where we can organize the chest camp. So this activity is planned a month ago. And then a week ago, our team goes to that area. They visit the area, meet with the area notables, and tell them that we are going to organize a chest camp in your area, and this would be our mode of intervention. And then after a week, a mobile van with a doctor, a radiologist, and a gene expert technician. They visit the area, they organize a chest camp, the people come there. We screen mostly through chest x-ray, because we have the digital x-ray machines and CAT4TB software installed in the vans. Person go into the van, get screened through chest x-rays, get their scores. If the score is 70 or above, they go to the doctor examines, and then if the doctor says that this patient is presumptive and his or her sputum should be tested, we take the sputum samples on the field in that chest camp area, and since we have gene expert machines in the vans, the sputum sample are tested there in the same chest camp. So this is the methodology that we usually do. Once the patient is diagnosed, the patient is referred to nearby public or private health facility. It's upon the choice of the patient. And it's the responsibility of the field staff to register that patient in that health facility. Once the patient is registered into the health facility, then it's the responsibility of the concerning health facility staff to follow up with the patient for the next 6 months. Again, once the patient is registered, then our field staff visit the patient household within a week for contact screening, And if we find some symptomatic contact, we refer them to the same health facility for further diagnosis. If there is no symptomatic contact, then we ask them for preventive therapy. So this is the whole situation and whole modality we are conducting. Thank you.
Thank you, Dr. Adil. We will take one last question, but I just wanted to check if we have any questions online. One question online and one question we have Lena there in the audience. But before that, I would like panelists to think, what is that one last takeaway message you would like to leave us all with? So prepare your 30-minute speech of what you would like to share with all of us. Over to you, Huma.
Yes. So the online question is for Dr. Vaishali. So there's somebody asking about your working in Uttarakhand. As you know, Uttarakhand has a high incidence of TB and there are good unmet needs due to topographical situation in the hilly area. My question, please, can a private hospital in Uttarakhand collaborate with your NGO in diagnosis and care of TB care in Uttarakhand, and whom to contact? Thanks.
I just want to add one comment for the question asked for the diagnostics. In Mumbai, we have a successful pilot running for almost 5-6 years now, where a few of the, there's around a random number, say 25,000 X-rays. Vouchers are being given to the private practitioners when the patients are coming for checkup. Normal symptomatic patients are given these vouchers and they are getting the X-rays free of cost at the private facility. So it's a good access where the, again, as you mentioned, that the patient has that trust on the private, can go get the checkup done, but can get access to free X-rays through the government.
Thank you. Thank you. Lena. We can't hear you. Please use the mic.
Going back to the first presentation that Mike from TAG made, I just wanted to highlight that, the data is so critical to be presented to governments to show the shortfall in funding for upstream research, for vaccines, drugs, diagnostics, point of cares. And in some sense, one of the things that we could do in this region is to highlight the shortfall in upstream research to our organizations and governments in Bangladesh, in Nepal, and India, and Sri Lanka as well, because middle-income countries can also fund upstream research. And I think this is such a core thing that, the TB consortium of ICMR has proved. For example, the clinical trial that just funded for nutrition and of course, other areas. So I just feel that, we should come up with a strategy between all of us who are working in South Asia to present the data formally to governments about the shortfall in funding. So that's it. Thanks.
Thank you. Thank you, Lena. Let me give the floor to Mike. 30 seconds. What is that you would like us to leave with? I know the conversations are not going to stop here, but just to conclude like that.
Yeah, thank you. And listening to all the other presentations, what struck me was just the importance of the social interventions and thinking about community and the delivery of care. And it's one thing to develop these new tools like new drugs or one day a new vaccine, but they're meaningless if they don't reach people who need them. And I think what our funding data show is that the emphasis on TB research is really on product development, developing the new tools, and social science, delivery research, patient-centered research, community-level interventions, and research on that receives comparatively less funding. So as Lena said, when we're making the case to governments, I think we need to talk to them about more than just product development, but also about the social science and sort of the bigger picture in which research is conducted and making sure that it's connected to people who are beneficiaries of the science. So that's my final message. Thank you.
Thank you, Mike. And now is Thursday for you, I believe. So let's move on and actually start from that corner. Dr. Kritika, what's your takeaway message for all of us?
Yes, thank you very much. I think my main message is that there are financial barriers for people with TB. There are costs associated with it. So we need more appropriate actions to do that. And I think vaccine is one of the promising thing that we have to develop as fast as we can, because with that we can reduce the cost, we can reduce the income and the time loss, which are often underestimated. And we need to provide social protection protection for people with TB, because we know that when we are with the people, we cannot ask people to take medicines unless they have food to eat. So I think social protection is one of the key support that we need to provide. And yes, to do all these things, we need more funds. So yes, thank you.
Dr. Vaishali.
I would like to say that within the Southeast Asia or the South Asian region, all of us are at different pace. Like, Pakistan has, yesterday I was having a conversation where I think the BPAL regimen trial already was done, and there are a few countries who have not yet reached there. So we really need to have a platform like this where we can continue to learn from each other's, experiences, rather than investing time and money in the same thing which has been done by another country. So that would be really good to save resources. So yes, that's it.
Thank you, Dr. Ashish.
Yeah, thanks. So for me, I think health system strengthening is still the key component moving forward. And then it's supported by things like active case finding and all. But even in then, the reach that we had, 50% of the samples were still tested by sputum samples, even with active case finding. So having those rapid molecular tests, point of care, is very important moving forward, I think. On top of this, I think community system strengthening. We still don't, in TB, in HIV we have, but in TB we still don't have that community engaged actually in terms of planning and all, implementation, advocacy. So we need that group strengthened, and the country needs to support, and also Global Fund. I think we need to support those groups. And then finally, TB care and support. We completely are yet to strengthen on nutrition, as well as mental health part. That is totally untouched in terms of our context. So yeah, that's my message.
Thank you. Dr. Shyala.
Yeah, thank you. So my recommendation, I think two I can say. One is community system strengthening, and another is to strengthen the community people, and another is the government commitment for social protection, as TB is a huge burden still in the Southeast Asian countries. So I think each and every country's government should move forward under universal health coverage to support and secure the social protection of the TB patient as well as other people of the country. Thank you.
Dr. Adil.
Yes, thank you. I think the most important message that I like to highlight here is that if we want to end tuberculosis, not a single intervention will work. We'll have to choose different interventions based on the reality and the data. While designing those interventions, the most important thing is community engagement. We need to hear the voices of the communities, that how they want to be treated and what are their issues, and then we can design the interventions. Thank you.
Thank you very much. Not to put the spotlight, but we have Dr. Manisha here. She is the director for HIV and TB for SARC. So, Lena, to your question about should we have a more collaborative approach, I'm looking at not only Dr. Manisha, but many more to keep this conversation going. Thank you very much for all of you spending your time and attention in sharing what is happening in each country in South Asia, and also Mike giving us a global overview. So we do have many things that we can keep on continuing discussing, not only through the day, but in coming weeks and months, so that next time when we meet, next year, we are able to say what has changed. Thank you very much. Mike, your scarf is here with us. Whenever you are on this side of the world, we'll share it with you.
Sounds great. Thank you.
Okay. One or two little housekeeping things before we start the next session. People are talking sometimes in the room, which we asked you not to do because it's very distracting for the presenters. If you don't mind, you've got little notepads, you can write a message to your neighbour if you need to, or whisper, please. And the other thing is that because we have such a good turnout of people here in the room, we're not going to be able to have lunch just outside here. We're going to have to go downstairs to the coffee bar. There's 100 people here, apparently. So that's good news. The next talk, we have Mike still in the early hours of the morning in New York, who's already been introduced to you. You've just spoken to him. It's a talk on tuberculosis prevention, and he will be joined by Dr. Saeed Hassar. Dr. Hassar is a scientist at ICMR National Institute for Research in Tuberculosis in Chennai in India. So in this session, we're going to discuss the latest developments in preventive vaccines for household contacts of patients, along with a post-infection vaccine to prevent recurrence. Breakthrough findings in the clinical and preclinical development of TB vaccines have galvanized the field and suggest for the first time since the development of Bacille Calmette-Guerin, BCG, otherwise known as, that a novel and protective TB vaccine is on the horizon. Here we highlight the TB vaccines that are in the developmental phases and share the opportunities and challenges in conducting such clinical trials in developing countries. So this is an online presentation for Mike and Dr. Saeed, and both are here. Thank you very much.
Okay, great. Thank you. Let me just pull up my slides again. And it's great to join you on both Wednesday and Thursday in New York. So 2 days for me. What I hope to do with my presentation is give you an overview of the research that's happening for new TB vaccines to sort of set the stage for Dr. Hassar, which we'll talk about a more specific study that's ongoing in India. And so I'm going to give you a view of the pipeline, but I first want to put this in context of sort of the larger TB prevention landscape. So I'll be starting with an opening framework. I'll then go into the pipeline of TB vaccine candidates that are under development, and then I'll do a close-up look at several clinical trials and candidates that are receiving a lot of attention. And just to thank you for MSF for inviting me and for putting this on the agenda. Those of us who work in TB vaccines are getting lots of questions these days about the state of the research, how long is it going to take, what's going on. So this definitely seems to be a hot topic area. And just as we publish a report on TB research funding, we also publish an annual review of progress in the clinical development of new TB vaccines called our Pipeline Report. And this is also a resource that you can find on our website. So to start, I want to make the point that new TB vaccines will sit alongside many other good ways to prevent tuberculosis. And so research to develop a new vaccine for TB is not about developing a silver bullet. It's really about introducing a tool for prevention that will be used alongside other preventive tools. And we have a lot of good ways to prevent TB already. We have infection control in hospitals, clinics, families, and communities. We have preventive treatment, which is probably our most powerful biomedical intervention. In terms of short course preventive treatment regimens, 3-HP and 1-HP, which are now being introduced in South Asian countries and can prevent TB in as little as 1 month or 12 weeks. We do have a TB vaccine, BCG, which is very important for protecting infants against severe forms of TB, but not very good at protecting adolescents and adults against pulmonary TB disease. If you're living with HIV, ART is highly protective against TB, more so if you pair it with preventive treatment. And then I've been using this slide for several years, and when the rations trial published results, I added this last point about adequate nutrition. And we saw the data today, and clearly just the simple but very powerful act of supplementing household food budgets is highly protective against tuberculosis. And I agree with Dr. Bagava, who said that, adequate nutrition is the best adjuvant for vaccination and an adjunct to good TB therapy. And all of this depends on respect for human rights, human development, poverty alleviation, and health coverage. And so TB vaccines will just be an additional tool to a prevention landscape that already is quite crowded in some ways. So that being said, TB vaccines are still very important, and we won't end the TB epidemic without new vaccines. At the moment, there are sort of 4 overarching strategies for TB vaccine research, different goals that vaccine developers are pursuing and developing these vaccine candidates. And these strategies are known by acronyms that sort of signal the primary endpoint of interest. So we have vaccines that are being developed to prevent infection with MTB, and these are studies that we call POI, prevention of infection, clinical trials. We have vaccines that are focused on preventing TB disease, and those are called POD vaccines. I put a box around POD because this is really the focus of the pipeline, the idea being that modeling evidence shows that vaccines that prevent disease will have the greatest impact on driving down TB incidence and ending the epidemic over a certain time frame. We also have vaccines that are called POR, and this is prevention of recurrence. These would be vaccines given to people who have had TB before and been treated for it, with the idea of preventing recurrent TB, defined as either relapse or reinfection. And then the 4th strategy is somewhat related to POR. It's really a therapeutic vaccination approach. Some vaccines will be studied on top of, that is given together with TB treatment to see if they improve treatment outcomes. And those could be defined as treatment duration, the success of treatment in terms of cure, low risk of relapse, or perhaps even better post-TB health in terms of better lung function, clear chest radiography, and other outcomes of interest. So these are the overall strategies, but the central one is prevention of disease. So before showing you the pipeline of different vaccine candidates, I wanted to give you sort of the bird's eye view of where we are. At the moment, the clinical pipeline contains around 16 different vaccine candidates, and this includes 6 candidates that are either in or preparing to begin phase 3 efficacy trials. So it's actually a moment of great promise in the sense that we will have a lot of human efficacy data either soon or in a few years' time. And when I added up the size of all of the different phase 3 trials that are underway or about to begin, I got to over 80,000 people, participants who will enroll in these studies. And this is worth mentioning because I think it's a big number. It's the most people who have participated in TB vaccine science since the middle of the 20th century, when India conducted several very, very large studies of the BCG vaccine that involved, hundreds of thousands of people in Shingleput and other places in South India. And if you look at where the studies are being conducted, 28 countries on 5 continents have a registered TB vaccine trial of any phase. So it's truly a global endeavor. And these studies will provide us the opportunity to collect hundreds of thousands of participant samples that will be critical for TB immunology work, for adding to TB basic science, for helping us to find biomarkers. And not every study is diverse in the patient population it's enrolling, but we have studies that are being conducted in a diverse group of people at risk of TB, including people with HIV, children, household contacts, people with TB infection, and those without. So it's really, in some sense, quite a diverse pipeline in terms of the strategies, the trials, and the populations that are being looked at. So on this slide, I'm showing you the actual pipeline of TB vaccine candidates. The names of each candidate are in bold, and I've organized them by phase, from phase 1 to phase 3. The colors are showing you the type of vaccine that the candidate represents. So in yellow, we have viral vectored vaccine candidates. We have mycobacterial vaccines that are whole cell inactivated. And an example of that is the MIP or Immuvac candidate, which we'll hear more about. We have mycobacterial live attenuated vaccines in orange. In green are protein adjuvant vaccines, sometimes called subunit vaccines. And then in light blue, we actually have the very first mRNA vaccines for tuberculosis, which are being studied by BioNTech in 2 phase 1 clinical trials, one in South Africa and one in Germany, with some future trials planned. So what you can notice about the pipeline is that it actually is a little what we would call top heavy, in that phase 3 has more in it than phase 1. And normally in a clinical development pipeline, it would be the opposite of that. You would have a very large phase 1, and then as you move through the pipeline, it would get narrower and smaller. But at the moment, we have a pipeline that is really weighted toward the late stages, phase 2B and phase 3, which is both an opportunity, but also comes with some certain risks. In gray there, in phase 2B, the H56 candidate that is sort of grayed out, I grayed that out because the phase 2B trial of that candidate reported results in December. Those results were negative, and based on those, that vaccine is no longer being taken forward. So you can see that it's actually a dynamic field and things are changing quite quickly. On this slide, I'm showing you the same pipeline again, but just sort of highlighting some recent news of interest. I'll focus the news on the phase 3 candidates, so you can look there. The top 2 there, MIP and VPM 1002, these are 2 mycobacterial whole cell vaccines that are being studied in a clinical trial run by ICMR, and the next speaker will tell you more about that study. We think results are expected this year. I guess Dr. Hussar can confirm that. The third candidate on the list is MTBVac. That's another live mycobacterial vaccine. It's very interesting. MTBVac is actually Mycobacterium tuberculosis itself. It is the TB organism, and it has been made safe for human use and been made into a vaccine through strategic gene deletions, the deletion of 2 genes involved in MTB virulence. BCG is in phase 3. It's odd to have a 100-year-old vaccine listed in phase 3, but there is work underway to look at whether revaccination with BCG, that is giving a second BCG dose in adolescents, can prevent either infection or disease. And then the candidate that has perhaps generated the most discussion is the last one, M72 AS01E. And we'll look more closely at this, but this is a subunit vaccine initially developed by GSK, now being taken forward by the Gates Medical Research Institute and Wellcome Trust, and it's expected to start a phase 3 trial next month. So a lot of activity in the late stage pipeline. I want to give just a little bit more information on the VPM candidate. This is a live vaccine based on recombinant BCG. It was initially developed in Germany, but is now licensed to Serum Institute of India. And it's worth discussing because it's actually in 3 different phase 3 trials, and they represent 3 of those 4 overarching strategies. So there's the POD, Prevention of Disease study, that includes VPM, and the second candidate, MIP, that we'll hear more about in the next presentation. It's also in a prevention of infection study, comparing it to BCG among newborn infants in African countries, and it's in a prevention of recurrence study that's looking at whether it can prevent TB disease recurrence, and that study is enrolling in India and Bangladesh. So lots of work on the VPM candidate. This is just a schematic of that ICMR study. I won't say too much about this because we're going to hear more about it, and I'm hoping that all of the details I have on this slide are accurate, but we'll find out soon. Let's talk for a moment about M72 AS01E. So this is a subunit adjuvant vaccine. As I said, it was initially developed by GSK, and now the Gates Medical Research Institute is taking it forward. The reason we have so much excitement around this is because in 2018, the New England Journal of Medicine published results from a phase 2B study of this vaccine in Kenya, South Africa, and Zambia. And those results showed about 50% protection, 49.7% protection against developing bacteriologically confirmed pulmonary TB disease among participants who are HIV negative and MTB infected. So they entered the trial with a positive test for infection, but were HIV negative. So you can see from the results summary from the New England Journal paper that in the arm that received the M72 vaccine, 13 participants developed TB over 3 years of follow-up, compared to 26 participants in the placebo group. And that worked out to the estimated vaccine efficacy of just under 50%. And so based on this, which was really the first positive efficacy signal we had from a phase 2b study, there was a lot of excitement and the need to conduct a phase 3 trial. And the past 5 years, we have been patiently, and some of us very impatiently, waiting for this phase 3 trial to start. I'll show you what that trial looks like on the next slide. But in the interim, the Gates Medical Research Institute did 2 important studies. They completed a safety and immunogenicity study of this vaccine in 400 people living with HIV in South Africa. This study presented results at the Union Conference last October, and it had good safety in people with HIV, good immunogenicity, and based on these positive results, people with HIV will now be able to enroll in the phase 3 study when it opens. The Gates Medical Research Institute also started an epidemiological study, which was meant to prepare for the phase 3 trial, and it was really to generate local site-level data on IGRA positivity and TB incidence near potential trial sites, including in some countries represented in the room today, Bangladesh and India, and some other countries in Asia, including Vietnam and Indonesia and Philippines. So the phase 3 trial is expected to begin next month or in early April and open to enrollment. I've been told that some of the details of the study have changed since I made this slide last month. So don't be surprised if it looks maybe slightly different than what I'm showing you here, but this will give you the basic idea. It's going to be a very large study, up to 26,000 participants enrolled, randomized 1-to-1 to receive either 2 doses of M72 spaced 1 month apart or placebo. And this will be a prevention of disease study. So the primary endpoint is the prevention of pulmonary TB. They are going to enroll different populations. So the primary efficacy analysis will be among participants who are IGRA positive but HIV negative. But they're also enrolling a cohort of IGRA negative, HIV negative adults and adolescents, as well as 2,000 people living with HIV. And this study will be done in 7 countries, including Indonesia, Kenya, Malawi, Mozambique, South Africa, Vietnam, and Zambia. As I said, beginning very soon. And then I wanted to end with just a word about BCG revaccination, because I think this is something that we're hearing more and more about. And the reason that we're hearing about it is because around the same time that M72 published results in 2018, there was a second phase 2 study that year that published results that showed that BCG revaccination of South African adolescents had a vaccine efficacy of around 45% in preventing infection. The infection was defined as sustained IGRA conversion, and this is a detail worth paying attention to. So that was an initial conversion from negative to positive on IGRA that stayed positive at subsequent testing 3 and 6 months after the initial conversion. This, however, was a secondary endpoint. It wasn't the focus of the trial. And so there was a need to sort of confirm it in a larger study. And again, the Gates Medical Research Institute decided to do the follow-on study. They've recently completed a phase 2b study to evaluate BCG revaccination. And the table on this slide compares the initial trial in the before column with the current study in the now column, just showing you that the study they're doing now is larger, sort of about double the size. It's a slightly wider age band. The initial study was at a single site in South Africa, and this other study is at multiple South African sites, and sustained IGRA conversion is now the primary endpoint rather than a secondary one. And my understanding is that this study has results which will be presented at a conference called Keystone, the TB Keystone Conference in March. And we should have data on BCG revaccination from this study very soon. This is what it looked like. This new study, about 1,800 adolescents randomized to BCG, a second dose or placebo, work done in HIV-negative adolescents. There was recently a commentary published in Lancet Respiratory Medicine about what's next for BCG revaccination, sort of trying to anticipate how do we respond to the results of that study, whether they're positive or negative. Do we need to conduct a phase 3 study to see if BCG can prevent disease? Or is it enough to say, okay, if it works, let's start offering a second BCG vaccine dose? Should we consider another option, like evaluating BCG revaccination, not in a trial, but in a well-designed programmatic rollout? And then, of course, the question what to do if results are negative. So that paper is available to read if you're interested in thinking through what some of the alternatives are. So with that, I'll just say thank you again, and really looking forward to hearing the next presentation and to taking any questions people have about TB vaccine research at this moment of real promise and excitement. Thank you.
Thank you, Mike. Very comprehensive. I hand over to Dr. Saeed now, please.
Thank you very much. Good afternoon. I will just share my slides. I hope you could see my slide and you can hear my voice.
Just to put them in presentation mode, maybe, or click on the first one. That's great, thank you. And we can hear you very well.
Yeah, thank you so much. Myself, Dr. Syed Isar, representing ICMR, National Institute for Research in Tuberculosis, which is a premier institute dealing with research in TB.
Dr. Syed?
ICMR.
Sorry, your slides are not in presentation mode. It's showing the whole PowerPoint.
Now?
Not yet. Maybe click on number 1 and it comes up.
No, it's showing to me in presentation mode.
Ah.
Can you share the slides? I have already shared the slides.
Press F5 is a recommendation from here.
Okay.
Sorry, you have to stop sharing and then press F5. And then put it in slideshow and then share it. Thank you.
How about now?
Not yet, no. Stop sharing, F5, and then put it in slideshow and then reshare, if I understand correctly. Oh, we can do it. Sorry, we can do it. We have the PowerPoint. But you need to stop sharing, please, Dr. Said, so that we can share it. Thank you.
Full window.
Thank you. Thank you for that. Now we can share it from our side, I hope. And there we go. Can you see that, Dr. Said? Dr. Said?
Is it okay?
Yeah, it's perfect. Can you see it? I think you can start your presentation, please. Dr. Said, can you hear me?
Let me know if you can see the slides.
Yes, we can see the slides. Sorry, we can see the slides and we can hear your voice. Please start with your presentation. Thank you. Dr. Syed, can you start, please? Speaking, I mean, we can't hear you at the moment if you are speaking.
Yeah, please. Thank you. Can I proceed with?
Dr. Syed, we can hear you, but can you please start the presentation?
Yeah, thank you so much.
Thank you, thank you.
Can you see my slides?
We can see the slides, yes. Thank you.
Okay, okay, thank you. So, thanks for the invite, and I'm going to just focus on the challenges in the conduct of TB vaccine trial in India. So, as we heard from the past speakers, it is very crucial that we have new tools of vaccine, new drugs, as well as tools for diagnostics, which will help us in accelerating the elimination of TB burden. So phases in vaccine trial, we have phase 1, phase 2, phase 3, and phase 4. We are going to deal with a phase 3 study, which is ongoing. So steps in conducting the vaccine trial is development of protocol, identification of collaborators, regulatory approvals, and getting local IEC approvals and CTRA registration. This is prior to initiation of the study. Then second part is preparing the sites and stakeholders, that is stakeholder sensitization, preparation for trial conduct, and begin with recruitment. And the most difficult part of the vaccine study is retention. As you all know, we are dealing with asymptomatic and apparently healthy individuals from the families. So it's very difficult to have retention of these participants over a period of time of follow-up. Then comes very crucial closeout and managing the data and generating the report. So coming to the TB vaccine prevention trial, VPM 1002, Imuvac vaccine in prevention of TB. Efficacy of VPM 1002 and Imuvac vaccine in reducing the incident TB cases. It's an design of randomized control trial. As already told, we have 3 arms. One is VPM 1002, Imuvac, then placebo. This is a double-blind study, and we have a gracious sponsor from ICMR, that is a consortium. The sites are spread all over India, from Tamil Nadu, Telangana, Mumbai, Odisha, New Delhi, and Karnataka. The target population is healthy household contacts of new smear positive pulmonary tuberculosis. The incident TB cases from 2nd to 38th month after the vaccination is taken as the outcome and would be analyzed. The total sample size is over 12,000, and we have now completed the recruitment into this trial in 2020 December, and now the follow-up is ongoing. So I am just presenting the our own experience from Tamil Nadu with respect to TB vaccines trial. So you could see we have around 5 sites spread across Tamil Nadu state, wherever our presence is there. So to go on, the preparatory activities for conduct of vaccine trial, we started with capacity building, mapping of DOT centers and TB patients, preparation of SOP, standard operating procedure, to deal with the participants as well as the trial related SOPs, training of the study staff, meeting the National TB Elimination Program staff, who are the backbone for conducting TB vaccine study in this, and to keep the infrastructure in place, trial conduct equipments, refrigerators for the vaccine, then computer, chat table, and handycam for consenting process, etc. So this is the template of mapping of DOT centers and TB patients across the TUs. So this is how the mapping was done. So to start with, each we formed a very large team. This is one of the centers teams, how we focused on each team to be responsible for some of the TUs and devotee centers. So we allocated staff members as well as the staff scientists who lead them in each area, as well as the project staff who would help. So if a particular TU is there, so from starting from mapping of the TB cases, then participants mapping, from then enrolling the participants, then keeping them on follow-up and fail to attend attendances, everything is maintained by that team, and team is led by a scientist. So this is the training of study staff we undertook when we initiated the study. And the main, as I told, the backbone of the study is NTP staff who are really collaborating with us in getting the details of TB patients and their whenever they are getting diagnosed. So we are meeting with NTP staff and explaining about the study and capacity building them, and meeting with the NGOs. Then since we are going into the community, we also engage the community. So as to when we started our study, we really had some initial phase of period where we couldn't enroll participants in necessary numbers. So we had put down some efforts to increase participant recruitment in this vaccine trial. There are expansion of sites and TUs. So initially we had Chennai with 36 TUs, then we added up with Tiruvallur with 14 TUs and adjoining 5 TUs, and Madurai district 21 TUs, and Tambaram 4 TUs, and Vellore 14 TUs. Thus, we had another challenge. We were covering a wide geographic area. That is one challenge we had by expansion of sites and TUs. Second, we increased the index case identification. So our field investigators who are recruited were given tasks to daily line listing of TB cases, index cases who are started treatment for tuberculosis or diagnosed with tuberculosis. Then we created WhatsApp groups in each district so that all NTP staff as well as the NIRT, ICMR, NIRT study staffs were put into that. So whenever a message comes into that WhatsApp from a given TU, the subsequent ICMR staff will take note of it and follow it up with those participants. Then we also got the list of TB initiated index cases list from the DTO office in time to time, so as to verify whether we are covering all the TB cases from this geographical area. And also the diagnostic reporting labs also contacted for those things. Third one is to reduce the refusal in household contacts. We took the help of our field investigator as well as medical social workers and medical officers to put extra effort, and we had all the posters and flyers and FAQ flip charts were used so as to convince them to be a participant and to take benefit of this trial. And also we offered them convenience of participating in this trial, like screening and follow-up to be done in weekends during which mostly our clinic is off, but we opened our clinics in weekends to have these patients for screening as well as for the follow-ups. Lastly, we had efforts efforts taken during the COVID-19 lockdown. Yes, we had a lot of challenges during those time, which is transport, fear of coming to the hospital, staff going into a COVID positive positivity, then concomitant zones were notified. Then we couldn't have the participants followed up. The efforts taken were transport services to household contacts were provided and strengthening was done. So these were the WhatsApp groups which had district-wise, where the NIRT project as well as the permanent staffs were involved and were added into it, and NTP staffs were also added, and whenever they happen to diagnose or initiate the treatment, they normally put a message, and the study team will follow up and further recruit the participants. So these are the posters and flyers, flip charts, FAQs, which we used during the study enrollment as well as follow-up. So you could see the month-wise screening and enrollment across NIRT sites. As I mentioned, the initial days we were struggling to enroll the participants. Then we had some augmenting method of having a WhatsApp group and having line listing of all the index cases and getting the participants into the clinical trial. And side by side, we also plan to initiate our own existing sites, you could see. But altogether, the study came to a stall when lockdown was announced, and we had around 2 months without much activity during COVID-19. But we got back again with the initiation of more sites, and you could see around October we had maximum enrollment, and we completed our enrollment in December 2020. So this is our recruitment completed status with 2,723 household contacts were screened, and 2,214 contacts household contacts were enrolled as participants in this study. So coming to the last part of my presentation, the retention of participants in vaccine trial follow-up. As I told, this is a very cumbersome thing because we are dealing with asymptomatic and apparently very healthy participants. So the strategies for retention of participants we had is track follow-up appointments. We had beforehand all the appointments in an Excel sheet as well as put down in a notebook for the each individual teams. Ensure participant attends clinic for scheduled follow-up visits. We try to avoid missed visits as well as loss to follow-up due to the time which we would see. Then monitoring of follow-up visits, whether they are they have come to the visit or not come to the visit, and what are the next steps to be taken, and the periodic phone calls which is normally done in the study and taken care for the follow-up visits to be scheduled. Then lastly, the periodic study review meetings happened within each site on daily basis, as well as all the 5 sites we tend to have weekly meetings also. So this is tracking of follow-up appointments. We put down everything in an Excel sheet, and we track down and track all the follow-up, keep track of patients, and the hard copy is maintained by the individual teams so that they don't miss any participants in follow-up. Then this is a fail to attend notebook we have, where the patient couldn't attend a scheduled follow-up and rescheduling has been done so meticulously, which is normally done and captured in this notebook, and then all this data is again captured in the Excel sheet so as to complete the process. So this is the phone calls to participants made and made a note of it and filed in the participant. Any one of the investigator who is in charge can see how many attempts were made and what is the next he or she can make. So this is a weekly team meeting on Zoom platform. We had across our 5 sites. Every week we used to meet so as to discuss what is pending for this week scheduled visits, and what are uncovered failed to attend visits, and what is the action taken for the last meeting. So everything is discussed and made in minutes and given to the teams, so that the next week they try to comply and complete the follow-up visits. At the same time, as I told, the NTP staff are the backbone, and we had a very good linkages with the NTP program and study participant recruitment, starting from the recruitment to the last follow-up. We are in touch with the NTP program staff, and the support if required in retrieval of study participant. We approach them for management of household contacts with TB breakdown, as well as index case management. We discuss with the medical officers, and also we give feedback on our study status regularly. So this is the linkage with the NIRT and NTEP staff. So apart from having the WhatsApp groups, we try to be there in their monthly meetings happening once in a month to brief about our study, as well as to get their support. So these are some of the challenges we had, and we tried to overcome with our own things, and like not picking up the call for 3 weeks. So we tried to attempt a home visit to the participants, and when the participant is when participant is located in a very distant area, when they refuse to come, the visit, we try to visit the participant home and do the chest X-ray at the nearby healthcare facility. Then planning of follow-up visit, as I informed, yes, it is meticulously planned, and having a meeting with the study staff on daily basis, and all other sites with the PI and clinic sites on a weekly basis, so as to have a overall follow-up retention is maintained at over 95 or 98%. So the participant, the next issue we faced is participants shifted to other places due to death, or due to work, or due to other reasons. The migration is happening. With the help of other sites across the Tamil Nadu, we have our presence in 2-3 districts, 3-4 districts. So we approach them and we transfer the case sheets for the completion of follow-up. Then we take efforts to establish contacts with the participants' relatives, and try to give them reimburse them the travel assistance for the clinic visit if it is they have relocated very far. Then if it is not possible, then we offer investigation to be done from nearby lab and communicated to us. Then the main issue is patients not willing to participate in the study during the study, like I am healthy, busy with my work, students going for exams. So all this, like, you need to have a very good counseling process, find them and schedule them in a good timing. For example, busy working person or a student having exam, you schedule them after exam and on Sundays or early visits, etc. So we try to find out the reasons and schedule them a convenient weekend clinics. So if they refuse to take the calls, first visit is made by health visitor, the second visit is made by the medical social worker, and third visit made by the doctors, and then at the end the issue is brought up in the clinical review meeting. And next is when the participant got married and the participants parents doesn't want to reveal to anybody, and they say they have relocated and married, and she may not be able to come to the follow-up. So we approach the parents again to retain the participants. We do the phone call with the help of the participants' parents, and we establish contact with the participant and make sure whenever they come or nearby lab, we take the investigations done for them. Another thing is the issue is index patients. See, normally the index patient care is given in the program. So we take an extra effort so that we make sure that the index case is taken care well, and if nutritional support is not provided or they need any support, we try to provide from our end. And counseling the participants is very important in the case of a death of the index case, because they tend to say our relative who is a TB case is dead, so why should we follow up with you? So it's not necessary. So we need to give them the importance of this study, and counseling plays a very important role to keep these participants in regular follow-up. Then coming to last, the participants getting annoyed and angry over repeated phone calls, we give them a break for 2-3 weeks and counsel them importance of the participation again, and we keep them on board. So you see that retention is a very difficult process, and for this 3 things are main thing. One is establishing a contact and maintaining the contact. 1. 2 is giving an adequate counseling at every visit and every contact of the patient. And 3rd, do possible help to all the household contacts as well as the index cases, whatever they are expecting, so as to retain their follow-up. Thank you. Thank you for patience listening.
I don't think you showed the last slide there, Neha. Oh, sorry. I thought there was one before that. Thank you very much. Thank you very much, Dr. Syed, and we really appreciate you stepping in at short notice. That was very, very, very helpful. Do we have any questions in the room or online for Mike Frick or Dr. Syed, please? Yes, we do. Sorry, could some, yeah. There's actually a microphone on that table as well. Thank you.
In the protection against tuberculosis, we know that cell-mediated immunity is of critical importance, and these vaccines are probably going to ensure T-cell responses. Now, we know that underweight people can generate antibody responses, but it is well known that T-cell responses are muted in underweight individuals. So while we are seeing this pipeline now, in a population with significant prevalence of undernutrition, again, we may find that they are not acting to their potential. And that is one of the reasons why BCG was supposed to be not that effective in India compared to other countries in the world. So we will still have to consider public health interventions along with vaccines to ensure TB prevention. Even to ensure the efficacy of these vaccines, we'll have to address these risk factors in our population.
Thank you. Are there other questions or comments from anybody? Or online? Is Dr. Homa there? No? Okay, I think that means for now we're going to say thank you very much to Mike. You can go to bed now. You have our permission, and thank you very much for staying up so late. And Dr. Syed, thank you so much for joining late. It would have been lovely to have you both here in person, but anyway, thank you. Thank you.
Next time. Thank you very much.
Okay, for the room, we have lunch now, but we have lunch downstairs in the coffee bar. Before you leave, you will get lunch if you have your tag on from registration. If you don't have it on, I'm afraid they won't make MSF pay for the lunch. So please do wear your registration tags. Coffee shop is on the first floor. We're on the second floor, so you just can go down the stairs. And we're back here at, what exactly? When are we back? 1:30. We're back here at 1:30. Thank you very much, everybody.
Hello! This amazing little plastic box that can fit in your pocket has helped to save many people's lives by getting them on the right life-saving treatment quickly. We use it every day in Doctors Without Borders to diagnose people with tuberculosis, HIV and hepatitis. This magic box is a test cartridge for a machine called GeneXpert. It uses PCR. You remember those tests, right? Let's take a closer look. It's not that complicated. So here is the lid. It opens to add the sample here. A reagent chamber. Here inside for storing the reagents. And here is where the plunger from the machine takes the sample and mixes it with the reagents. And finally, where the magic happens, here is the reaction chamber. The patient's results are then displayed on the GeneXpert machine, and presto! We know the answer to a critical question: does the patient have tuberculosis or not? And if so, is it drug-resistant tuberculosis? This is very simple, but we are finding some of the math around this cartridge a lot harder to understand. Cepheid, the corporation that makes these cartridges, charges $10 for a tuberculosis cartridge when it costs them less than $5 to make it. That's double the cost, making it unaffordable for people in many parts of the world where tuberculosis is one of the leading causes of death. And that means many people get sick, but they can be tested and get the medicines that could save their lives. We think this is really bad math from Cepheid. Bad math that is costing millions of lives. If you think this is as puzzling as we do, call on Cepheid to drop the price of the GeneXpert cartridge to $5 to save more lives. Cepheid, it's time for 5.
हमारे सब घर वाले रोने लगे जब मुझे उल्टियाँ आईं खून की, तो मुझे सब कहते थे अपने इसने बचना। मेरी तो उम्मीद बिल्कुल ख़त्म हो गई थी कि हमारे घर में पहले एक वाक़या इस तरह हुआ है।
मैं 2 दफ़ा इलाज करवा बैठी हूँ, तो मुझे नहीं फ़र्क पड़ा अब यहाँ से क्या हो जाएगा। मैं बहुत परेशान भी थी और मैं रोती भी बहुत थी।
MSF is a place for everyone and treats everyone, irrespective of your culture, irrespective of your ethnicity, irrespective of your color, irrespective of your race. So MSF do not discriminate because there is beauty in our diversity.
तकरीबन 70 से ज़्यादा ममालिक में MSF इंसानी फ़लाह बहबूद की खिदमात को सरअंजाम दे रही है। MSF पाकिस्तान में 1986 से काबिल कदर की खिदमात सरअंजाम दे रही है।
इनिशियली जब पेशेंट आता है तो ही हैज़ टू अंडरस्टैंड कि डिजीज़ है क्या। अंडरस्टैंडिंग ही उसको कंप्लायंस पे उसको अडेरेंट करेगी।
हमारे प्री असेसमेंट सेशंस होते हैं। प्री असेसमेंट सेशंस में हम लोग पेशेंट को एजुकेट करते हैं, उसके साथ रेपो डेवलप करते हैं और उसकी जो नीड असेसमेंट्स हैं उसको आइडेंटिफाई करते हैं। उसके बाद जब वो ट्रीटमेंट के ऊपर आ जाते हैं तो फिर पोस्ट इनिशिएशन सेशंस होते हैं जिसमें हम आइडेंटिफाई करते हैं कि हाउ थिंग्स आर गोइंग, मेडिसिन उनके साथ कैसे चल रही है, उनको कोई साइड इफ़ेक्ट तो नहीं आ रहा और उनकी लाइफ में क्या चेंजेस हैं या वो किस तरह से अपनी इस ट्रीटमेंट जर्नी को साथ लेके चल रहे हैं। सो एक पेशेंट, दूसरा उनकी फैमिली, तीसरा जो है वो हमारी मेडिकल टीम, तो ये सब मिल के जो है वो इस जर्नी को लेके चल रहे होते हैं।
The multi-drug resistant TB is a type of TB that a patient is being infected with a strain of bacteria that is resistant to the 2 key drugs in treating TB, which are rifampicin and isoniazid. And now with the GeneXpert diagnostic tools, these patients are easily identified and started on treatment. This treatment is a bit difficult because the patient would have to consume nothing less than 10 medications for a period of 9 to 24 months, which is a bit difficult for any normal human being to be taking in their lives.
हमारा मकसद है एक इंसान को ट्रीट करना, तो एक इंसान में मुख्तलिफ चीज़ें भी हो सकती हैं। ही कैन बी डायबिटिक, ही कैन बी हाइपरटेंसिव, तो हमने उन सब चीज़ों को एक साथ लेके चलना है और अपनी जो मैनेजमेंट प्लान है उसको मॉडिफाई करना है। ज़रूरी नहीं कि अगर हमारी गाइडलाइंस में लिखा है कि पेशेंट ने बाई वीकली फॉलोअप पे आना है इनिशियल 2 months में, तो ही हैज़ टू कम बाई वीकली फॉलोअप। हम उसको मॉडिफाई कर सकते हैं डिपेंडिंग पेशेंट, ताकि पेशेंट पे जो डिजीज़ का बर्डन है वो कम हो सके। We have registered 161 drug resistance confirmed DRTB patients. Among those patients, we have successfully treated 8 patients till date who have completed, who are bacteriologically fine, clinically fine and radiologically fine, and they are being followed up also. We also have 6 patients who are about to complete within the 2 weeks. MSF free of cost treatment दे रहा है। यहाँ पर आप जैसे पेशेंट एंटर हो जाता है उसके बाद उसने कुछ भी पे नहीं करना, हम उसको एंट्रेंस से ही हम ऑन कर लेते हैं। इनका एडिशन टू सोशल सपोर्ट हम न्यूट्रिशनल सपोर्ट भी पेशेंट्स को प्रोवाइड करते हैं, जो कि लो वेट होते हैं, जिनको ट्रीटमेंट के अलावा इस चीज़ की ज़रूरत होती है क्योंकि इम्यूनिटी बढ़े।
सिर्फ रजिस्ट्रेशन करने से, पेशेंट का ट्रीटमेंट करने से ये बीमारी जो है वो ख़त्म नहीं होगी। हम जो है उसके घर जाते हैं, घर जाके उसका होम असेसमेंट करते हैं कि घर में कितने लोग रह रहे हैं और जो पेशेंट है उसके पास सेपरेट कमरा मौजूद है रहने के लिए या नहीं मौजूद। फैमिली की एजुकेशन करते हैं टीबी के हवाले से कि टीबी क्या है और ये कैसे फैलती है और इससे बचा कैसे जा सकता है।
So the good news is that now we have a shorter regimen in treating multi-drug resistant TB, which consists of just 4 to 5 drugs for a duration of just 6 months. So this is more cost effective.
वो हमारे दर्द में सारे वो 1 साल इक्वल होते हैं। वो कहते हैं अब आप भूल जाओ कि आप बीमार, अब आप ठीक हो जाओगे। तो आधी बीमारी तो पहले ही ख़त्म हो जाती है, आधी मेडिसिन से हो जाती है।
मेरा इनके साथ दोस्तों के साथ जैसा रवैया है, बहुत ही प्यार से अच्छे से फॉलो करते हैं। जो सा डॉक्टर ने मुझे बताया मैंने वही रूटीन फॉलो की है, टाइम बोला वही टाइम पे इस्तेमाल की है, मेडिसिन नहीं छोड़ी, क्योंकि दिल करता है बंदे का मेडिसिन छोड़ने का, इसहत होती है शुरू शुरू, लेकिन नहीं, मेडिसिन नहीं छोड़नी।
ये ना सोचा करो कि पता नहीं मैंने अब बचना ही नहीं है, मुझे क्या हो गया, नहीं, तुम ये सोचो कि मैंने जीना है, अपनी अम्मी के लिए, अपने अब्बू के लिए, बच्चों के लिए खासकर मैंने जीना है। ये कि इन्होंने बहुत मुझे हौसला दिया है, तो अल्हम्दुलिल्लाह अल्हम्दुलिल्लाह मैं बहुत ठीक हूँ।
इंसानियत की जज्बे के तहत काम कर रहे हैं ताकि टीबी का जो नासूर है, जो थर्ड वर्ल्ड कंट्री का बहुत ज़्यादा एक इशू है, उसके अंदर ये हमें बहुत ज़्यादा हेल्प कर रहे हैं एंड दे आर वेरी सीरियस एंड डूइंग द स्टेट ऑफ द आर्ट वर्क। और इनकी जो काविशें हैं मैं उनको सराहता हूँ।
Mumbai has a huge load of tuberculosis patients, and we have around 14% contribution at the national level as far as drug-resistant tuberculosis is concerned.
Since the goal to end TB is by 2025, we have got this 5-pillared strategic plan for Mumbai. The first pillar is search.
Search means patients जो hidden है, community में है, उनको एक्टिवली या पैसिव तरीके से ढूंढना।
The second is detect. So in detect we are giving upfront CBNet services to every patient.
मान लीजिए एक्स्ट्रा पल्मोनरी टीबी है तो उसको प्राइवेट लैब में, एंगेज प्राइवेट लैब में फ्री में सोनोग्राफी, सीटी स्कैन, एमआरआई ऑफर किए जाते हैं।
In treat we are having free drug access to each and every patient in Mumbai, whether it is public or private.
एकदम एडवांस ड्रग्स भी अवेलेबल है, जो न्यूअर ड्रग्स है, डिलामिनेट, बेडाक्विलिन, वो भी अवेलेबल है। तो वो गवर्नमेंट के नेशनल टीबी प्रोग्राम के जो पीएमडीटी गाइडलाइन के वो हिसाब से ट्रीटमेंट दिया जाता है।
Fourth is prevent. As you all know that TB is an airborne disease with particulate matter going in the air. So air infection control is the must to prevent this disease.
हर इंस्टीट्यूशन, हेल्थ इंस्टीट्यूशन AIC कंप्लाइंट है क्या? ये MSF की मदद से हमने हर इंस्टीट्यूशन का AIC असेसमेंट किया, रिक्वायर्ड चेंजेस करवाए उसमें, प्रोवाइडिंग मास्क टू द पेशेंट्स, मास्क टू द हाउसहोल्ड मेंबर्स, प्रोवाइडिंग स्पूटॉन्स टू द बेड रिडन पेशेंट, ये सब प्रिवेंट के अंदर आता है।
And the fifth pillar is to build.
Build यानी अलग अलग पार्टनरशिप बनाना, मल्टी सेक्टरल कोऑर्डिनेशन करना।
So there is an engagement between 3 parties over here, that is NGO as an MSF, private chest physician, myself who is dedicating my expertise and skills over here under the premises of a government sector, that is BMC run hospital. So this model is really unique in itself, which we had implemented here in Mumbai since 2015 onwards.
पेशेंट को हर जगह जाना नहीं पड़ता है। उसमें काउंसलिंग, ब्लड इन्वेस्टिगेशन, डिस्पेंसिंग ऑफ मेडिसिन, कंसल्टेशन, देन लैब टेस्टिंग, सैंपल कलेक्शन, एवरीथिंग, सब चीज़ें एक रूप के अंदर होती है और इसकी वजह से ट्रीटमेंट इनिशिएशन बहुत फास्ट होता है। और हमको ये मालूम पड़ा कि दिस इज़ ऑल्सो नॉट इनफ, ये भी सफिशिएंट नहीं है। तो और भी DRTB साइट्स प्रोग्राम ने पिछले साल से 2 साल से चालू किया है।
So this outreach model serves as a aspect of being closer to the community. It's patient centered. The traveling time for the patients to visit the center for their consultations is reduced. These services also serve as a one-stop shop for their DRTB needs in terms of doctor consultation, counseling, pharmacy, and biochemistry needs like ECG and blood tests.
Plus, we are starting some of the polyclinics also, where we will have consultants coming into the dispensary, ophthalmologist, ENT specialist, then we'll have dentist, we can have skin specialist, chest physician, and so on, as per the requirement from the community. So definitely it will help us to decentralize the tuberculosis management of all the patients.
ये PPSC एजेंसी में पेशेंट्स को, TB सस्पेक्ट्स को चेस्ट एक्सरे, जीन एक्सपर्ट और इतर सारी डायग्नोस्टिक सुविधा फ्री में उपलब्ध की जाती है और ड्रग्स सेंसिटिव पेशेंट्स को ट्रीटमेंट केमिस्ट द्वारा फ्री में उपलब्ध की जाती है। ये अगर एजेंसी द्वारा कोई ड्रग रेजिस्टेंस TB डायग्नोस हो गया तो उसको पब्लिक सेक्टर में लिंक किया जाता है।
And into that, as per this scheme, many respondents are coming in, various NGOs, they are coming forward and helping us in this PPSS scheme.
बहुत सारे पेशेंट्स हैं, माइग्रेटेड पेशेंट्स हैं, तो माइग्रेशन की वजह से उनका एडरेंस का भी इशू हो सकता है। लेकिन अभी एक निक्षा पोर्टल जो है उसमें नेशनल लेवल का डाटाबेस बना रहता है। सो मेरा पेशेंट अगर UPP में गया तो भी वो ट्रेस हो सकता है।
हम उनको दवाई देते हैं PHA लेवल पे, तो कुछ भी ADR हो उनको तो हम उनको ट्रेस करते हैं। HV के थ्रू हम उनको काउंसलिंग करते हैं, टीस काउंसिलर्स है तो उनको काउंसलिंग करते हैं और उनको दवाई पे वापस लाने की कोशिश करते हैं।
और एक दूसरा अलाउंस है निक्षा पोषण योजना, उसके अंतर्गत पेशेंट्स को हर महीना 500 रुपया न्यूट्रिशन के लिए दिया जाता है। वो पेशेंट के अकाउंट में डायरेक्ट बेनिफिट ट्रांसफर द्वारा दिया जाता है।
In Mumbai, a new initiative has been started under this BPAL study. Into this, 3 drug regime is prescribed: bedaquiline, pretonamide and linezolid. And the characteristics of this regime is that it's shorter duration regime, only for 6 months. Then it is given orally and it is freely available.
दवा खाने से ज़्यादा लोग मतलब दवाई खा के ठीक हो रहे हैं, तो ये बहुत अच्छा है, क्योंकि उस दौरान इंजेक्शन के टाइम पे तो बहुत सारे साइड इफेक्ट भी होते थे, तो वो सब बहुत तकलीफें होती थी।
अब के डेट में सरकार ने बहुत अच्छी रूल निकाल दिया है कि दवा भी देते हैं, साथ साथ में घर में भी डॉक्टर आते हैं और वो पूछते भी हैं कि कैसे हैं कैसे नहीं हैं।
मेन फोकस अभी गवर्नमेंट का TB प्रिवेंटिव थेरेपी। जो एग्जिस्टिंग पेशेंट है जिसको हम इंडेक्स केस कहते हैं, उसके जो हाउस होल्ड कॉन्टैक्ट्स है उनको स्क्रीन करके उनके अगर TB पाया गया तो पूरा TB का ट्रीटमेंट, और TB नहीं पाया गया तो उसको TB प्रिवेंटिव ट्रीटमेंट देना। ये प्रिवेंट में सबसे बड़ी स्ट्रैटेजी है। डिफॉल्ट रेट जो है एक ज़माने में 20 या 22% था, नाउ इट हैज़ कम डाउन टू बिलो 7%। स्टिल incidence should come down and it should come down at a faster rate so that we will be able to control it before 2025.
So if you really want to win a battle against tuberculosis, all these 3 sectors need to come together and get collaborated together and fight this battle and win this battle.
Apart from whatever government is doing, we really need to have more number of partners to reach for this elimination of tuberculosis and to cut down the transmission in the community.
Tuberculosis is a disease that claims the lives of over 2 million people a year. As things stand, low to middle income countries account for around 80% of all TB cases, and it's a public health crisis that's deeply rooted in inequality. Central to this is multi-drug resistant tuberculosis, or MDR-TB, a strain of the disease which doesn't respond to an initial course of antibiotic treatment. For a person with MDR-TB, existing treatment plans could run for up to 2 years and take a real toll.
What is quite clear with MDR-TB is that sometimes the treatment itself is worse than the disease. The outcomes were not acceptable.
So, what did we do about it? We set out to establish a treatment plan which was shorter, safer, more effective, and with fewer grueling side effects. The 6-month drug regimen that won out was BPAM, and it resulted in a huge reduction in symptoms and side effects. Not only is the treatment shorter, but on balance, much more bearable, going from up to 20 pills per day to around 7. What we saw was a marked improvement in terms of quality of life. The bottom line, though, is that with this new approach, MDR-TB survival rates went from 50% to 89%. But the job isn't done. Our trial has shown that shorter, safer, and more effective treatment is possible. It's shown that when we work together with affected communities, trust local expertise, and put people at the center of our thinking, change can happen. For people with MDR-TB, it's given hope. The next step is getting this treatment to the people who need it most.
Ndadibana ne-MSF bekwiphulo lokokubana abantu mabaqale treatment eklinikini. Bebona into okokubana i-TB ininzi apha eKhayelitsha, and ke ngoku njengokubana abantu abane-drug resistant TB funeka be-admithwe esibhedlele, kwacaba isibhedlele sine-challenge. Abantu abaninzi bayasweleka belinde ibhedi.
Ukufumanisa kwam ukuba ndine-TB kwango-2013 kwakungekho lula, kunzima, akho counselling, akho ntoni, medication inzima, inenality every day.
You realize that this disease is for heroes.
Kuba mna ndaye ndathetha phandle mna nge-TB yam kwaye kwaba khona namanye ama-patient aye abanomdla nawo aqinisekise into okokubana azawudlulisa amabali wawo. Loo nto leyo yanceda ngoba kaloku ngoku abantu abanyangekayo apha e-TB baninzi.
Advocacy is really important, and advocacy really works to really get things done.
We need that link. The scientist, TB advocate. It's a community in between. We're working together for one goal, to say TB can be cured.
It's very important to work with the community, and that's why we are training also community ambassadors, TB leaders, people who are influential in the community. If they can identify symptoms of TB, talk with people, reduce the stigma around TB, that will be very instrumental in finding patients who have TB, who are in the community and who are not coming to the clinic.
For me, these workshops are very much important because they enlightened us as ambassadors as to what is happening in the TB world.
Baningi abantu abashonayo ngenxa yokungabi nalo ulwazi. Baningi abantu abadinga lolu lwazi le-TB.
Since we started attending such workshops, we have an idea of how can we work with people in the communities.
Sesiqalile sifundisa nge-TB, baningi abantu abazosizakala esizobathola kufanele balwazi le-TB.
As the traditional healers, we are the first point of reference to the people from our village. We are having a huge role to play to find the missing cases concerning TB.
MSF ungiphe isibindi, wanginikeza amaqhinga okwazi ukuthi ngibone umuntu onempawu ze-TB. Senginakho ukuthi umuntu mangabe efika fanele ngimrefer esibhedlela.
Imfazwe yokubana sinqobe i-TB isaqhubekeka.
I-TB sinqoba ngokuthi sisizane.
Igoal yethu i-1 yinto okubana masifumane i-treatment ebhetele. Inida abantu abaninzi abasebeyihambile le journey ukwenzela bazohlahla indlela bancedisa abantu.
Yeah, this is Captain speaking. We are proceeding to that point. We are 25 miles away.
This is not camp, this is prison. We not go back because if we go back, it's a big problem.
Stop bombing hospital, stop bombing health workers, stop bombing patients.
I'm psychologist, project coordinator,
community engagement coordinator.
I am a medical doctor. I work with Doctors Without Borders, which we also call MSF.
MSF is a humanitarian medical organization. But in my opinion, it's more than that.
MSF tries to get solutions from the people, the patients that they treat.
We are always the first responders. Sometimes we go to places where we are the only source of relief available. All the patient that comes to our facility is being treated free of charge. And we treat them equally, no matter where they come from.
We have the freedom to decide and to respond to the needs wherever they are, as we are not influenced by governments or politics.
We try to develop a work that will continue even when we leave the country.
MSF goes beyond where everyone else would go.
This is Doctors Without Borders. Patients.
मेरा नाम भक्ति चौहान है।
My name is Goodman Makanda.
मैंने बहुत गंभीर बीमारी का सामना किया है।
We survive one of the deadly diseases known to human,
जिसका नाम ड्रग रेजिस्टेंट ट्यूबरक्यूलोसिस है। I was so scared at that time. मैं बहुत डर गई थी कि ये बीमारी की गंभीरता मुझे पता थी और ट्रीटमेंट और उसके साइड इफ़ेक्ट्स भी मैं जानती थी। मैं बहुत डिप्रेशन में चली गई थी कि मैं इस बीमारी से ठीक होंगी या नहीं होंगी।
It's no better medication. You drink the medication and you vomit. You drink the medication and you vomit. You feel like you're committing a suicide, but you want to live.
Newer medicines are completely controlled by pharmaceutical corporations like Otsuka and J&J. And that basically means they decide who gets it and who doesn't. So I think between getting governments to admit that we have a public health emergency and then putting the right drugs there, it's an immense battle for treatment.
TB can be cured. I'm a living proof. I lose a lung, but I did make it.
अभी मेरी ट्रीटमेंट ख़त्म हुई है तो मुझे फ्यूचर प्लान मेरा ये है कि मैं MSc बायोटेक स्टूडेंट हूँ तो मुझे R&D में वर्क करना है और मैंने जो बीमारी से 2 साल जूझा है मुझे उस बीमारी को ख़त्म करने के लिए बेटर ट्रीटमेंट डायग्नोसिस उसके ऊपर काम करना है R&D में।
We need Bhakti and we need Goodman, we need South Africans and we need Indians and we need the Brazilians all in solidarity to fight against this disease and the rights that we need to fight against this disease.
I'm a TB patient activist.
Our patient voice counts. So does yours. Pay it forward.
When I was told that I'm having a drug-resistant TB, I was having a child who was 2 months old by then. So my heart was breaking because every day I was thinking that I'm gonna infect my child because I grew up knowing that TB is infectious, so you can infect the other person. My name is Busisiwe Beko. I'm a mother of 2 kids. I was diagnosed with drug-resistant TB, the TB that is not easy to treat with the normal TB drugs.
To be able to prevent someone from having to go through that suffering with drug-resistant TB is life-changing. Having drug-resistant TB has a huge impact on individuals. It causes a huge amount of suffering. It's a life-threatening condition. It has huge socioeconomic impacts. It can make it that someone is not able to work, which can mean that the whole family doesn't have an income. We can prevent people from getting drug-resistant TB and we can prevent that suffering by making sure that people at risk are offered preventative therapy. One of the major things we've tried to do with this program is to make this accessible at the household level. And I think that's really what's needed if we're serious about preventing TB and we're serious about preventative therapy.
This approach is really working for the community of Khayelitsha. When we do the home-based care, we're not just focusing on screening only. We make sure that we do counseling for them. We want to make sure that we care for them as a family, and then we continue to support them and go through the journey, the TB journey with them all the way until they finish the treatment.
Today we're lucky because we've got preventative therapy that people can use so that they can prevent getting TB. We always used to say prevention is better than cure. I do agree, as I know the journey of having drug-resistant TB. So I'm happy And I'm so over the moon to know that today there is a preventative therapy for also drug-resistant TB.
Each year, there are nearly 500,000 new cases of rifampicin and multidrug-resistant tuberculosis. We call this MDR-TB, which is defined as disease caused by a TB bacterium which is resistant to rifampicin, the most effective of the first-line antibiotics, with or without resistance to another important drug, isoniazid. In the last 5 years, only 31% of all these cases have been treated, and less than 15% have actually been cured. For some patients, MDR-TB treatment is long, up to 24 months. It includes thousands of pills, may require painful daily injections, and has frequent side effects. Moreover, guidelines on the treatment of MDR-TB rely on very low certainty of evidence.
In partnership with Médecins Sans Frontières, Partners in Health, Interactive Research and Development, the UNITAID-funded clinical trial was launched in 2017 to address the problem. The NTB clinical trial used the first anti-TB drugs developed in almost 50 years, bedaquiline and delamanid, to find shorter, tolerable, injection-free treatments for people affected by rifampin-resistant TB. The NTB clinical trial is a randomized, controlled, phase 3 trial that tested 5 new, all-oral, 9-month regimens compared to the local standard of care according to WHO guidelines. The NTB clinical trial enrolled 754 patients across 7 countries: Georgia, India, Kazakhstan, Lesotho, Pakistan, Peru, and South Africa. The NTB clinical trial picked up where the pharmaceutical industry had left off in its development of bedaquiline and delamanid. That's why the UNITAID funding and this partnership among non-governmental organizations was so important.
खांसी बहुत डेंजर आ रही थी, मतलब पूरा मेरा ये छाती वगैरह दर्द कर रहा था। सब स्पूटम वगैरह चेक किया तो उसमें पता चला कि ये एमडीआर निकला है करके। और क्या हुआ था सर, मेरी एक बहन है, वो ना टीबी की वजह से उसकी डेथ हो गई थी, मतलब 3-4 महीने पहले, और उसके बाद मुझे भी डिटेक्ट हुआ। उस वजह से घर वाले बहुत ज़्यादा डर गए थे, और मैं तो बहुत ज़्यादा डर गई थी कि ऐसा होता है तो मैं रहूँगी कि नहीं, मेरी बेटी का क्या होगा।
वो धीरे धीरे कमज़ोर कर देता है अंदर से, तो आपके ना बॉडी को बहुत इफेक्ट होता है। आप अगर एजुकेशन कर रहे हो, आप अगर जॉब कर रहे हो, तो आपको ये सब मैनेज नहीं कर पाओगे, क्योंकि इसमें टैबलेट्स के साइड इफेक्ट बहुत होते हैं। अगर आप बेडाक्विलिन और डेलामिनाइट लोगे और 2 साल का अगर प्रोसेस है, तो आपको वो आपका सब पीछे छूट जाएगा, आपकी लाइफ पीछे छूट जाएगी उसमें। और फिर हम यहाँ पे आए औंध में, पुणे में, उनकी टीम मिली, उन्होंने हमें गाइड किया, हमें बताया। स्टडी वो स्टार्ट करने वाले हैं कि उनके टैबलेट्स जो भी है बेडाक्विलिन और डेलामिनाइट, उनका वो स्टडी स्टार्ट करने वाले। अगर हमें स्टडी में अगर हम इंटरेस्ट लेते हैं या पार्टिसिपेट करते हैं, तो आने वाला टाइम बदलने के लिए।
6 years later, we're excited to share the NTB clinical trial results. They provide evidence for 4 all-oral shortened regimens for rifampin-resistant TB. 3 of them have robust evidence for nearly every patient, and 1 is an alternative for patients unable to receive other recommended treatments. The results offer patient-centered treatment options and empower clinicians to tailor drug regimens based on individual patient characteristics and conditions, thereby aligning treatment with patient preferences for a more personalized approach to care.
क्योंकि ये यूथ के लिए और आगे के लिए बहुत काम आएगा।
आज मुझे बहुत अच्छा लग रहा है कि मैं पूरी तरह ठीक हूँ, मुझे कोई बीमारी नहीं है, मैं पूरी तरह ठीक हूँ।
पर्सनल एक्सपीरियंस है, एज अ साइंस स्टूडेंट मैं साइंस से हूँ। ये बहुत बढ़िया है, गवर्नमेंट को इसके ऊपर सोचना चाहिए, इम्प्लीमेंटेशन के लिए बहुत ज़रूरी है।
Trial results provide new treatment options for all patients, adults, adolescents, children, and pregnant people. NTB shows excellent results in a population with severe disease and with a high prevalence of important comorbidities, such as diabetes and infection with HIV and viral hepatitis B and C. It also offers alternatives in case of drug intolerances or other contraindications, drug-drug interactions, drug resistance, or lack of drug availability.
Following these exciting findings, allowing additional safer and shorter treatments for MDR-TB, the next step is making sure people can actually access them. That means governments and providers need to be able to afford them. We'll continue to advocate for lower prices for rifampin-resistant TB treatment and diagnosis.
Today, we finally have 5
Can everybody
new
please
all-oral,
rejoin?
shorter,
Come back into the room.
patient-friendly MDR-TB regimens, which can be composed with a formulary
We have
of
our
only
next
8
session
drugs.
starting now. Okay, I'm going to actually start, even though we're 1/3 full, I think. So, I hope you all had a good lunch. The next session is called Ensuring TB Treatment and Care Across Diverse Settings. Could you please take your seats and stop talking? Thanks. This is going to be moderated by Lina Mengani, who is the Regional Head of the Access Campaign for MSF South Asia. And I'm going to... Sorry. Papers. This is the second panel discussion of the day, and the topic is ensuring TB treatment and care across diverse settings. In this session, the highlight will be on the key structural determinants of TB epidemiology, including global socioeconomic inequalities, high levels of population mobility, and rapid urbanization and population growth. These conditions give rise to unequal distributions of key social determinants of TB, including food insecurity, which we heard about first thing this morning, and malnutrition, poor housing and environmental conditions, and financial, geographic, and cultural barriers to healthcare access. This discussion will encompass TB care in conflict zones, in densely populated urban areas, and in difficult-to-reach populations due to geographical constraints. We have experts from the field with us today. Lina will moderate this session, and I hand it over to Lina to introduce the panelists and take this forward.
So good afternoon. I'm really happy to be here in Nepal, talking about something that all of us really care about. In any public health program, you always look at finding and reaching people who are most difficult to access or set in remote settings, but also being inclusive by including people who are affected by conflicts. And lastly, addressing issues which we are all seeing in our own South Asian settings, which is you have concentrated urban settings where you have to roll out both preventive and treatment for TB. So without delaying the session too much and hoping that everyone sort of settles down after lunch, and just reminding everyone of the ground rules, if you can not be chatting with the person next to you while the person is speaking. And number 2 is to keep your questions ready at the end of the session. And lastly, to avoid calls during the session. So these are the 3 things that I would really request all of you all to do. So I'm just going to move to the next section, which is densely populated urban areas, something that we are all familiar with in South Asia, right from Mumbai to Islamabad. And of course, across the region, we have many other places like that. So we have two very experienced speakers for this session. We've got Lorraine Rubello, and she's a nurse by training, but she's also a medical activity manager for our DRTB project in Mumbai. Welcome, Lorraine. But what I wanted to say about Lorraine is I've known her for, I think, decade and a half, maybe 2 decades. I've worked with HIV networks. She was there in the clinic. And it's lovely to see that journey of where we've actually provided treatment for not only HIV positive, but for drug-resistant tuberculosis. So we have a lot of memories of very long treatments to hopefully much better treatments and a brighter future for drug-resistant tuberculosis. So I'm going to invite Lorraine to the dais. And then we have Dr. Saifullah Khan. Lots of Khans in this session, I have to say. Not the Bollywood ones, of course. But we have Dr. Saifullah Khan. He's the Deputy Medco from MSF Islamabad. He couldn't make it all the way to Nepal, but he's online and he'll be joining us as well for the second presentation. And we have Dr. Lorraine's colleague as well, Dr. Khan from Mumbai as well, and he'll be supporting Lorraine's presentation based on his experience as well. So we have 3 resource people, 2 making presentations, and I open and give the floor to Lorraine.
Thank you. At the onset, let me thank the organizers, South Asia office, for inviting myself and my team, Dr. Khan and Namrata, who is our community health worker. This is our first time in Nepal, and we're very excited to be here. Our presentation is about managing drug-resistant tuberculosis in an urban slum setting. So as we all are aware that the prevalence of TB in urban cities is more as compared to rural areas. 54% of the world's population now resides in cities, and due to the rapid urbanization that we see in developing countries in these slum settings, in addition with the convergence of the determinants of TB, which we find in the poorest and the most marginalized sections of the populations, it is becoming a challenge to treat drug-resistant tuberculosis in an urban slum setting. My presentation is based in such a context from the city of dreams, as some of you all know it, Mumbai. So allow me to transport you all to our setting. Next slide, please. So our setting takes place, our story or our journey begins in M East Ward, which is located at the northeastern tip of the city of Mumbai. It is one of the 24 districts that Mumbai is divided into for ease of administrative purpose. It has an official census count of 8,60,433 population size, but this is the official census which you can see was last conducted in 2011. The unofficial census data from the health post and the dispensary stands at more than 11 lakh now. And all of this population is condensed in a square kilometer radius of 32.50 square kilometer area. 72% of the population resides in slums, and out of the 72.5 population, 50% of the population are migrants. It also has the lowest HDI, Human Development Index, in the city of Mumbai, and the highest infant mortality rates as per a report published by Tata Institute of Social Science. It has one peripheral hospital, which is famously known as the Shatabdi Hospital. This is for moving it ahead. Thank you. And also, it has 13 dispensaries, 21 polyclinics, and 15 primary healthcare centers functioning from the ward. The prevalence of TB in 2021 in Mumbai stood at 292 per 1 lakh population, and in M East Ward in 2022, that figure stood at 466 per 1 lakh population, making it a hotspot for TB transmission. It contributes nearly more than 3,000 new cases of TB are detected in this ward, which constitutes 10% of the burden of TB of Mumbai. Next slide. Okay, I forget that I have the remote control. Okay, so our strategy was to function. So our model of care was to operate from 2 sites. One was the MOH Collaborated Nodal DRTB Center, which was operational from Shatabdi Hospital's TB OPD. And the other is our standalone MSF independent private clinic, which focused more on providing care and treatment to patients who were failing their TB treatment and who had no recourse to newer drugs. So they had to be put on salvage regimens, so which is a carbapenem and new drug oral regimen. Also, our nodal DRTB center was more structured in providing DRTB consultations from the OPD, We also had a clinical mobile team, which was something very similar to the previous presenter, where a doctor, a nurse, and a counselor would visit the health post on fixed days to provide clinical consultations and do the contact tracing for patients who reported at outreach because of the distance, because the OPD is quite far from where the patients reside. And the third arm was conducting contact tracing, which is done by our community health workers, visiting the patient's home, screening the household contacts, and then referring them if there was anybody with symptoms of TB. And community engagement, which was also done by our community health workers at different levels, going and doing TB awareness in the dispensaries, at the health post, at the NGOs, at the CBOs, which are located within the ward. This is a snapshot of that is a schematic representation, and this is a true picture of the Shatabdi OPD. So we try to provide a one-stop service for our patients where all the services, be it clinical consultations, the counseling services, the nursing services, because our nurses also do the ECGs for patients. We also perform the sputum induction out here. So it is a one-stop shop service of care. A summary of data of our activities at both these sites. So as you can see at the MSF Independent Clinic, 685 patients so far have been treated, with 5% of the cohort being children below 10 years of age. 69% of the patients were treated with carbapenem-based regimens, out of which we have a successful outcome rate of 64%, which is in itself a big achievement because these are patients who, these are patients with very poor clinical prognosis. As I said earlier, that they have very limited or no treatment options left for them to define an effective treatment regimen. So the team puts in a lot of hard work to arrive at this. So it's robust clinical monitoring and psychosocial support that is provided by our teams. A total of 253 patients have been subjected to the BDQ DST, out of which 27% are BDQ resistant. At the MOH Collaborative Nodal DRTB Center, we have more than 80,000 samples processed for gene expert testing, which shows a detection rate of more than 20%. Total DRTB patients who received treatment were more than 7,000. We also have comorbidity management at our OPD. So you see the DM-DRTB percentage of patients having both DM and DRTB, diabetes and DRTB is at 12%. And as the very prominent speakers today morning, Dr. Bhargava, pointed out about malnutrition, and rightly so we see that in our cohort also there is 29% of the active cohort is currently malnourished. With 70% of them receiving therapeutic supplements from MSF. And the treatment outcomes stand at 79% for successful treatment outcomes and 21% for unsuccessful treatment outcomes. Our achievements in the diagnostic cascades is that we, for an urban slum setting, we had a very effective sample transport pathway where samples from the patient's houses, they came to the nearest health post or the dispensary or a private clinic, submitted their samples there. The logistic provider picked up the samples, brought them back to our Shatabdi Gene Expert lab. And within the next 24 hours, we had the result ready. We also had a dedicated biochemistry lab. So this was set up by MSF so that patients do not have to enter the Shatabdi hospital. Also in terms of infection control, which we very easily forget, because now we have a DRTB patient entering into the, a suspect entering, a confirmed case entering into the hospital probably for his, picking up his report or going for his lab test. So these measures helped us. Even the sputum induction is done in our TB OPD by our nurses. So for children and for even adults who find it very difficult to cough out a sample, we have the sputum induction procedure which is conducted by our nurses. For the gastric lavage, we send our patients to, because of infection control norms in our OPD, we send our patients to the MSF clinic for the gastric lavage procedure. And so does the Shatabdi Hospital Pediatric OPD also doesn't have the facility in-house, and they also refer the cases to our private MSF clinic. So in short, we realized that an effective sample transport pathway has, and the other processes has enabled us to decrease the turnaround time from diagnosis to treatment initiation. In the treatment cascade, of course, we tried as much as possible to provide decentralized patient-centered ambulatory care for our patients where the newer drugs, rollout of the newer drugs was concerned. We also have the all-oral regimens with concomitant use of bedaquiline and delamanid. And for the under 5 pediatric patients, because delamanid is not yet available in the program, we are referring to our MSF independent clinic where they can access this drug. Timely identification of treatment failure is another key component of care and management, where with the help of robust monitoring, clinical monitoring, we are able to see and identify early treatment failures and then provide them with the necessary regimens based on their DST patterns. Yes, this one I've covered, that we are providing carbapenem-based regimens for our patients on ambulatory basis for our failure cases. And the systematic comorbidity management is another key aspect of our clinical and monitoring measures, which has, we had for the HIV-DR TB component, we had a doctor from the ART center, which is located inside Shatabdi Hospital, coming to our TB OPD and was capacitated, was mentored by our doctors to do a clinical consultation for the patients who were HIV-DR TB co-infected. For the DM-DR TB management, we do the close monitoring of the HbA1c levels, which is done at baseline and every 3 months to see if the diabetes is under control or not. And we refer them either to their existing private physicians with whom they were already taking their treatment, or then the MOH facilities where they can get their diabetic medications. For the malnourished patients, SAM and MAM, our nurses are the ones who are doing the initial screening. And based on that, we also have an in-house nutrition who provides support to the DRTB OPD. Based on their status, we are giving them the RUTF supplements. And if they need to be hospitalized, then we are referring to the MOH facilities. Post-TB follow-up consultations are being done at our clinic at 6 and 12 months. And at the Shatabdi Hospital Nodal DRTB Center, we are doing it at 6 months post-completion of their treatment. In patient support, this is a very key component that helps our patients to stay adherent on this long, arduous treatment regime, which is already debilitating for patients to take because of the tremendous side effects that they experience to the drugs. So we have created tools such as the PHQ-9, which is the Patient Health Questionnaire 9, and the audit tool to identify patients early on, even before they can be put on cycloserine, which is a drug which is a part of the regimen and which can create symptoms of anxiety and depression. So if it is already identified at the baseline level, the physicians can either delay the introduction of the drug or start at small doses, decrease doses, and then scale it up till the patient can tolerate it well without these symptoms. We also have psychosocial assessment forms, which is filled by our social worker, our nurses, and this tool helps us to identify family issues and any other social issues at the onset, because we tend to miss these support system mechanisms, which are very important for patients who have to undergo this long treatment journey. So if they have good family support, we have seen in our practice that patients who did have a good family support are the ones who ended up completing their treatment successfully. TB health education was done at different levels to create awareness and to prevent stigma or to minimize stigma and discrimination. So this is being done by counselors and community health workers at both the facility as well as at the household level when they go to do the contact tracing screening. We also have targeted support group meetings with different themes as per the need of the populations. If it's children, then it's a different approach to organizing these support group meetings. If it's adolescents, their challenges and their needs are different. So we have to cater the support group meetings based on the different needs for different age groups. We also had a very powerful qualitative study, which was photo voice, and it's unique because it is an experience that the patients themselves took on. So they took pictures of what constituted stigma and discrimination for them, and then wrote a caption below that stating why that picture represented for them during the course of their journey stigma and discrimination, and how they tried to overcome that and stay adherent to their treatment.
Yeah, can I ask you to wrap it up, because there are two other...
we last on the last two slides. So in community engagement, we see that our community health workers already go around in dispensaries, at the hospital, at the NGOs and primary healthcare centers to do the community engagement activities with the focus on TB awareness. In operational research, we have approximately 40 publications done till date by MSF, and our technical experts, that is our technical reference doctors, are invited to provide their inputs on the standard of care TB document as well as the palliative care guidelines, which is a work in progress. The challenges that we have, and this is the second last slide. So it's migration, because how do you keep patients on their adherence to their treatment during 18 months if they have to migrate to their village during the farming season, and some of them don't try to come back. So this itself is a challenge. The high density of population, the poor unhygienic living conditions, stigma, infection control, and a very poor health-seeking behavior. These are all factors that impede their treatment adherence and then leads to very poor treatment outcomes. Bureaucratic delays, we know, in implementing changes at both the policy level and also at the implementation of operational levels, whether it is HR, adequate HR, whether it is drug stockouts or sufficient drugs available at all the levels, and also out-of-pocket expenditures which patients have to incur for different tests, and also when the drugs run short, they have to buy it from the local pharmacy, and some of them don't even do that, so there's a treatment interruption period. Inadequate in-hospitalization services. So for a population of 21 million, which is what is Mumbai's population, there is only one civic hospital, which is Shivri TB Hospital, and it's a 1,200 bedded hospital. And so if you see the prevalence of TB and then compare it to the population of Mumbai, it's totally insufficient. So you need more. And palliative care is not, while it is mentioned very briefly in the national guideline document, nothing is done operationally as yet. So for patients who even fail their salvage regimen, then they have to be put on palliative care. And there is nothing existing as of today for this area of DRTB management.
Thanks, Lorraine.
Can I do the last slide?
No, absolutely Please? Not. No. There are 2-3 speakers. I'll have to cut into the time.
Just recommendations.
No.
Okay, so I'll just run through half a minute.
No. There are other speakers. And they are from Afghanistan and Pakistan. Okay. So yeah, they are waiting online.
That's the last slide. So for those of you who want to catch it later, please do. Thank you for your patience and time.
Thanks, Lorraine. I hate cutting people short when they are doing their presentations passionately, but nevertheless. So I just wanted to say that we've got Dr. Saifullah Khan, Deputy Medco from Islamabad, waiting online. And then one of our speakers who was facing a challenge in linking to the meeting, the first speaker, in fact, Taiba Azizi, she's back. So we're going to do Saifullah first. Lovely to see you here again. And next we'll do Taiba. So please, Saif, it's all over to you.
Thank you very much. Good afternoon, everyone. I guess I'm supposed to share my screen.
Yes. Or do you want us to do the slides?
I can share as well.
Yes, you can share. You must be a co-host, so you can share. Absolutely.
Thank you. Just 1 minute. Yes, so thank you for the introduction. Just to repeat it, my name is Dr. Saifullah Khan. I am the Deputy Medical Coordinator with MSF OCP based in Pakistan. And one of our activities is related with ensuring DRTB treatment and care in the high density urban areas of Pakistan, specifically in the district of Gujranwala. So that is what we'll be presenting. But starting with a bit of national context, and then we will narrow it down to the more specific provincial and our site as well. So unfortunately, Pakistan, when it comes to DRTB, we have the 4th highest burden an estimated 16,000 cases in 2021, incidence rate of 6.8 per 100,000. 2.5% of these are new cases, while 4.9% have been already previously treated. And our estimate of the DRTB cases in 2021 amongst all the notified TB cases was 7,422. It's also important to mention that we have one of the highest rural to urban migration rate in South Asia, which contributes to an extension of the poor housing settlements, especially in the big cities. And an estimated more than 40% of our urban population is residing in so-called slums. There's an uneven distribution of the population as well, with around half of the country's population living in the Punjab province. And these figures that we're sharing, both for the national and the provincial context, are from our National TB Control Program. Going to the next slide now, coming to the Punjab context, the top 5 highest TB case notification districts were Lahore, Faisalabad, Multan, Gujranwala, and Rawalpindi. And these are also the districts with the highest population sizes. And some districts are still more affected than others, despite having a comparatively lower population. For example, the district of Mandi Bahauddin, which has a population of 1.7 million, but a high number of notified TB cases, which were 4,400 in 2021, resulting in an incidence rate of 258 per 100,000, which is the highest in Pakistan. Now, continuing with the national context in terms of the management of DRTB, there is a capacity, there is a program by the National TB Program called the Programmatic Management of Drug-Resistant TB, which addresses DRTB cases. Over the decade since 2012, the cases have increased from 888 to 3,878. In 2021 figures, there were 3,373 DRTB cases identified, which is 45% of the estimate of amongst all the notified TB cases. Around 85% were treated with the second-line TB medicines, and this indicates that only 18% of the estimated 16,000 DRTB cases appearing nationally per year are being treated. And again, as per our NTP's figures, their last cohort analysis is reporting that 72% of DRTB cases are successfully treated. Going to the next slide. Now, coming to our activity in the district of Gujranwala in Punjab, our main objective in collaboration with the MOH is to diagnose and treat DRTB cases through establishing a model which is replicable by the MOH in other sites as well. This is important, of course, for the sustainability too. Specific objectives are to increase case finding amongst the diagnosed TB patients through networking, through advocacy, through contact tracing of our registered patients, and also with a focus on patient-centered care. Now, to show you a brief or simple timeline of the activities, sorry. Yes, so we've completed 2 years of our implementation. They have stabilized after the initial phase. We have really worked on having a stronger relationship with the health and administrative authorities and other stakeholders, as the activity itself is housed within a greater infrastructure of an MOH district secondary care hospital, having other departments as well that we work with. So as we, during the implementation phase, we also realized that we are getting patients from outside the district of Gujranwala, because some of the adjoining districts do not have DRTB or PMDT sites. So we had to kind of expand our outreach. We needed to expand our outreach activities, or the decentralized care, at least in its initial stages, to start to accommodate those patients coming from other districts as well, by doing their home assessments and contact tracing as well. So it's already started in one of the adjoining districts, and based on the success of this, let's say, extension and our own capacity, we may extend it to other adjoining districts as well. Now, to show you geographically what the origin of our patient looks like. So in the middle, you can see, understandably, the biggest hotspot for us is the district of Gujranwala itself. And then we do get a smaller but significant number of cases from other adjoining districts as well. You can notice Gujarat, you can notice Mandi Baudin. To show you some of our key achievements, it's of course patient-centered care, in which we do, for example, have a committee which includes and gets opinions from patient representatives and treatment supporters as well. In terms of treatment success, it's important to mention BPAM introduction, which, as you may know, as per the WHO's consolidated guidelines on DRTB from 2022, it included 2 new recommendations. One was a 6-month regimen composed of bidalaquine, pretonomid, linezolid, and moxifloxacin in patients with resistance to fluoroquinolones, also known as pre-XDR TB. And then the second option being a 9-month regimen in patients with DRTB, but not having fluoroquinolone resistance. So this is one highlight we do wish to mention. Also related to case finding and diagnosis, there's a better collaboration, again, through our outreach team with the other gene expert sites and also with the other MOH staff. For example, during last year, we did awareness sessions with 778 MOH staff in the peripheral areas of the district, which included a large number of lady health workers, lady health supervisors, Tehsil TB assistants, other paramedical staff, medical doctors, and it enabled them to, in doing combined home visits with our outreach team, we believe it enabled them to follow their patients in a more efficient and regular way. And as a result of these sessions, these staff were able to refer 53 presumptive TB patients to the health centers for TB diagnostics. So outreach and MOH more or less, integration more or less already mentioned. In the graph below, you can see the variation we have experienced so far in the 2 years of the project in terms of the patient registration. There is a noticeable drop that comes every winter. To our understanding, it is related perhaps to the health-seeking behavior of the population, which in the more extremes of winter, they tend to stay more indoors and attribute any respiratory symptoms more to more common viral illnesses instead of reporting to the hospital. Going to the next slide. To show you some of our key indicators, total till last month, we had 294 cases registered. We also see a high degree of comorbidities, diabetes being the top, then hepatitis C. Malnutrition is in there as well, currently at 26% of the cohort. These are our underweight classified patients as per their BMI. All patients are screened, and then as per the results, there is a criteria for providing nutrition care, which depends on their age bracket, which depends on their weight for height Z score or the MUAC. Also important to mention that 56 cases so far have been treated with BPAM. Now the challenges are many, and since the time is almost over, I will just talk about case finding. As per the WHO's guidelines, with every case needing to be tested through gene expert, which is also endorsed by the MOH, but in practice, this is much less than what should be ideal. So this is something that we are working on through our networking and advocacy as well as outreach activities. Our priorities in 2024, again, the focus is on improving case finding, including collaborating and working with other stakeholders like the Punjab Anti-TB Association, like Mercy Corps, which really see a high number of cases coming in. And these are some of our main, let's say, referral sources as well. Also to improve on the pediatric TB and extrapulmonary case finding, because this is still a very small percentage, less than 5% of our cases. There's a need for a focus on non-sputum samples, a better collaboration with the Provincial TB program, which has been having its own administrative challenges, further build on the decentralization plan, replication of the decentralization or outreach extension to other adjoining districts, as I mentioned earlier as well. There is also an operational research protocol being looked by us internally, and then further to be discussed with the MOH for implementation, especially to see on how the shorter regimens are going, how the outcomes are. Also, better patient-centered approach, improve our comorbidity management. There is another MSF initiative around testing, avoiding, and curing TB in children, known as TACTIC. It's possible implementation as well. We are facing a common challenge of stigma as well, which even exists amongst medical staff. So this is something we have to counter too. Better utilization of the gene expert sites. And just to mention the bigger picture as well, there was recently a strategy released by the NTP for the next 2 years, as in from 2024 to 2026, which targets to treat successfully 35,000 DRTB cases over these next 3 years. So we are hoping that we'll be able to play a small but significant part in that as well. So thank you very much.
Thank you, Dr. Saif. And we could see some of the parallels running with the Mumbai project on some of your asks. So I've got both Lorraine and you online. So just a very quick break from the presentation as well to, allow a couple of questions for urban settings for the audience. So just 2 questions. Please keep it short, not multiple questions in the same response. That will be really appreciated. So the floor is open for 2 questions. Lorraine, would you like to address it from here, or would you like to sit there? So. Yeah, Dr. Devan, please go ahead.
Thank you so much. Yeah. So as we can see from almost all the presentation, most of the issues are so similar. But if we combine the setting of conflict as well as the densely populated urban population, 2 or 3 specific questions to Dr. Lorraine. For your carbapenem patients, how do you arrange the PICC line? Yeah, that's.
So initially when we started, we were sending to a private hospital for insertion of the PICC line, but it was too expensive. Yes, so then we collaborated last year onwards with JJ Hospital for a free insertion
That's
of PICC line.
That's a challenge because I see it. We get voluntary donors for the medicine, but how do I have a PICC line for
So we provide the consumables and the imipenem vial, and the insertion is done free of cost at JJ Hospital.
And some other points which I've noted for both of you, then can you add some telemedicine or echo models for getting the patients the specialized care? Because somewhere the challenge is the transport itself.
Yes.
And secondly, because I have seen drug-resistant TB patient, you are referring 27% to bedaquiline resistance. That is also being seen. I have been a thoracic surgeon for 3 decades. I have seen that if we can catch up cases slightly early, if they are localized, disease is localized, get them surgically resected also, in addition to the proper treatment. Because otherwise the situation of DRTB will keep on becoming more and more desperate, and we will keep on looking for newer and newer drugs. So please, and that third is about differentiated TB care, because that project is also being done by ICMR. If you can identify cases with malnutrition, HIV or severe comorbidities, and somehow arrange their admission, that will be a challenge, and that's an area which needs some focus. Thank you.
While we don't face challenges for the HIV admissions, because Shatabdi Hospital does admit our patients if there is a referral for admission, so far we've not faced challenges in IPD referral for HIV. Coming to your second question, which was, yeah.
So I'm going to, the second question that was, the first question that was addressed was on the telemedicine aspect. So if Saif, you have anything on decentralization, whether you all have used telemedicine, and of course, any of the other challenges that Dr. Devan mentioned, including the PICC line for patients who are very complex and need carbapenems.
Yes, not for outreach, but yeah, in the more centralized part of the activity at the PMDT itself, yes, the team has had access to telemedicine from the start. When it comes to specifically TB, DRTB or its complications, we have our own TB reference. So with them, the team is communicating with and discussing with directly. But for more, let's say if there is an associated comorbidity or a complication of that comorbidity needing specialized opinion, so for that they have been regularly using telemedicine.
Okay. Yeah.
Can you consider, because that's something which I feel is not sufficiently taken into account because surgery is not available. But probably by discussion and conversations we can make it available. For instance, for the Mumbai Center, I talked to surgeons there that they will do it free of cost and other things, some other areas.
Yeah.
Yes, Lorraine and Saifullah both.
Yeah. So Saif and Lorraine, on the surgery requirement, if you would want to comment, if any of your patients have needed a surgical intervention and whether it's available and how are you doing that? And also to Lorraine, who's much...
I could take the question first. Dr. Devan, thank you for that question. Yes, in the past we have referred patients, one to yourself, and at Mumbai level we have Dr. Banushali, who is a prominent cardiothoracic chest surgeon, whom we are currently referring cases to. But yes, the cost of surgery is very high when we do refer to a private setup. And it will be nice because Shivri TB Hospital, coincidentally, used to have lung surgeries 4 years ago, just before lockdown. But then they stopped, discontinued the surgical intervention component there. So it's on hold. And we don't see any signs of it again restarting at the moment. So that is another area because their surgeries were happening for free. So yes, we take up your suggestion, Dr. Devan, to have like a collaboration with government hospitals where cardiothoracic surgeons could conduct these surgeries free of cost for DRTB patients.
Yeah. So Saif, if you have a comment, otherwise we'll move to the second question.
I'll just quickly say that so far, luckily, there is no surgical case that we've experienced so far needing support. But however, for the more, let's say, medical complications, as I mentioned, we are luckily housed within a secondary care MOH hospital, which has other departments, including pulmonology, including internal medicine. So that is our referral source for support in such cases. Then for more specialized care, if there's a tertiary level care needed, then there is a facility in a city 2 or 3 hours away in Lahore where we may refer cases as well. And in case we need a local solution and it's a culture positive patient, and since the secondary care hospital does not have an isolation ward, we also temporarily for now have an agreement with the local private facility where we are able to refer these patients for any kind of medical complications.
Thank you so much. So there's a question on this table. I didn't see who it was. Yeah, go ahead.
I was just interested in data on TB, other TB cases in the families, and whether you do any family assessment at the time of this thing and follow up. So how many linked cases of DRTB do you get, and have you contemplated any kind of research, for example, prophylaxis and the levoflox, this thing? So what is the situation with family members?
Well, through our contact tracing activities, we have detected cases of family members being detected and put on treatment. But the yield, however, so far has been pretty low. So it stands at 3% for us, despite putting so much of effort, human resources to do the clinical contact tracing at household level. But the yield for the cases to be identified has been pretty low. And there are quite a lot of reasons, because one is the delayed, the post-health seeking behavior. Family members do not think that they are, they feel that they don't have symptoms at the moment, so they do not come. They delay this procedure completely, and so it takes time and a lot of effort by the community health workers to call them back and say, please come for your X-ray, and then to see the doctor who can then look at your X-ray and prescribe further gene expert testing or whatever testing is needed. And no prophylaxis, yes.
We're not providing prophylaxis, I think. So, Saif, over to you. Contact tracing for DRTB. There's a question whether what's the percentage and what's the linkage and what we are doing about it with prophylaxis.
Yes, a similar response. Our yield is on the lower side as well, around 5.2%. So the TB cases are referred to the PTP. The DRTB cases, of course, we enroll. And through contact tracing, the yield is on the lower side as well. And in terms of a prophylaxis, it is again, since the provincial TB control program is offering this facility, so the cases are referred to them as well. We are not doing it internally.
Okay, thank you. Okay, so the floor is opening for questions, but I'm just conscious someone is waiting. So do you want, is it related to this situation? Yeah, please, there's a gentleman behind you. Yeah, the gentleman behind you. Yeah. And then Dr.
Yeah, just wanted to share our context on that one, because even in DRTB contact tracing, we had some like 8% of DSTB contacts. So this prophylaxis for DRTB, we have to be a little bit cautious on this one, because all may not be able to produce samples, sputum samples. So clinically also we might, I mean, I don't know, the NTP in India, Pakistan are doing it or not based on clinical judgment. Are you initiating or treating DRTB or not? But that's an area, because not everyone is producing sputum anyway. So for now, maybe that's it. But I have something on conflict too. I'll discuss later.
In conflict, for the conflict thing. There's another presentation, and I'll keep you in mind and open it up. Dr. Sangeeta, anything burning that I can bring you on?
There's nothing burning over
okay.
here. I just wanted to ask, are these your patients under NTCC?
Yes.
All of them.
Yes, all of them are registered.
And the other question is regarding the children, how you were able to manage the drugs for less than 5 years? Because they're not improved under the program.
So, Dr. Sangeeta, some years ago, we did a project to open up compassionate use and looked at the legal framework. And we used personal use applications to the CDSCO where we got permission, and then patient by patient you have to import it, which is also the argument now that, you know, we have data coming in from different sources, not just from the drug companies, to allow the registration for below 10 kgs for Delaminid and below 5 kgs for bedaquiline.
That is now already approved. It's already approved by the DCGI that we can give Delaminid for all children, you know, more than 1 year of age and more than 10 kg, and bedaquiline more than 5 years and 15 kg.
Yeah.
So that is approved in the program.
So for those who don't fall within that, we do personal use importation, patient by patient. Yeah.
Okay, because in my case, being the National Center of Excellence, we have a DRTB, National DRTB Committee. So we call both the parents, they need to sign in front of the committee, and then we take it under compassionate use.
Absolutely. That's the same process.
Yeah, the same procedure.
We follow those procedures. Okay, so I'm going to go back. Sorry. Thank you very much, Lorraine, and thank you, Saif, if I can call you that, for your patience.
Thank you. Thank you very much.
Yes. So I'm going to go back to the first speaker, Taiba Azizi, and she's a doctor, as I just to remind you, in Afghanistan, in Kandahar, and we have her working in a conflict situation, conflict setting in South Asia. Over to you, Taiba, and I'm very happy to have you back. Yeah, and you have approximately 8 minutes to present, and maybe a couple of minutes for a question that's there from the audience. Yeah, go ahead.
Okay, hello everyone. This is Taiba Azizi. I'm speaking from Afghanistan. Medical doctor working an MSF DRTB project in Kandahar. So I'm going to present that in our project, what kind of facilities do we have and how to serve the patients in our area, which is a conflict area. So about the epidemiology, as we know that Afghanistan is a central country in Asia. We have about 41 million people in population. The estimated DRTB cases that we have, it's 5.4, and the new cases is 36, according to WHO report in 2021. And among those, 123 is pre-XDR cases, those patients who are resistant to fluoroquinolone. And also the MSF facility is the only facility which is supporting DRTB patients, especially in Kandahar, and also supporting the other neighbor provinces which is around Kandahar, like Zabul, Helmand, and Nimruz, Farah, and other provinces, and also Oruzgan. So this facility is run by MSF. So our model care is so patient central model of care. We support TB patients, MSF support the DRTB patients besides providing treatment for them. They also support psychosocial supports and things, financial, and also the family support, or we can say the social support. Currently, we are using different kind of regimen in our project, including shorter novel regimen, which are acceptable for our patients. The duration of the treatment varies among the cases. So the duration is 9 up to 12 months, and sometimes for individualized patients, we have among up to 18 months. We also have implemented the new recommended this regimen, BPAL and BPAL-M regimen, which is a better regimen for the DRTB patients. For exceptional cases, as I mentioned before, we also have individualized regimen. We have active contact tracing for some of our patients. Almost for all of our patients who are MDR-TB and are registered with us, we also do active contact tracing for them.
So Taiba, can you hear us? Is there a break?
Yes.
Yeah, if you put off your video, you'll probably get better connection for presentation. So
okay.
Yeah, perfect. Thanks. Go ahead. Taiba, we can hear you.
Yes, I can hear, just I cannot switch the slides. I guess there's some problem.
No, we can see your slides.
You can see it?
Yes, they're perfectly well displayed.
But in my own computer, it's not working.
No worries, Taiba. My suggestion is you complete your presentation as it is, because you know the subject so well. So we are listening. So we'll be very happy for you to complete the presentation, even if you can't change the slides.
Okay, wait a minute. I have to.
Taiba, do you want us to share the slides? That will be helpful for you. Okay. Yes, I think the slide just changed for a minute.
Sorry for delay. So TB treatment care across diverse settings. Afghanistan. Afghanistan is one of the countries who has a broken economy and also dysfunctional health system, which makes a situation for most of the TB cases in these settings. Besides this economy and dysfunctional health system, we also have other barriers as well. The special one is the lack of knowledge among the people and low knowledge level for them. That's why we have more cases. Estimated tuberculosis cases that is especially the resistant form. It makes 13,000 people in Afghanistan every year. And it has become a very challenge for our patients, because here we have insufficient infrastructure, and also the financial and length of treatment are the challenges that we do face in our setting. So especially the barriers that I have to talk about are the distance between communities. Most of the provinces and our patients, they are from far areas. So reaching to the health facilities is a big challenge for them to come and have treated and to treat them. So that's a big barrier and obstacles in our settings. The other barriers that we have in challenge, we have that's limited access to laboratory services, and most of the provinces there is no lab to diagnose TB. So most of the times patients are being treated in a different kind of antibiotics, which makes more resistance profile for our patients. And sometimes when we have patients, we can see that their lungs are already destroyed because there was no place so that they could go and have a proper and on-time diagnosis. The other problem in our setting, especially in Afghanistan, is that we have limited qualified health staff. So most of the health staffs are not much qualified to diagnose the patients and refer them on time to the TB centers. Instead, they are providing wrong medications for them or misdiagnosis, which makes more problem for the patients. The other problem is insecurity, as we know that most of the conflicts and insecurity makes a big challenge and both for the patients and health staff to go to health facilities, be there, and also for the patients to come to the hospital on time and take their treatment. The other barriers that we have is economical and cultural barriers. Most of the people here, they have no good economy profile and also have some cultural problems, so they cannot come to hospitals or go there. Like for women, it's they cannot come to hospitals at all alone, so they should always have a caretaker with themselves. That always make them the problem for them. And we also know that the knowledge of the people here are very less, so that's why most of the patients or the people who get to know that they have TB, instead of treating it, they try to hide it, so that patients don't want to share it with the medical staff or other things. Instead, they are hiding. That's why the situation is more and more. And the problem in Afghanistan also is the no access to DST. So for patients who have already received drugs, other drugs or TB drugs, we cannot know if they have some sensitivity in their resistance profile only by GeneXpert XTR, because for some other drugs like bedaquiline and others, we have to have a proper DST. Which is also a big issue for us. That's why we sometimes have to treat the patients for longer and longer time, because we don't know about the resistance profile of the patients. And mostly in the conflicts and insecurity that make an obstacle for access of healthcare is also a big challenge in Kandahar. For example, the challenge in conflicts and also during the war is that most of the time patients are not able to come to hospital on time. So they, of course, may have interruptions during their treatment. And also they get in-home treatment without proper observation of health staff, because it's a far area, and if there is insecurity, so they have to take medications by themselves at homes, so there will be no observation from health staff, and that's for sure. They may have poor adherence. We cannot understand if they have missed medications or not. And a problem of insecurity, the other area is that for such kind of conditions, we have to give medications for 2 months or 3 months. That makes also a problem for us, because for every DRTB patients, when they start treatment, we know we have to do monthly investigations and lab results for them, and should have good results and see the results. According to the results, then we can decide what kind of drug should we continue or stop. But because of insecurity, we give longer duration than when they come back. So of course we might have some side effects and other issues, because they are not stopped on the proper time because of the problems. And as we know that here it's situations of conflicts, so most of the problems, as I mentioned before, like economical, financial things, they all cause some psychosocial instability for the patients. And also during the war, they are already under pressure in these situations. So it's very difficult for them to convince, and it always make a challenge. So poor socioeconomic status of people is also a challenge for us. But for some of the problems, we have some solutions and approach in our settings that we can provide to our patients for better treatment and of them. So some approaches that I'm going to mention is that, as I mentioned before, some of the challenges is psychosocial problems. Here in our settings, we have good psychosocial support services. We have counselors who provide regular counseling for the patient. We have also integrated core of morbidities. We have morbidities in our patients. Most of them have some kidney or cardiovascular other problems. So besides providing TB medications, we also do cover their other morbidities as well, like treating or controlling their diabetes, hypertension, and other comorbidities that they have. The other thing, as we mentioned, that is a financial problem. Because it's far area to reach to health facilities, and it makes or takes lots of money from them. So MSF is also providing travel allowance for them. Beside that, we have good food package, so they can be supported nutrition and other areas, and for allowance for them. The better approaches that we are trying to do nowadays is implementing shorter regimen. As I mentioned, we have implemented BPAL and BPAL-M regimen, which is a shorter one, and it's easier for the patients to accept with lesser side effects. And patients are also trying to have a regimen with less side effects and shorter duration. Also, we do have providing a place where they can be with their family. The patients who cannot stay alone here, we ask them to bring their family so they can be all together. And this way we can solve some of their social or psychosocial problems by family support. We also have other approaches like contact tracing. For all our DRTB patients, we do have health promoters who take lists of the patients, and we ask them to come monthly so we can do contact tracing among those patients' family, and whoever is DRTB patients, then we can enroll them in our program as well. We have regular health promotions for our patients, so they can understand and how to increase their level of knowledge, so that they can have good preventions at homes, and to also deliver such kind of information to their family members and also to their relatives. The other approaches that care of pregnant patients. Among our patients who are pregnant and need antenatal and postnatal care, we are also, MSF is also providing such support so that the treatment is easier for them to take. We can also see some pictures of our health facility that our counselor is providing group sessions and individualized session for our patients. So for our current module of care outcomes, overall we have good success rate from 2016 up to 2024. The overall success rate of our treatment is 79%. In 2021, we started with the short oral course regimen, which is for 9 months, because it was shorter one and more acceptable for the patient. So the success rate, fortunately, was 90%. And now we have implemented BPAL and BPAL-M. So we have recently started it, we of course might have a better success rate for this regimen. So in such a model of care of patients in Afghanistan, patients have good outcomes, hopefully with the help of MSF and providing most of the support to the patients beside the treatment. We also can see the patients who has finished their treatment. We can see that how happy they are. we have so complicated patients that they are even disappointed and thinks their disease are not curable. So we can see how happy they are after treating them. And thank you so much.
Thanks.
Yes.
Yeah, no, great. Thanks. Yeah, so tremendous effort to join us online with all the challenges that you can face in Afghanistan with the internet connectivity. We had one question and then we go to the last speaker. So I think you wanted to raise a question about conflict settings, if I'm not mistaken. Yeah.
Not exactly in conflict, but cross-border migration related to conflict.
Okay, please go ahead.
If there is any experience they would like to share, the migration that happens off conflict, because we also have cross-border migration, but not of conflict, it's a regular cross-border migration between India and Nepal, and we have a lot of challenges in addressing cross-border migration in TB as such, but I'm sure with conflict that would be even in a greater way. So just a question to Nini and Taiba if they have anything to share on this.
Yeah. So, Nini, Taiba, any responses to this question? And I think we can also take it up in your session as well, in the last speaker's session as well. So, Taiba, you've already she's actually highlighted the challenges that she's faced in conflict. And I wonder if Nini is online still.
So in our setting, as we have know that sometimes conflicts makes migration, that we might have some loss of follow of patients because they might go to other cities and countries. We have some patients who have left here and went to other areas, so we had such kind of loss to follow-up patients. And currently, when some of the neighbors have we have more immigrants from the other countries, so of course the number of DRTB patients are increasing in our facility.
Yeah, so one more question. Well, we are running way over time, so I'm going to ask the organizers whether, we have the time to take another question.
It's just one. So what I wanted to ask all the presenters, except maybe Afghanistan, because they said they don't have DST, is what is the prevalence of bedaquiline resistance? Lorraine, I know you talked about the clinic, but in East Ward, where the general population is there, what is the prevalence?
So I'm just going to reserve that question for people to discuss among them, because the whole issue of bedaquiline resistance also comes from the context of how you use the drug post-2016 to now optimize regimens. Because if we don't cut it now, we can't have the last speaker, and I definitely want the speaker from Nepal to be part of this session. So I have to do this. I would like to invite Dr. Shrestha. He's the director, and very importantly, of the National TB Program, and he's waited a long time. His name is Dr. Prajwal Shrestha, and he was there in the morning as well with us, so I don't need to do a reintroduction. Yeah. No, there's a last speaker. Yes, please go ahead. Yeah, so Prajwal is going to speak on the difficult to reach populations, and of course all of us know who worked in the northeast of India or Nepal, we have some of the remotest communities living in South Asia in these areas. So please go ahead, Prajwal. When do you use this?
So, okay, good afternoon, everyone. So, in next 10 minutes, so I will give you a brief overview of how the geographical constraint or geographical terrain is imposing the challenges and hurdles to successful outcome of the National Tuberculosis Control Program in Nepal. So, I hope I will finish in time. So this is our, our vision, our target. Then we have the National Tuberculosis National Strategic Plan 2021 to 2026. So the first one is we have to decrease the incidence from 238, which was in 2012, 20 to 181 per 1 lakh population. Currently, it is 229 per 1 lakh population. So very minimal decrement. Then we have to decrease the mortality from 58 to 23 per 1 lakh population. We have to meet the NTB target as given by the SDG in 2035. Lots of talk has been done, already done by regarding this catastrophic cost bringing down to the zero. Currently, it is around 54% in our country, and eliminate TB by 2050. So this is the overall trend of notification and incidence in our country. So altogether, we have to diagnose 69 to 70,000 cases per year, but our national tuberculosis program is able to catch around 37,000 and plus patients each year. There is increment in the notification in post-COVID era by 18%, but still we have to catch hold of too many patients. Our notification gap is 45%. And to add on this, we had one national TB prevalence survey completed in 1920, and it showed that the estimated burden of tuberculosis was way higher, almost 1.5 times higher than the previously estimated burden in our country. So this is the this year data. We notified this 37,400 plus case of DSTB with notification gap of around 45%, and out of estimated more than 2,000 cases of DRTB patient, only 549 cases were notified from the National Tuberculosis Control Program. The TB is still the major leading cause of death in Nepal, with estimated 17,000 deaths per year, and almost half of the population is infected who have the latent infection. So let's see the distribution of the disease notification, and as you can see, the major notification comes from these three provinces. The number one is the Madhya Pradesh, one is the Bagmati Pradesh, and the Lumbini Pradesh. And almost 68% of the notification comes from these three provinces, and the rest, 32%, are from the rest of the 5 provinces. And these are the provinces where the difficult terrain like mountain area, high hill area, hilly region is very prevalent. So actually, whether the case load is low in this area, or it's just a notification, or it's just a missing case that is very high in this area, that we will look. So when we see the notification across the nation, so this down the line, or those districts which are connected with India, the plain area, they have the higher notification rate. And when you go up towards the northern side up to China, then in the high hill area and the Himalayas, the mountain area, no notification is progressively goes down. So this is the map of our country. We have total population of 29 million as per the national census of 2021, and our country can be broadly divided into 3. This red color is the mountain area, this yellow color is the hilly region, and this green coated area is the Tarai region, which constitutes 17% of the total land. It's a plain with the fertile land and the warm climate. The hill region constitutes 68% of the total land, a mix of valleys and mountains, and the most difficult one is the mountain region, where which constitutes the 15% of total land. It contains geographical remoteness, limited infrastructure, and vulnerable, and also it is more vulnerable to many natural disasters. So, but if you see the population distribution, more than half of the population is there in this Tarai region, only in the 70s. So population density goes up to 400 plus in the Tarai region, and in the hilly area, that is the population percentage is 40.21%, whereas only the 6.19% is there in the mountain region. So then let's see from where the notification are coming. So now if you see from the mountain region, which constitutes the 6% of the total population, 17% of the total land, over the past 5 years, only 3.39% is being notified from the mountain region. So altogether, if we combine hill and mountain, only 25% notification is coming from these two difficult area like high hill area and the mountain area. From the Tarai and the Kathmandu Valley, where we are now, it has got good notification there. So the mountain and the hill region altogether both contains 16 and 37 districts out of 77 districts in our country. So actually now let's look into whether actually the case load is low in the mountain and hill area, or it's just a notification, it's just a missing case that is very high in these two regions. So there comes the prevalence notification ratio, PN ratio, and you can see the PN ratio, which is the ratio of estimated prevalence by the notification rate, is high in hill and the mountain as compared to Kathmandu Valley and the Tarai region. So we are missing more cases in this hill area and the mountain area. So when we see the distribution of, this is our service outlets of the National Tuberculosis Control Program. We have altogether 786 designated microscopy centers. So most of them are centered around the hill, and more than 50% are in the hill. Very few are in the mountains. Gene expert XR, we have altogether 113 centers, 51 in the hill and the 9 in the mountain area. We have only three culture lab, three liquid culture lab in the nation. One is in the Tarai region and one is the hill region. Similarly, there's the distribution of the DOT center, mainly in the hill and this mountain region, and the DR center as well. So, but the one good thing about our National Tuberculosis Program is the treatment success rate. So you can see we are been able to maintain the high treatment success rate of more than 90%. The target given to is that the more than the 90%. So in the mountain region, we are been able to maintain the good treatment success rate in the mountain area above 90%, and similarly in the hill region, it went down to 88% during the COVID area, but overall it is in the acceptable range in both hill and the mountain region. So what are the current intervention that targets this, in this difficult geographical region through sub-recipient, TB-free initiative, active case finding, and community mobilization? So basically, we now more focusing on the sputum courier, effective sputum couriers service to hard-to-reach population, contact tracing, and household screening of TB among the malnourished children in this difficult terrain. This contact tracing, screening of the family members, screening of the presumptive DR-TB patient, and TB. And one of the successful modalities that is implemented from the SR is the referral from the pharmacy. The outcome is very good from when the patient gets referred from the pharmacy. And similarly, the TPT for children and active case finding camp, which is mainly conducted through the which is known as the TB-free Nepal initiative. So TB-free Nepal initiative is the highly politically committed this initiative taken by the government of Nepal. It was launched in 2021, almost 3 years back, and this the main principle is that from the center we cannot reach up to the the difficult terrain or the local level for the implementation of tuberculosis program. So it was initially launched at the 25 local level out of 753 local levels, and the results that we did preliminary assessment at the end of the 2 years was 2 years was that it was in these 25 palikas there were 36% increment in the notification rate of the patients, mainly implemented through the coming from the active case finding at the community level, and plus there was additional generation of the almost 117 crore of Nepalese rupees for the control of the TB program from the local level. So from this year, in last month only, we scale up this TB-free initiative from the Madhya Pradesh Tarai region. We have moved a bit towards include the hilly region and the high hill region also. And from last month only, we have expanded this program to additional 100 palikas. Now altogether, we are running this TB-free initiative program in 125 high burden palikas, local government out of 753, covering 66 out of 77 districts in our country. So, and the activities from Red Book to local government in this TB-free initiative implemented palikas are mainly the community DOTS program, TB modular training for their health worker, various activities of TB-free declaration campaign, active case finding, TB case finding in the risk group, contact tracing, and TB-related orientation to the community, and door-to-door tuberculosis screening program is something that they have to do in a regular basis, capacity building, and and at last biannual review of tuberculosis program cohort analysis of treatment results that they must do as per guided from the Red Book of the local government. So, but there are various gaps in the services in hard to reach population screen in all screening, diagnosis, and the treatment. The only 35% of presumptive TB reach for TB test in mountainous region. Healthcare facilities are having shortage of skilled health workers in hilly and the mountainous district. Lack of awareness and the knowledge. Lack of access to the treatment, especially in the dispersed habitats in the hills and the mountain. Very few TB diagnostic centers with limited capacity, as I highlighted, and challenges in treatment adherence due to the accessibility issue, especially in the hilly and the mountainous region. So, but we need some additional effort needed to cover this hard-to-reach population of the mountainous and the upper hill population. It mainly consists of courier service, the sputum collection and transportation network to all the districts for diagnosis of TB. Currently, it is being run in 42 districts as per the from the PR. Meaningful multi-sectoral involvement, community and the private healthcare engagement is very vital. And the expansion of the TB treatment in community through community or family-based. We have to move from the facility-based dot service to the community-based dot service in the form of community and the family dot service. Increase in active case finding events using portable digital X-ray, mobilizing the community people for screening and the referral of presumptive TB. Till date, majority of the active case finding in Nepal is being done on the symptom-based screening. So there is only single sub-recipient of the Global Fund that is currently using the routine digital X-ray. But as per the National Tuberculosis Program, from this year we are introducing this portable, ultra-portable digital X-ray for this active case finding at the community level. We need to educate and encourage local level to invest in the TB program, and the local level are being very proactive, as our experience says that in those 25 Palika, they proactively created and invested the additional fund on the top of the fund provided by the central government, and 117 crore of funds were being able to generate across the nation. That was the additional fund created from the local level. And we need to also establish a community-led monitoring and the evaluation system if we truly want to, to bring our National Tuberculosis Program up to the community level. So with this, I would like to conclude my presentation. Thank you.
So yeah, we are almost done with the session, but there's a question, I think, from Dr. Hemant and Dr. Ramesh. And since we are in Nepal, we have a Nepali speaker. I'm going to open the floor. We started 11 minutes late. We are 20 minutes over time. And I'm really sorry, but it seems, it's a rich session with a lot of presenters. We just allow 2 questions, just last 2 questions. Yeah? Yeah. Go right ahead, Hemant.
Yeah, hi, Dr. Pujwal. So we see there is big gap in notification rate, but then treatment success rate is very good. So what are the mechanisms that Nepal is implying for ensuring adherence to treatment?
So thank you for the question. So DOTS strategy was something which was very successful in Nepal, and it was globally appreciated from the appreciated program in Nepal. So basically, we cater our service through the DOTS only, which is directly observed treatment short course. So basically, we are the notification gap. In the other hand, you can see the notification gap is 45%. But when patient comes to our system, our success rate is more than the target that we have been given. So it says that we are being able to provide care through our DOTS strategy across the nation, but our main challenge is finding those 45% of missing cases, which I think is in the community because of lack of access to information, lack of access to health facility. And we have also the huge, almost open border that we share with the neighboring country, India. So there is an open border, there is lots of migration, mobile population that I think these two, and the majority of patients also, I think, in the private sectors, taking medicine from the private sector, which are not being enrolled from the National Tuberculosis Program.
Thank you so much for that.
Okay.
Dr. Ramesh, go ahead.
Thank you, Dr. Prozol. That was a nice presentation. And well, being from Nepal, I just have a couple of just thoughts passing my mind. It's more on the more planning side, a holistic sense of TB. So what I would like to bring up is, okay, fine, we are thinking of bringing down TB by 20 to 35, 0 cases, whatever. But when you talk of TB, it's not only TB treatment. It's not only catching TB. It's a holistic sense in that there are lots of HIV cases who would have TB. What's the program for that? Similarly, there are lots of, let's say, immunocompromised situation, like let's say Dr. Bhargav, Professor Bhargav, and both of them said earlier, the malnutrition, that causes TB. Where are we in those programs in order to also attack, or let's say tackle TB, rather than just talking about TB, bringing down TB? If we don't have all of that, then it could be a bit more challenging, I can see that. So I just want to bring this up, what our program is, how we are all going to, you know, kind of integrate these other programs in order to bring down TB. Yeah. And I don't want to talk too much, but even when Dr. Roshan Shrestha, the General Health Secretary, said, I don't think it's going to be possible, he already put he already underscored that. But that's not the point. The point is, it's great. WHO makes everybody work with their vision, with their endpoint. So it's great. It's great. We're doing something. It's great. We're moving forward. Well, at least if you throw a stone very high, it might come a little bit there, but at least you threw a stone. So I see that. So I just wanted to know what your holistic program for other the causes that other programs that cause TB as well.
So okay, thank you for the question. I would like to answer you in as brief as possible. So it's about cross-cutting areas. About it's not about thinking the vertically just TB, but we have a risk factor like malnutrition, we have smoking, we have diabetes mellitus, HIV, and the alcohol. These are the 5 key risk factors, 5 topmost risk factors for tuberculosis in Nepal. So I'm a pulmonologist also, and the tuberculosis is a disease which is there since decades and centuries among the humankind, and it is something that's spread through the respiratory droplets. So until and unless we have a effective vaccine or some very effective treatment, we will increase our notification by all these activities, but to bring that curve really down, to bend the curve, we need more, integrated, more holistic approach, like you said. So in the first session, in our keynote session, Dr. Bhargava, respected Professor Dr. Bhargava, beautifully explained how the nutrition, the nutrition is the new vaccine. So how important that the maintenance of the nutrition can play in the elimination of the tuberculosis. In Nepal, it's a fact that almost 35% of the children less than 5 years are stunted, and the prevalence of malnutrition is around 11 to 13%. So yes, and now we have, as per program, we have initiated an integrated program with the Family Welfare Division as per the screening of the TB symptoms in both the maternal and the child screening. As per the diabetes, which is almost it's the 3rd most risk factor for the tuberculosis, we have indoors guideline for the screening both diabetes in the tuberculosis patient and the tuberculosis in the diabetic patient. So that also we have initiated. And for smoking, that I want to highlight is that, so direct tax is taken from each cigarette that is being sold in the market. So, but the whole of that generated tax is given to the cancer care only in Nepal till now. So the voice that we are trying to raise is that since the smoking is very much prevalent, it is more prevalent than India, it is more prevalent than the Thailand in this region in Nepal. So now we are advocating that now. In one hand, we have a funding gap of 42%. So we need that, tax, that collected amount, at least some percentage to control of the tuberculosis program. So these are the few initiatives. So we have a fixed TB and HIV program. We have the fixed TB and HIV guidelines. So that is in place since long time. So yes, you are correctly right. But I think to bend the curve, to eliminate the disease, we need some intervention like maintenance of the nutrition or maybe the effective vaccine that 6 already in the phase 3 of the efficacy trial. Thank you. Thank you.
Thanks. Thanks, Dr. Shrestha. I'm going to end the session. And nutrition is the new vaccine, or nutrition is the vaccine, was an interesting response. I just have to say that with alcohol and tobacco, we also have to hold those companies responsible for what they are doing in our countries, you know, particularly tobacco. So I just can't resist the big push that tobacco has done. Yeah, we should, instead of, you know, using the tax money, we should find a way of holding them accountable for some of the health outcomes we have. So ending the session on that note, and thank you for the 30 minutes extra. And thank you to all the resource people who waited patiently online for their turn. Thank you so much.
So 30 minutes over, oh dear. Anyway, we'll manage, hopefully. The next session and the final session of today is fostering collaboration, exploring opportunities and challenges in public-private partnerships for TB elimination. And it's people who are present here in the room who will be discussing this and presenting. The moderator is Dr. Ravindra Kumar Devan, who's the principal consultant in the was the principal consultant of the National Institute of TB and Respiratory Disease in New Delhi, and Dr. Adil Tahir, who is from Mercy Corps International, and Rajesh Kumar Yadav, who joined us today from Pokhara, or yesterday. Thank you very much. I hand it over to you, Dr. Devan.
So, thank you so much, Helen. Thank you. And because we have had lots of time, so being a surgeon, I can be very precise, very limited, and so we can save some time and hopefully avoid the pain that is associated with the prolonging of the sessions. I'll try to do that. I am, as you mentioned, I am the principal consultant. I was the director earlier. And now, right now, my director is Dr. Sangeeta here. She is there. Okay. So why I wanted private practitioners to be also discussed. And both of these people who are sitting on the dais are very important who can address this question. Because we have seen in presentations in the morning that about 70% of the people do take private medical care despite our countries being very poor. And at least in India and almost entire South Asia, a very robust initial health structure having been already in place because we had British imperialism. So we have a system which works with all its challenges. So, but nevertheless, including poor patients, it's not that only middle class and rich people take the private Medicare. It is the poor people also take a lot of private medical care. And medical colleges also diagnose a number of pediatric tuberculosis, for instance, and the extrapulmonary tuberculosis. There are two challenges in which most of the approaches that we have developed do not work, which do require, and private medical care, especially corporate medical care, is very important. So how we have to develop strategies to incorporate them into the humanitarian care being provided by voluntary donors and the government institutions. That is one thing. With this challenge, I will invite my first speaker, Dr. Adil Tahir. He is working as Senior Program Manager for Mercy Corps International, Pakistan. Thank you. Yes, Dr. Tahir.
Good afternoon, everyone. Okay. Yes, I think we have talked this in the morning session, so I'll skip it, about the burden of tuberculosis in Pakistan. This is the achievement. As per the data of 2022, which is available in the Global TB report last year, Pakistan was able to diagnose 424,000 cases. Treatment coverage is 70% with a treatment success rate of 94%. Still, we have a gap of undetected cases which is 183,000. And the main reasons or the main missing cases include asymptomatic patients. These are the TB patients which do not have any obvious TB symptoms. The patients who are misdiagnosed because they are going to the doctors or certain informal healthcare providers who are not trained, and they are giving them antibiotics and other medications and just suppressing their symptoms. And unreported private sector treatments. So there is still a large number of private doctors who are working in the country, but they are not reporting cases to the national algorithm. These are the main reasons. Private sector involvement. Now I talk about Mercy Corps. Mercy Corps has started working in tuberculosis since 2004, and we have become the PER, principal recipient for Global Fund, in 2007 for their advocacy campaign. That grant ended in 2010, and then we initiated the process of public-private mix, which has expanded over the years. And you can see that we started with involvement of general practitioners in the country. So we select the districts and map the doctors there. The doctors who run their private clinics, we approach them, we offer them a partnership agreement. Those who agree, we take them on board, we train them on national guidelines, and give them free of cost medicines and diagnostic facilities. So this is our model, and it has been continuously working since then. In 2016 and 18, we have expanded it to involve large private hospitals as well, because we found that the clientage of these hospitals is different, and we need to take them on board. So we started taking private hospitals on board, and we started mobile screening camps. As I mentioned earlier, that we have decorated mobile vans equipped with digital X-ray machines and gene expert machines. Then we involve lady health workers or community health workers as well. As we saw the presentations that Mercy Corps has basically piloted this initiative, and we involve lady health workers who runs from door to door for basically for family planning services. We train them on screening of tuberculosis, and referral mechanism has been developed, and through them referral system is being developed, and treatment insurance is also being done. Then there is a specimen transportation model that we initiated, and I'll explain these in detail. Regarding the GC6 grant that has ended last year in December, we have seen massive expansion. This is the grant where we have expanded our network of doctors as well as hospitals, and our specimen transportation model. In the current GC7 grant that has started from January this year, we will again expand a bit, like increasing our general practitioner network to 17,000, and increasing our hospital network to around 600 hospitals, and we'll continue active case finding through 40 mobile vans, and specimen transportation in 119 districts. And there is a new intervention, which is TB HIV. We'll start in this grant, and we will screen all the registered TB patients for HIV in the clinics. We have almost 800 private laboratories on board. So I'll explain the model in the next, yes. The first intervention, which is the main intervention, and it will give around 80% of our cases, is involvement of general practitioners. These are family physicians as well as the specialists who run solo GP clinics. We involve them and offer them free of cost services for our patients, and we provide a nominal incentive, which is around $3 per patient to them, so they don't charge to our patients. So we cluster a group of 10 to 15 clinics and link them to a private laboratory. Again, we do not establish any health facilities. All these health facilities are already present in the district. We just take them on board through a partnership agreement. So doctors identify presumptive from their OPD. They refer them to the nearby laboratory that is designated. The patient goes there, submit their sputum samples. We have been doing a sputum smear microscopy over the years, but now we are replacing it with Gene Expert as a first-line test from this year on. So the patient go there and get himself tested, and get back the results and go to the doctor and then registered. With each cluster of doctors and the laboratory, we have a district field supervisor, and he is responsible for registration in that clinics and in that laboratory. So once the patient is registered, the district field supervisor call the patient and plan a visit to his or her home, conduct the visit, and then screen. Contact screening is done, and also TB preventive therapy is offered. With this intervention, we have also involved pharmacies because in Pakistan, over-the-counter sale of drugs is still not banned, and anyone can get antibiotics as well as anti-TB drugs from the market. So what we are doing is that we have trained pharmacists in certain type A pharmacies, which are the pharmacies that sells ATT. Any patient from the district or from the community who comes to the pharmacy with a prescription of TB drug, the pharmacists have an application in their mobile phone. They take the picture, upload that into their system, and then our field staff get the notification that this is the patient who got the prescription and it's not being prescribed from our doctor. So the patient as well as the doctor both are approached, and we try to take them on board. So in this way, we are trying to find the missing TB cases. Also in Pakistan, it's a practice that if someone has a cough or certain ailment, they try to go to the pharmacy instead of going to the doctor. So if any patient comes to the pharmacy for a cough more than 2 weeks, again, the pharmacist is trained enough to tell us that these are the patients who are having chronic cough. So our staff coordinate with them and convince them to get tested for tuberculosis. So this is also an intervention which is embedded in this GP model. Then there is enhanced case finding through private hospitals. More or less the same algorithm is being repeated. The difference is that these are the hospitals where at least 2 or 3 doctors are present, and some are very large private hospitals as well. So we perform the same services in these hospitals. Then active case finding through the mobile vans. We have talked about it in our previous session. We have currently 40 mobile vans, and these mobile vans run in clusters, and each mobile van conducts around 20 chest camps in a month. So altogether, we are conducting 800 chest camps in a month, and our average yield is around 3 patients per chest camp. So through this intervention, we are diagnosing around 2,000 cases in a month through these 40 mobile vans. And this intervention is being conducted in almost 100 districts of the country. Now, with this intervention, we have found that it's sometimes difficult for the mobile van to go into certain areas with limited access of roads. So we have procured portable X-ray machines. Now, 25 portable X-ray machines have been procured, and these will be run in 25 districts in small vans rather than big vans. So we can go to the peripheries where the access through these mobile van is difficult. Then specimen transportation. Again, we have talked about it briefly in our previous session, but I'll explain it again. This is a digitally innovative system. All you need to do is just download the application from Google Play Store, install into your mobile phone, and you will be registered as a rider in our system. Our field staff approach you, and they'll train you about the system. So the riders, these are the community people. They are not our staff. Once they're registered with our system, all they need is a motorcycle and a valid driver's license. We train them how to use our applications. So the health facilities where the sputum samples are being collected, the health facility staff generates a request through the application. The nearby rider gets that notification, goes to the health facility, scan the QR code, which is pasted on the sputum sample bottle. So nothing has to write in paper. They take the sample, transport it to the gene expert site, and again, QR code scanning is done, and the sample is being transported. All we can monitor this digitally through the dashboard and live in our head office in Islamabad. Once the gene expert in charge tests the sample, upload the result in the application, automatic SMS is generated that goes to the patient as well as to the doctor with the result that this patient is diagnosed for tuberculosis, and now you need to coordinate with it. So this system is being developed and is being run in almost 102 districts at the moment, and will expand in all the districts of our intervention. So these are the interventions that we are doing. Our main intervention is involvement of general practitioners, and then the other interventions. This is overall our implementation model. You can see, and it's represent a district. So in each district, our focus is community. We mobilize the community to interactive voice response calls. We have hired different vendors who generate IVR calls to the mobile phones and convince the patient and raise awareness about tuberculosis. So anyone with a cough of more than 2 weeks, he or she should be tested. That's our flagship message. Once the community is mobilized, then the community go to the large private hospital or to the GP clinics available to them. For the community members who do not have access, our mobile van goes to active case finding, and we screen them for tuberculosis. And all these are linked through our staff as well as to the specimen transportation model. So this is our model, which is replicated in all the districts. This is the contribution that Mercy Corps has been doing in the national case notification. So you can see that we started in 2018, our contribution was 22%, but now it has increased to 40%. So if 100 patients are diagnosed in the country, 40 cases almost are through Mercy Corps efforts. So our contribution in the national case notification is 39 to 40% now. I have just presented the data for the last grant. So you can see quarter-wise improvement in our cases. These are the all-form cases. So we started with just 22,000 cases, and now in each quarter we are diagnosing and registering almost 50,000 cases. Treatment success rate remains almost similar, around 93-94%. This is their community referral, and it is basically the chest cam intervention. As I explained earlier, you can see the progress in this intervention as well. Number of sputum samples that we have transported for expert. We just started with 750 samples in one quarter, and then now we ended up with 51,000 samples in a quarter. Almost daily yield is more than 1,200 samples in a day, and we are doing it. The turnaround time for the results is less than 48 hours. So within 48 hours, we get the results through this intervention. TB preventive therapy. Now this is another challenging intervention that we started in July 2021. Basically to offer TB preventive therapy to all the contacts of TB patients. As per the national guidelines, we need to do chest X-ray of all the contacts, and if the X-ray is clean and the patient, the contacts do not have any symptom, then we offer them the TB preventive therapy. So we started it, there were certain challenges, the guidelines were not available, the drugs were not available, but overcoming all the challenges, we were able to convince patients. Now we are seeing improvement in this TB preventive therapy. Most of the doctors who are working with us, they still are not convinced. So what we did is that we started roundtable meetings in the districts where we invite a pulmonologist and 10 to 12 GPs in that meeting. The pulmonologists talk to the doctors, convince them, answer their questions, and this way we are increasing our network of doctors who are convinced for providing TB preventive therapy. But linked to that is advocacy campaign for the patient and their families, which is still not very much active in this grant, but we are focusing on that and will hopefully find some funding for this. The main innovations, the innovation we are doing is digitalization of TB recording and reporting through DHIS2 intervention. Now all the field workers that we have on board, we have provided them tablets, so they just record the data of all the TB patients electronically. So slowly and gradually we are moving to a paperless environment where all the TB data is captured digitally into DHIS2, which is a national system and is being developed by University of Oslo for Pakistan, and we are enhancing it. Currently this system is in the pilot phase in 18 districts, and we are increasing its replication in other districts. Use of artificial intelligence in detection of hotspots. I think I've explained that in my previous session. So we use technology to identify the hotspots, and then we organize the chest cam in those hotspots. And the specimen transportation system, I have explained it already. Challenges, the main challenges is the stigma attached to the TB disease, and that's the main hindrance for TB preventive therapy. Still, the patients hide their disease, and if we offer them TB preventive therapy, they say that it will get themselves labeled as TB patient, because for preventive therapy we are offering isoniazid and rifampicin, and isoniazid is a well-known TB drug in Pakistan. So this is the main challenge that we are facing. Screening of HIV patient in TB, all the TB registered clinics. Again, it's a challenge because HIV is also a stigmatized disease. Even most of the doctors who are working with us, they are not convinced that they offer HIV testing for their patients. So that's a challenge, but we are developing and coordination and with them, and slowly we'll see the results. unregulated private sector. In Pakistan, the private sector is unregulated. Any doctor can prescribe any treatment and any medication and any test to the patient. So convincing them to follow the national guidelines, it's a challenge sometimes. Still, most of the doctors, they rely on chest x-rays rather than ordering sputum smear microscopy or gene expert testing. So that's a challenge that we are facing. But still, through our efforts and with the efforts of National TB Control Program, the government of Pakistan has approved the laws of mandatory TB case notification. So all the doctors who are working in the country, if they register a TB patient, they need to notify it. And through this Mandatory Case Notification Act, we are trying to regulate doctors into our systems. So that's it about my presentation, and thank you very much.
Thank you, Tahir. I think you have touched upon previous interventions. Number one, congratulations for a lot of success that you have achieved and very innovative technologies that you have used. Now, when you last mentioned that unregulated private sector, as a, maybe some of you know that I'm a thoracic surgeon, not a TB specialist, but when I started working in TB hospitals, one of the first things, one survey done just near our hospital showed that 80 different regimens were being used for treatment of TB by the doctors there. So that's a challenge, but we have to accept the reality that majority is being treated in private sector, and the private practitioner is not, his intention is also to treat the patient as best as possible. So the interventions like notifying all TB patients being a law, it is a law in India also, but of course its penal action is never implemented, it is only the encouraging action which is implemented. Similarly, from the pharmacist viewpoint, that whenever a pharmacist is selling an anti-tubercular drug, he has to notify. But there you see one of the challenges is how to familiarize these private doctors and pharmacists with the NTCC technology, and how to give them a number so that they can also enter in the NTCC register. Only then a unified supervision surveillance model can be developed. That is one of the challenges. And as Vaishali mentioned the model in the morning, PPSA, patient private sector, I don't know what that's a model, agencies have been identified, but that have also been identified only in 16 to 17 states in the country so far. If, for instance, in my own state of Delhi, there is no notified agency. And India being a country with various different state, provincial governments than the central government, sometimes even the political differences cause a problem in such an agency being identified. But she has demonstrated in Karnataka at least very good interventions through the PPSA agencies. So we have to develop those conversations with the private sector, I think, and they have to be further encouraged. And that is one of my questions. You see, another thing, many, for instance, in the last governing body meetings of my institute, a private doctor asked me, can we not be given the modular training? We still don't have modular training access to all the doctors who are treating TB, whether they are general practitioners or just physicians, so as the programmatic management. That training, and they are ready to take it. Only thing we have to develop innovative models so that they can be recipients of such a training. And maybe that's why I mentioned even an ECHO model when we join them online, maybe a better method rather than. So first of all, your comments about my suggestions, Dr. Tahir. And then I will open it to House also.
I think it's working. Regarding the online training
It's all right. Oh, okay. Sorry. Do it again. Okay.
Yes. Now it's on? Okay. So regarding the online training module, we have developed an online training module, and we have coordinated with Pakistan Medical and Dental Council, and there will be 5 credit hours awarded for any doctor who just registered it to that module and complete the training. It's a 7-day course and it's free of cost. So we try to do that, but to our surprise, most of the doctors, they still prefer in-person training rather than online training, and they say that it is more collaborative and they can ask questions. That is not very much successful. Still, some of the doctors do that. Yes, you are right regarding pharmacy intervention and other intervention. For treatment of, once the pharmacist notify a patient that this patient is been prescribed anti-TB drugs, our staff approaches the patient as well as to the doctors. And they try to convince them through the same law that I was mentioning, that this is the law, and we involve sometimes district health authorities as well. In Pakistan, there is district TB coordinator who is involved in our TB work, so we also involve them, and they convince the doctor that you need to notify. If still you are not ready to be part of our program, at least you should notify the patient to our program. Regarding the treatment regimen, I think we do not have this kind of problem, because in Pakistan, only fixed dose combination of tuberculosis medicine are available. So all the doctors, they know and they prescribe only that fixed dose combination, and it's a standard treatment for drug-sensitive TB. Yes, the diagnosis is an issue, because some of the doctors still diagnose on chest X-rays, on high ESR readings. Some of them rely on TB gold test. So that's a challenge to us, and sometimes it's very challenging, particularly for extrapulmonary tuberculosis and for childhood TB, because the child obviously cannot produce sputum. But we have recently started testing of stool specimen for children, and all our gene expert sites, we are doing this intervention, and our yield is around 6%. Still, it's almost an year that we have started this intervention, and we'll hopefully do some research as well as share our findings with that. So these are the few challenges, but slowly and gradually we are trying to mitigate those challenges and finding some convincing evidences to convince the doctors who are working with us. Thank you.
Now it's open to the floor also. Yes, Lauren. Yeah. Oh, sorry. Yeah, please go ahead, doctor.
Yeah, hello. Yes, thank you for the very comprehensive presentation. This is me, Sharan. I'm representing from Nepal, one of the sub-recipients for the Global Fund. It's very encouraging presentation using 40 digital mobile vans and detecting 2,000 TB cases every month. I would like to know how many participants do you need to screen to detect 2,000 TB cases per month? What is the capacity of that van to screen per day? I would like to learn from you. And I'm afraid that, do you have any planning beforehand? Because if we detect too many cases, there may be logistic challenges, how to manage drugs, anti-TB drugs. This is one area I would like to learn from you. And proportion of the types of TB, PBC and PCD cases among the diagnosed cases from the ACF camp. And for the confusing cases in the field, how do you manage to confirm for the confirmation of the diagnosis? Thank you. And what is the acceptance rate of the participant when you do active case finding in the community? You say tuberculosis. Many asymptomatic patients are there. So what is their acceptance rate of the treatment?
Okay, I think these are very good questions. So 40 mobile vans, how many patients that we screen on average in each chest camp? We screen almost 120 OPD. So our capacity is 200 X-rays in a day, but on average it's more than 100 patients, 100 to 120, and we find, as I mentioned, 2 or 3 patients per camp. So this is our average yield. Logistic challenge, we have been doing this intervention since 2016. So we anticipate the number of chest camps and the number of patients. So there are no challenges because we already forecast the number of patients that we'll find through this intervention. Proportion of cases, yes. Our proportion is that regarding pulmonary and extrapulmonary cases, 80% are mostly pulmonary cases and 20% are extrapulmonary. But in pulmonary cases, yes, we are struggling to increase the back positivity rate. Still, it's around 50% in the country. 50% of the patients are bacteriologically confirmed, while the 50% are clinically diagnosed. So that's the biggest challenge, and with the increase in the gene expert network that we are expecting from this year on, I think this has also been largely addressed. Then confusing cases, with each chest camp, we take a doctor, trained doctor with us in the chest camp. And the doctor, they are working with us for the last many years. Some of them are very trained. So they normally diagnose the TB patient. But for confusing cases, as I mentioned, that we are working with more than 1,000 specialists as well. We refer them to those specialists, and the same package is being offered. So the specialists also don't charge to these patients, and for those confusing patients, they address the issue. Thank you.
Okay, now I think lack of time, we have to ask the other second speaker to speak. Lauren, please discuss in T now. Thank you so much. Yes, Dr. Rajesh Yadav, who is working as a program coordinator for TB for Save the Children Nepal. Your presentation, Dr. Yadav.
Thank you. And good afternoon, everyone. And thank you so much for providing this opportunity to me. And I'm present here in the public-private mix approach in Nepal. And public-private mix approach program through implemented global fund, sub-recipient through organizations and the different all province and basically in the 6 metropolitan city and sub-metropolitan city. And tuberculosis is the high in the middle and low and middle income country, especially in the Southeast Asia region is the two-thirds of the tuberculosis loaded in the 8 countries, especially in the India, Pakistan, Philippines, China, and in Nepal, more than 40% TB cases is missing. Not diagnosis and not enrollment in the TB programs in the each years, according to National Tuberculosis Prevalence Survey 2018. And public-private partnership approach is a strategy initiatives that involve engaging private and public healthcare providers in the fight against tuberculosis using the international healthcare standards. And public-private partnerships play a significant role in tuberculosis control, significant contribution in the case detection, diagnosis, and treatment. Not for the diagnosis and treatment, but if the private sector strong and in the collaboration with the private sector in the TB programs, they can also increase the awareness program and reduce the stigma. So you all are the focus in the private sector engagement in the tuberculosis program. And the PPA strategy recognized that importance to engaging a wide range of the healthcare providers, including those in the private sectors, and to address the global burden of the TB effectively. PPA approach aims to create a synergy between public and private, delivering and the respective strengthening enhanced to overall TB control programs. So public and private systems should be strengthening, not for the implemented guidelines, but strictly follow the guidelines, private sectors also and governments also. And there's so many guidelines publish and implement, but not strictly implement in the real field in Nepal as well as other countries. And private sector and public-private partnership also included in the Sustainable Development Goal. Sustainable Development Goal is included one in the 17 goal number is strengthening the private sectors to also in the health sectors as well as in the other not for only the TB programs, also on other diseases and maternal and non-communicable disease also enhance. But in the private sectors is very important in the tuberculosis programs. And one of the major in the Nepal, basically in the hilly and mountain regions, people are the migrant in the urban area to rural area, but in the health facility are the allocated in the rural area, but till date in the urbanization is increasing day by day, and health has facilities are also allocated in the urban area, so very important to increase and the private sectors in the tuberculosis programs. Then you can be achieved in missing cases and the TB yearly diagnosis and treatments of the tuberculosis. And that one of the best intervention in the PPA in the Nepal and other, just like my colleagues, the Edil also experience here in the tuberculosis is one of the PPM approach is one of the best intervention in the tuberculosis programs. And opportunity of the public-private partnership, one of the best opportunity is the case detections. basically in the case detections, number of the TB, if the private sector engage in the tuberculosis programs, they enhance in the case detections and treatments, increase SS2 cares. In the private sectors, also SS in the community and in the basically in the urban area, and people are easily SS to go in the private sectors and got the service. So you are increasing the access to healthcare service is also one of the best opportunity of the public-private partnership. And diverse service and delivery channels in the private and public and private partnership approaches, including the not for the only of the private hospital, but also included in the private pharmacy, polyclinic and hospitals, and enhance the private doctors and expertise using the tuberculosis programs. So, so many expertise and utilized in the TB programs, then easily to strong the TB programs in the Nepal as well as worldwide. And enhance the surveillance and reporting system is also one of the best importance and opportunity in the tuberculosis programs. If basically in the private sectors, there are so many private sectors not notify the TB cases diagnosed in the government system, national tuberculosis programs. So if the enhance the private sectors, they are also strong in the reporting and surveillance systems. I have already told in the resource mobilizations, if the private sector are engaged in the tuberculosis programs, they can be utilized of the high expertise in the, so many expertise in the involved in the private service, private health facility, and doctor and paramedics provide the so many service in the private health facility. So if the private sectors and enhance in the tuberculosis programs, these expertise utilized in the tuberculosis control programs in Nepal as well as other country also. And holistic patient-centered care, one of the opportunity for the tuberculosis programs is the public-private partnership is a holistic approach to for the patient as well as in the health systems. Tuberculosis program also strengthening in the this opportunity. And I have already explained. And more than 80% of the doctors are involved in the private sectors. So you are enhance the private sectors in the tuberculosis programs, not for the government health facility, but also enhance private practitioners, private doctors, private and polyclinics, pharmacy. And basically in Nepal, in the pharmacy, in the PPM approaches, basically in the pharmacy is refer to the higher centers for the TB diagnosis. So many people are in highly presumptive TB cases are go to in the pharmacy. And in Nepal, there is no any policy to stop without any prescriptions. You got medicine, by medicines, cough syrup, example for the cough syrup, any antibiotics without any prescriptions of the doctors. So if the policy is strongly implemented, then easily to increase the case notification of the TB missing cases reduced in the TB program. And one of the research published in the Frontier and the pharmacy related research in the PPM approaches. This research is conducted in the Pokhara metropolitan city. And this research, major challenges facing to in the PPM approaches is in the side of the case detections. Major case detections. Why case detection is low in the private sector and overall in Nepal? And the major is in the private sector health facilities are inadequate knowledge on the tuberculosis programs, standard treatment protocols and diagnosis among the private health practitioners. So in the private practitioners are the very low in the using the standard treatment protocols in the national tuberculosis programs. Some private practitioners are using the old regimens. So they can be increased the one not for the decreasing the case notification, but also they can be facilitated enhancing the drug resistance So one of the major challenges facing. And in the private sector, so workload is a high for the basically in the pharmacy, polyclinics, 1 and 2 health worker assigned to overall work is done in the health facility. So these private health practitioners are not provide the proper counseling and educate time for the TB preventive screenings and counseling for the refers. So this is one of the, in the case detection part of the major challenges facing in the private sectors. And one of the next is the health systems in the poor engagement of the private sector in the government workshops. In the private sectors, I'm sure they all are here in this event, in the great event of the TB programs, but I've not seen in the any private practitioners and any private hospitals are involved in this room. So you are all are sharing the good coordination, but no some lacking of the coordination with the private sectors and government sectors and development sectors. So one of the major challenges facing to private practitioners are not involved in the any trainings and TB workshops. So they can be not notified and not enhancing the tuberculosis programs. And orientation of the TB programs is the one inadequate joint supervision and monitoring. In the government health facility and government health facility is also not adequate and proper supervision in the private sectors. So if the private sector increase in the supervision, joint supervision, both public and private practitioner supervision in the health facility, they can be private practitioner joint supervision in the government health facility go to in the private health facility and enhance the this is one of the major challenges facing the Nepal's till date. And so private practitioner and private health facility are not involved in the tuberculosis program. And the lack of the coordination and collaborations, this is also one of the major challenges. And private practitioner and private health facility are more focused in the money oriented. So they cannot be easily gain the public health programs like to TB programs and other just like the leprosy and basically in the TB programs. So these are the both way, not for the private in the government sector and private sector both joined in the lack of the coordination with the both side. And poor recording and reporting systems in the private sectors. In the private sector, so many patients are flow in the hospitals, but not recorded, not recorded. So one of the TB case notified, but not recorded in the health facility, not notify the NTPIMSC, National Tuberculosis Program systems. So these are also one of the facing of the challenges in the public-private partnerships. And the lack of implementation of the policy of the TB programs. Government endorsed the TB program policy and guidelines, but private practitioner, private health facility are not proper implemented this policy. These are the major challenges facing. And way forward and major recommendation for the public-private practitioner how to strengthening these interventions in Nepal as well as worldwide. More focus in the government stakeholder work together with the coordinations and stakeholder perform the monitoring and supervisions. And next is private practitioners should be involved in the training and orientation programs. All training and TB orientation programs, any TB workshops, these all events are jointly and coordinate with the private sectors involved in these programs. Then easily they can be honored to TB programs in the private sectors. And another is a presumptive, just in the private sector and the government sectors. Presumptive TB patients should be educate, counseling and proper time for providing the counseling to go to in the government health facility, because government health facility provide free of cost the diagnosis service and treatment service. These are the key recommendations. Thank you.
Thank you, Mr. Yadav. After having pointed out so many deficiencies on the part of the private sector, I may first counter that Dr. Ramesh Chokhani, a private practitioner in Nepal, has cared to join this meeting. And one of the objectives when we were planning this meeting was also that we should have a greater involvement of the private people also in this effort, because TB is a community effort. In India, for instance, our Prime Minister is very fond of using the word Jan Andolan, that community participation, and Prime Minister TB Mukt Bharat Abhiyan has been started. For those of you who are not from India may know that he has given a call for every able individual to join by becoming a Nikshay Mitra. That means he supports 1, 2, 10, 50 TB patients directly by providing money for their nutritional support every month. And the mechanism has been developed that the money reaches to them. And in our own institution, we distribute that food baskets every month in addition to the direct benefit transfer. So I actually started by an opposite promise, Mr. Yadav, that no, private practitioners are not only after money. They are also doctors. When they want to treat the patient, they also want to get the best result. Because that only improves their level of satisfaction as well as their monetary thing also increases. But for TB, they are willing. And earlier we started PPP model by giving some token incentive to the doctor if he follows the program. Now it has reached when we want a patient-centered approach in which there is a patient provider support agencies will be involving this so that patient has only a single window to deal with, his private doctor. And his sample will be taken from there, diagnosed, and proper treatment, counseling is done, counselor support is given, and all those things can be taken care of when another agency helps the interaction of the public system with the private system. Because we cannot wish away the reality that private sector is engaged and patients are somehow have a greater confidence. Majority of the patients have greater confidence in the private sector, and in addition, it is more accessible to them because they can't lose a 1 day's wage waiting in a long government hospital line, etc. So those are the issues. So what is important is to foster. Anyway, these are my thoughts. We are already running short of time, but nevertheless, 1 or 2 comments. Yes, Dr. Anurag.
Just I would like to highlight some issues that when we talk of public-private mix, first, there is a problem in the health system, public health system per se, because the general health services and the TB program do not work in complete alignment. The TB program depends on the general health system to deliver the services of case finding and treatment and supervision. So while we are engaging with the private sector, etc., we have to engage more with the general health services. In India, for example, there are many districts where the DTO cannot, have the system function in a particular way. So while we are talking of this, because the general health system is also covering other things, we are talking of TB, but what happens to infant mortality, maternal mortality, NCDs? Are we going to have PPM models for all of these? It's not possible, sustainable. So as a general rule, I think we need to do more within our public health system, more while we also engage. The second thing is the private sector is again a very heterogeneous entity, starting from an informal practitioner to a corporate hospital, which is very for profit. So we need to have a little nuanced thing of whom we are engaging with. There are faith-based organizations, there are not-for-profit who are clearly, who have different values. So I think there is a rule for that. And lastly, when we are talking of, successes, notifications is a definite success. Notifications have gone up. But as again, the overall quality of care or, the outcomes are not still available for majority of these. So it's a little task half done. So just pointing out that we need to look at our public health system more critically while also engaging with the private sector. Thank you.
Valuable and insightful and thoughtful comments, Professor Bhargav. And I think we have many other things coming to our mind. And it has been a wonderful session, but we are running out of time, and Helen is just nudging me again and again, so I call it a bye then. Thank you. I end this session. Thank you, Dr. Tahir. Thank you, Mr. Rajesh.
Okay, we are running behind, as you know, but we have a very honored guest here, Dr. Sangeeta Kaushal Mishra, who's the Director General, Department of Health Services in Nepal. And I think she will join us on the dais to give a vote of thanks. Thank you very much. And Dr. Prajwal as well, please.
Thank you, Helen.
First of all, thank you so much for inviting me here. I was supposed to be here in the morning during the opening session, but it is due to a conflicting schedule, I couldn't come in the morning, although it gave me a wonderful opportunity to listen to the 2 presentations. So that was really very good. So when I was listening, when Dr. Ravindran was saying that he's a chest surgeon, I need to tell you that I'm a gynecologist by training and a public health person. So the things which I may speak may not be very TB specific, but still I would like to try. So first of all, I would like to congratulate MSF and our NTCC for organizing such a beautiful program of TB Date 2024 in the beautiful city of Kathmandu. We all know that TB is a very deadly disease. And when we talk about a region, our region has suffered very disproportionately. We all know. I don't need to go into data. You know much more than me. But the most important thing which I have realized that when we talk about the global burden or when we talk about our regional burden, we're trying to learn from each other, but that learning has somehow that has been in silos. I was listening to Pakistan's and our own country's experience, how we are working on partnership. I still felt, when I was listening to these presentations, I just felt that somehow we are working on silos. We all have issues with the case notification. We all have issues with the MTR cases. We all have issues with the supply chains. So those are the common thing. But then what are the most important thing which we need to do together? Somehow I feel the first and foremost important thing is about the funding. I have been working in policy since last 2-3 years, and what I have realized when I look at the fundings, I have realized that the fundings has not been utilized the way it could have been. So we are not able to provide results. So most of the time, for most of the programs, either we say that we don't have enough funding, but then on the other hand, we never talk about how we are spending these fundings. So I think it's a good day to think about our investment. Were that investments okay? Or the way we invested or the way we spent, were they okay? So maybe like the first thing would be, from my suggestion, if I could, I think would be think about the impact of our activities which we did as a region together. Maybe some activities were more impactful, but then some activities are so and so that we need to leave now. So maybe the first thing is that. The other thing, again, when I talk about silos, I think we have not integrated or worked with other programs. I was looking at the agenda. I was very happy to see that the first thing was about nutritional supplementation and malnutrition. But have we done the programmatic collaboration with our malnutrition or nutritional program in our countries? I think for Nepal, we haven't yet. But yes, from this year, thanks to our new director, who is thinking about having an integrated approach between our nutritional division and National Tuberculosis Program. So maybe that would give you an idea, or maybe like we should integrate the program. Similarly, the other programs which can be of work, like is on the tobacco cessation programs and the other programs, maybe the Safer Initiative, which works for the alcohol control. So what I'm trying to speak here is we need to think about the intersections where TB is can be seen as an intersectoral area, because it is a very multi-sectoral approach. So that would be one important thing. Other thing is, we were talking about community, we are talking about community mobilization, we are doing community mobilization. But somehow I feel when we talk about going to rural areas, somehow we leave the urban slums behind. Somehow, that is my experience, that in high crowded cities, we are leaving all these people who actually have TB, and they are actually, we are leaving them behind. So when we are talking about case finding, it would be a good idea that if we think about this population. So that would be my other suggestion. Other thing is sample transfer. I'm very happy to listen to Pakistan experience that the way they have done the sample transport. But somehow we still need to think about sample transport more innovatively. Like, I don't know whether we have ever thought about using our postal services for sample transport or not. I'm not sure whether we have talked about using our college students for sample transport or not. I don't know. I'm just floating some of the ideas, which may be very absurd, but sometimes we can think something out of it. So that would be my third take on today's program. The fourth thing is stigma. Somehow we talk about stigma, but my experience or the way I see it is like stigma has not been dealt in a way it should have been. So sometimes we just have all these workshops, but at the community level, I think we need to do more on stigma reduction. So I think we have certain countries' experience, and the most important thing with the countries with the open borders like Nepal and India, we are having a very tough time because of this open border issues. Maybe the same thing would be in Bangladesh and Myanmar, I see, and many other countries may have similar issues. So how do we do this cross-border regulation, and how do we do the real-time data transfer between the countries? That can be one area which needs to be thought about. And the last but not the least, our ambitious goal by ending TB by 2035, eliminating by 2050, it's not very far. It looks very far, but the time flies, so we all need to think about more collaborative ways to actually end TB, to find more cases, and find more funding and mobilize all these funding mechanisms. So at the last, I would like to congratulate everyone for having this meaningful conversation. Let's start meaningful collaboration between the communities, between the countries, between the private sector. That needs collaboration. But for most important thing is advocacy. I think till now, TB has not been advocated the way it is. So let's start our advocacy, let's start our new tools of advocacy from today. And with this note, I will end my speech here, and I wish you a very good evening, and please enjoy our very beautiful city, Kathmandu. Thank you so much.
Thank you very much, Dr. Sangeeta. That was a very nice roundup of the talks this afternoon, especially. One thing is you all have a consent form in your bag, and please sign it and return it because it allows us to use your picture. If you don't want it to be used, then you should also say that. But please don't do it out of forgetfulness, because our team are very strict about having permission to use your image. The other thing I would say is Dr. Prajwal is going to make closing remarks now, and he's been waiting for some time to do that. And after that, I'm not coming back up here again, there's high tea outside. So please remain seated and silent for Dr. Prajwal.
So thank you everyone. So this goes without saying that this whole day was very, productive. We had a very productive and thought-provoking technical session we had since morning. So the major highlight of today's session was mainly in the preventive aspect of the tuberculosis. The keynote address by Dr. Anurag Bhargava and Dr. Madhavi Bhargava. We have read this article, we have heard about this study in various forums, but today it was more explanatory, and we understood every details of this beautifully conducted study. And yes, the nutrition is the vaccine for tuberculosis as per now. 39% efficacy in all form of tuberculosis and 48% in reduction in the this bacteriology confirmed tuberculosis, and 35% reduction in deaths. So that was very impressive figures. And we all talk about the nutrition, malnutrition, the association of the nutritional status with the TB. But as Dr. Bhargava rightly pointed, we only see, but we not record it, we do not report it. So how to go about it? So one is about the integration of the tuberculosis program with the other program, like the nutrition program of the country, like the just as the respected DG ma'am has highlighted. And another is that Dr. Bhargava told that assess, address, and give access. So that was very, so I have made a note of this, sir. Thank you. That was very thought-provoking session we had in this, and with this preventive aspect, then we had a very fruitful discussion on the, the development of the vaccine. We have now 16 vaccine in the pipeline, and the 6th vaccine has already entered the phase 3 efficacy trials in the various countries. So in effort to eliminate TB by 2050, we need some very effective vaccine, and I can sense that in future we will have, definitely we will have one effective vaccine in the pipe in the program. And then about the vaccination, then we also heard about the experiences of the BCG revaccination, that the 45% efficacy in preventive infection in the South African population. Then also we heard about the challenges of implementing this BCG vaccination campaign or study in India that we heard from the our colleagues from the Chennai. So beside that, we had a very fruitful session on the how the we already talk about the right utilization of the various fund for the tuberculosis control program. So how the fund trickles from the donors to the beneficiary. So we had a various countries sharing their experiences on how they are utilizing the grant. So then after that, in post-lunch session, we had a very long session on ensuring TB treatment and care across diverse settings, including the conflict areas shared by the Afghanistan and the Myanmar, urban slums in the densely populated area from the Mumbai and the Pakistan. We heard their experiences, and from Nepal, myself gave you a brief overview of how the difficult geographical constraints are imposing the challenge to the National Tuberculosis Control Program. And at the end, we had the last session on the about the collaboration with the public-private with the private sector also. So lots of things were discussed about the lesser number of notification, deviation from the standard guideline in the private sector. So as per the Nepal, we have 28.8% of portion of the notification coming from the private sector, but we have one study that showed that the 68% of the presumptive patient, their first contact point is a private health sector. So there is gap in public-private partnership also. So in all, so I would like to thank the advisory committee of this, MSF TB Day celebration. So I'm also a part of that committee. We had a series of virtual meetings since last 3 months. I think so we all did a wonderful job. We had a good participation, actually more than expected. We are expecting around 80 plus, but 100 plus were at the in the hall, and 250 plus also in the online. So I take it as a grand success of the program. So at the end, I would like to thank especially the respected Chief Health Secretary Dr. Roshan Pokhrel for his taking out his time in opening session, giving his remarks, and respected Director General Ma'am Dr. Sangeeta Kaushal Mishra for taking her time out of busy schedule to give her very constructive and impressive closing remarks in the today TB Day celebration 2024. So thank you all the participants for you have spent a whole day for we had such a great interactions, lots of queries, and the questions were raised from the floor, and all of them were addressed beautifully from all the speakers. Thank you to all the advisory committee of the advisory committee, including Dr. Helen, Dr. Homa, and also the technical support team, except for a few glitches, but that was out of their control. So beside that, everything was very smooth. So thank you. So we have come to an end of the today's special event in Kathmandu, Nepal. But as a program director, I take this as a beginning of, very constructive, meaningful collaboration with MSF and National Tuberculosis Program of Nepal in days to come. Okay, thank you. Thank you so much.